Stage.
भैया बैक स्टेज भैया पानी बैक स्टेज भैया पानी की बोतल दे दो भैया A very good morning, Dr. Anupam, the organizing secretary of CynoDent, and many thanks for having me here. Greetings from the faculty of dentistry, Jamia Millia Islamia New Delhi. Today I will be speaking on role of total joint replacement, that is TJR, in temporomandibular joint ankylosis. What is ankylosis? Ankylosis basically is a Greek term which is defined as bony or fibrous adhesions of anatomical joint components accompanied by limitations in the mouth opening, causing difficulties in mastication, speaking, and oral hygiene, as well as which inadvertently influence the mandibular growth as well. Now, if you classify ankylosis, it has to be depending on the sites involved. Like if both the joints are involved, it is classified as bilateral ankylosis. If one side is involved, it is classified as unilateral ankylosis. Sometimes the entire joint will be involved, that is complete ankylosis. Sometimes only a partial component of joint is involved, that is partial ankylosis. Sometimes you can have a full bony adhesion, that is a bony ankylosis, and sometimes the fibrous adhesions. One of the classifications which we follow, which we all Max 5 surgeons follow, was given by Sony in the year 1986, and he divided ankylosis in type 1, type 2, type 3, and type 4 categories. The most common etiology of ankylosis is due to trauma. Now, please remember this: if you have an injury over the chin, specifically in the growing age, or direct injury to the mandibular condylar process or to the glenoid fossa, which can lead to the condylar fracture and the glenoid fossa fracture, and this can finally result into an ankylosis. Other causes are infections of the ear, the parotid gland, the tonsils. Of course, osteomyelitis of the glenoid fossa and the mandibular condylar are little rare causes, but they are also reported. Few systemic diseases such as rheumatoid arthritis and ankylosing spondylitis are also given the cause of ankylosis. And there are few rare causes such as like one reported by after a bimaxillary surgery by Wright et al. Now the ankylosis, now see these patients. We have wide variety of patients, right from aging from 9-year-old boy to a 45-year-old male patient. Not only they have functional problems, they also have psychosocial problems. They would also have aesthetic problems. They would also have airway problems. And trust me, patient with a bilateral ankylosis, patient who is having a bilateral ankylosis, would also have obstructive sleep apnea, OSA. And that can actually deter the quality of life. The patient will also, like, over and above a physical problem, the patient will also have a psychological problem. Now coming to the management options, the different management options for ankylosis will depend at the time of occurrence. Now there are 4 distinct groups or affected patients which may present, which may require different or specific treatment protocol. We may have patients with dentofacial deformities who are growing in the growing age, and we may have patients in the growing age without dentofacial deformity. Then we have adult patients with dentofacial deformities, and then again adult patients without dentofacial deformities. Now this young girl has ankylosis, but the dentofacial deformity is not much prominent as compared to this boy who is having a significant mandibular or a significant occlusal cant. The cant is tilted to the left actually. So depending on what site involved, the stage involved, depending on what time the patient got an injury, Was it before the developing age, during the developing age, or after the development? The symptoms and the clinical features might differ. And this slide is showing an adult patient, with no significant facial deformity. All these four groups may require individual treatment protocol going to the specific character and different clinical manifestations. For example, the girl which I showed to you, young girl, she will simple interpositional arthroplasty will take care of her. This is a standard Popovich incision which we generally take for our ankylosis patient, and we create a gap once we are into the temporomandibular joint, so that the bony mass is removed. The gap is approximately around 1.5 to 2 centimeters, and we try to interpose something because there can be lots of heterotrophic bone formation afterwards. Here in this case, we used a temporalis muscle. The temporalis muscle was actually swung into the condyle component, and this was restored. So this is how we do a temporalis interposition arthroplasty, where we swing the temporalis muscle within this gap which we have created, and make sure that the gap there's no heterotrophic bone formation, and there is the mouth opening and the function is being maintained for years. And this is she post-operatively 1 year and with a good mouth opening. Now the other option with TM joint ankylosis is using a rib graft. We use or we interpose, we harvest a costochondral graft from the third, fourth, or the fifth rib, and we transplant it to the gap which we have created. We also call it as a growth center transplant. Now this picture I have taken from an article by Professor S.M. Balaji. Now this shows how a graft has been harvested, a rib graft, and then how the graft has been interposed in the condyle defect once we do a gap arthroplasty. But one problem with this technique is we cannot determine the amount of growth. There can be sometimes overcorrection, like the rib which we have interposed might overgrow, and one side can actually look different from the other side. Of course, there is secondary surgical site deformity also, and the surgical time is also increased. So today I am here to talk on total joint replacement. So the logic is why total joint replacement for TN and ankylosis. See, total joint replacement has been used by orthopedic surgeons for very successfully in the last 30-35 years. Suppose patients who are having degenerative joint diseases of the hip, of the knee, the TM joint is just like any other joint, and there's ample of evidence. The success of annuloplastic replacement over the last 25 years to justify its routine use for ankylosis, reconstruction, and rehabilitation, while preventing recurrence and restoring facial form. Coming to a little historical perspective about total joint replacement. In 1965, Christensen was the first person who developed a condyle head. The head was developed by PMMA or a polymethyl acrylate, and whereas the ramal component of the joint was by metal, white alien. In the 90s, this was developed, this was changed, and the condylar head was changed into a metallic one, and it had unfavorable outcomes. In 2005 onwards, we started to use an ultra high molecular weight polyethylene, which formed the glenoid fossa, and the ramal component was again made by a metallar rod. The question comes: the TM joint replacement or total joint replacement, should it be done in one stage or two stages? It can be done in one, it can be done in two. In one stage, definitely it is always advantageous because number of surgeries or surgical procedure is reduced, anesthetic risk is also reduced, and so is the hospital admission. And it is actually also economical to the patient. In two stage we can confirm the mouth opening. The patient is not developing any heterotrophic bone formation. And post-surgical orthodontics can also be planned and can be clubbed with the concomitant orthodontic surgery. But there is no evidence in the literature to suggest that TM joint total joint replacement has superior result. The two stage has superior result. Now this is how a joint, your TMJ, looks like, and the question comes: should the joint which we are planning to replace Should it be customized or should it be stock? Now the reply is, suppose I'm going to buy, I'm going to a mall or a shop to buy my T-shirt or a jacket. If I buy directly one of my coat, the fit may not be that great, right? If I go to a tailor and get my sizes done, and then exactly the fit would be exactly accurate. The same logic applies here for the cave joint as well. So in a customized joint, we require more planning, we require more time. Okay, it might not be a ready-made one key. You go to a shop and just pay money and just buy it. It may not be like that. But the ease of intraoperative surgery, there's reduced intraoperative time, and the joint is more precise fit. Whereas a stock joint or a ready-made joint, which are available, are there, but this will require more intraoperative manipulation and planning. Now, there are some certain pre-requirements if you are planning to do a total joint replacement. The first and foremost is a CT or a CBCT images with 1 millimeter slice distance. What we do is we superimpose an FX plate or the Frankfurt horizontal plate onto the joint, which will actually plan our cuts. And the same thing is transported by the CT diagram images. The Glenard fossa is designed, the drill holes are designed, and the ramal component. And one thing to remember here is that the holes which we are going to place onto the mandibular ramus should be a little away from the lingula or the inferior alveolar canal. Now, this is how I was planning. I was telling you just before that how the Frankfurt horizontal plane is mapped onto the skull like this, onto my CT images, and this is how the cut designs are managed, the superior cut as well as the inferior cut. Once we have the design of the joint, there are markings on the joint which will suggest me what should be the depth of my drill holes. Okay, just to make sure that I'm not drilling into the inferior alveolar canal or into the lingula. And this is how my final joint looks. This is the customized joint I'm talking about. So coming to our personal experience, that is the Jamia experience, I call it. Before we do a joint surgery, there is some pre-operative preparation for the patient. We start with the IV dose of an antibiotics night before and immediately before the surgery. Chlorhexidine and betadine mouthwash has to be started prior. The patient needs to keep his or her oral cavity very clean many days before this thing, because our incision would be extending into the temple or into the temporal area in the hairy part. So make sure that this area is clean. Do lots of shampoo. The patient should clean the hair pre-operatively, at least 3-4 days back regularly, and then we meticulously prepare oral cavity via betadine. Now, starting with my case, this was one lady who was operated thrice before, once by a plastic surgeon and twice by general surgeons. It was referred to us at my OPD in my hospital. This was the CT scan, which showed a huge bony chunk on the right side mandibular ramus. This was definitely a Sony class 4 ankylosis. And then, just as I showed you those images, those CT scan images, we made a stereolithographic model, which is here, and we planned the bony cuts as we designed the osteotomy cuts as well as our prosthesis. This is our incision. Now, for the difference between the incision for a regular interpositional arthroplasty and a total joint replacement is, in a total joint replacement, we would additionally require a submandibular incision because we need to put and fix the ramal component also. So an additional submandibular incision is also required once we are inserting the ramal component. This is how it looks after we have created the gap. We remove the ankylotic mass after the gap arthroplasty, and my fossa is ready here to put the fossa. And this is that ultra high molecular weight polyethylene fossa which is seen on the screen here. This is fixed as posteriorly as possible, and this is my submandibular incision down here. So this can be used to fix the ramal component. Yeah, I have a small video here. Okay.
So we have successfully done on TGI replacement of the right temporal mandible. Thank you.
So this is how the ramus move once we have fixed the ramus or the ramal component to the mandibular portion.
And the go and interpose after the interposition will also help to try not to extrude that.
So I was just showing this video just to make sure. See, we need some covering over the fossa, right? Specifically the fossa component. So here we are using the temporalis muscle. We are rotating it and we are covering the fossa, which we have just replaced with the ultra high molecular weight polyethylene. We are covering it with the temporalis muscle. This would actually prevent the externalization of the joint. This is my intraoperative mouth opening, which is adequate more than 45 millimeters. If it is less than 40 millimeters, please make sure that you do a coronoid removal as well. It can be planned by the same incision. And in case if it is still less, then go for the contralateral coronoid process. Remove it intraorally. Once you have done a successful coronoidectomy, the mouth opening will automatically pop out to 45 millimeters. This is the panoramic view post surgery. This lady is happy, and the mouth opening is more than 35 millimeters. And good with function and everything. And again, 2 years post-operative follow-up, patient is perfectly fine. Now, this is my second case here. Again, an adult individual operated at least thrice for ankylosis and showing a big ankylotic chunk in the left side mandibular ramus. This is how we plan an incision, a standard Popovich incision, extending into the temporal area. We do the exposure of the bony component, the ankylotic mass is exposed carefully. We should be careful that the branches of facial nerve should not be damaged by doing this. Once this is done, we mark our cuts. The first picture is showing that marking of our cuts. We mark it by a pencil or a marker, a sterile marker. And these cuts can be actually planned either via a mesotome, which will give you precise cuts, a bone burr, or even osteotome. But if you have the luxury to use a mesotome, that is always the best. This is the superior cut which is planned, and this is the inferior cut which is planned. Once we have planned these cuts, once we are through this cut, we remove that ankylotic mass, we create a gap, and once we have created the gap, we do a coronoidectomy bilaterally. Once the coronoids are removed, the mouth opening is checked. The mouth opening is approximately 50 millimeters here intraoperatively. So from 0 to 50, that basically is a good post-intraop result. And then we replace the fossa as it was shown in the video before. We fix the fossa and secure it via screws, and then here is my joint. And this is the same patient post-operatively with a satisfactory mouth opening, and the joint there can be seen, the joint which we have replaced. Of course, the upper third molar left side here was also removed some months back because it was impinging onto the anterior of the ramus, the remnant of the ramus. So, brief summary of our joint replacement. We have operated 4 cases in the last 4 years. In the age group, the patient, all were adult patients, the minimum age was 27 and the maximum 46. There were 3 male patients, 1 female patient. The mean intra-incision opening before surgery was 2 millimeters. Post-surgery, the mean IO was 39 millimeters. Follow-up is for around 3.5 years. The major complication is none, and the quality of life has hugely improved. These patients are very, very happy. They never thought they would not have ankylosis again, because both the cases which I showed you here had recurrent ankylotic episodes. They were operated a couple of times before as well, once by a plastic surgeon as well, but they could not come out of it. So why do we do a total joint replacement? Now, in orthopedic lectures, if you or orthopedics, if you listen to your orthopedic surgeons, they would suggest you a joint replacement if you have a degenerative joint disease of your knee, of your hip. So in orthopedics, this is being followed for decades now and with a very high successful rate. And the use of alloplastic TJR provides a biomechanical solution rather than a biological solution. It also reduces the chances of a secondary surgical site. As I showed you in my previous slides, that if you are harvesting a rib, you would require an additional surgical site, more complications can occur. Walford and Mercury in 2014 used alloplastic TGR in 56 patients, one of the highest series in 56 patients, and reported no failure. It allows immediate physiotherapy and marked reduced chances of recurrence. So there is ample of literature evidence pointing towards successful and predictable outcomes for total joint replacements, especially in recurrent cases. Total joint replacement also allows the fulfillment of another goal of TMJ management, that is the former facial deformity correction, as it allows concomitant orthognathic surgery as well. And as I told you, the customized joint is always better than stock joints, specifically in recurrent cases. So my take-home message for this lecture would be: we recommend TJR or total joint replacement for successful management of TMJ ankylosis, not only in terms of maximal incisal opening, but also achieving other TMJ ankylosis goals, especially in grown-up patients. Alloplastic TJR can provide adequate functional aesthetic outcomes and improve the quality of life. Use of alloplastic TM joint replacement in skeletally immature. Now, this is one component which will require further research because it is not being done in children or patients of growing age. Before I end, I would like to invite you to the next year to Delhi. We are we are actually hosting the national conference, the 47th national conference of AOMSI in Delhi, which is to be held in the month of November. Beautiful weather we have that time. So all the budding dental surgeons and the max-fac surgeons out here, I would like to extend this invitation there as an organizing team member. And this is my faculty where I work in Delhi. This is faculty of dentistry, and this is my life besides surgery. I play lots of cricket after whenever I get time, and this is our Premier League which we participate and we were the winners. My acknowledgement to Dr. Darpan and Dr. Anshul. Dr. Darpan is the one who gets the joints done for me. I get all the joints made from him, from his academy. So my acknowledgements to him, and thank you for your patient listening.
Thank you, sir, for this amazing lecture. Mother Teresa always said, while addressing people, let us always meet each other with smile, for the smile is beginning of love. So, to make you more happy and energetic, this early morning, I would like to call Dr. Anupam Agrawal, a great personality, the NDS orthodontist, consultant at Max Smart Super Specialty Hospital, Saket, New Delhi, speaking over the topic self-ligation, a game changer. Please welcome, sir.
Well, a very good morning to all of you. I am Dr. Anupam Agrawal, and the topic of today's lecture is self-ligation, a game changer for modern visiting orthodontic practice. I always start my lecture on self-ligation with this case. The patient presented with proclination, incompetent lips, and the chief concern was that she was not finding meaning in life. Now, many a times, I feel that as doctors, as orthodontists, our diagnosis is a bit limited to the anatomics, like where the teeth are, what are the values, what are the cephalometrics. I have found over past 15 years of my practice that when we connect to the invisibles, to some things that mean a lot to the patient and to their inner world, we create a better diagnosis. Gummy smile, the teeth going haywire, At certain point in time when I was treating this case, I was skeptical whether I will be able to give this patient the smile she really wants and the smile that she really deserves. After 1.5 years of treatment, these were the intro pictures of the patient. This was the result. Now, this made me feel the real power of self-ligation. I could have done this case with some other bracket system as well, but the self-ligation, the self-ligating brackets, gave me that power to give this patient this beautiful smile. The pre-treatment pictures, the post-treatment, and let me tell you, this case is really very close to my heart. And let me tell you why. This case is really close to my heart because this was a game changer for my private practice. This was a game changer because it helped me understand the true power of orthodontics. It helped me understand the way the patient approaches us. Many times it's not just the smile that patient wants, it's a total makeover of the inner being, the confidence, the self-esteem, the self-concept. And after we give a beautiful smile to the patient, we are not just treating him or her anatomically, we are empowering the patient's total being, the way that patient looks towards himself or herself. And this reflects in their health, their wealth, their business, and their relationships. This patient, which was with the chief complaint of not finding meaning in life, now is pursuing modeling. She's into cosmetics, and her whole life has changed. And this empowers me as an orthodontist, and I'm spreading the same message that we should expand our being as orthodontists, as dentists, and we should be receptive to the new techniques, new latest developments that are there, not for us, but to add more value to the lives of the patients, create more empowering treatment plans, and change lives. So I welcome you all to this journey of being a game changer in the life of your patients and taking game changers for your private practice. Now, let me ask you, what is a game changer? And I would like to make this lecture a bit interactive. So, anybody of you can share what is a game changer? Can you raise your hands? Anybody? What do you think is a game changer? And you may be totally wrong. You may say game changer is like Salman Khan, whatever. So, anything coming to your mind? What is a game changer?
Something that turns the thing like completely.
Great, thank you.
So your perspective of things.
The perspective of things, perfect, thank you.
Something which helps to boost your self-confidence.
Great, awesome, thank you. And all of that, right? So a game changer can also be called as something that disrupts the industry, something that changes the way you deliver treatments, something that changes the entire outcomes that you get. So this is the theme of this lecture is game changers. So the first half of the lecture, I will try to give you a holistic perspective of what are the game changers in various businesses, various industries across different verticals. And in the second half of the lecture, we will touch base with what are the game changers in the field of orthodontics, and particularly with regards to self-ligation as being a game changer. So I invite you all to this journey of finding your own game changers. You may be a game changer in the life of a patient. You may find a game changer for your own private practice, and our own, and most important thing, why we are doing this. Why all of you, and firstly I should applaud you all that you are here on this morning early in the day, taking out time for yourself to invest this time in your learning, and this speaks volumes about you. And let me tell you, I will make sure that whatever time you spend with me over here is well worth your time. So first of all, raise your hands. Everybody raise your hands. Right hand, up. Pat your back, and congratulate who? You, for being over here. So thanks a lot for being here, and let's begin. Now, what is the outcome? What is the outcome from this lecture? The dental and orthodontic market is changing rapidly. And I guess all of you must have witnessed, even after post-COVID, the way we approach the market, the way we approach the patients, and the way the patients are approaching us has totally changed. And if we think about the profitability of our clinics, if we think about the scalability, the relevance, and the sustenance, we need to have game changers. And we need to keep up pace with this change. And I tell you something. In this crowd, I find there might be some students, there might be some people who are in BDS, who are in the final years, internship, some might be postgraduates, some might be professors. You might be from whichever background you are, but this information is really required for all of us. Some of you might be opening your private clinics as general dentist, you might be calling an orthodontist to your clinic as a consultant. Some of you might be pursuing MDS in the field of orthodontics, you might work as a consultant yourself, or you might have your own private practice of orthodontics, or you might join a department or a corporate clinic. Whichever ways, you need to know that how to empower the lives of the patients with the modern age orthodontics. So again, this is all inclusive. If you are in graduation, still you need this information. So have that perspective, whatever I say, whatever I speak, let it land in whichever way on your ears and you perceive it in whichever way you want. So regarding the first half of the seminar, we are at the cusp of change. The COVID has really disrupted most of the industries. Some of the industries have been facilitated by it, some changes have been hastened by it. Information technology largely changed. Today we are having a hybrid conference. Maybe 5 years, 10 years back, hybrid was much of a showbiz. Now hybrid is a necessity. Brain chips. And since I told you, I'll be dealing with some things that are going across industries. Crazy things are happening, and the world is moving at a very, very, very fast pace. Earlier as well, maybe 5 years, 10 years back, the change in technology was there, but today the market is getting disrupted very fast. If in 6 months something new comes up and the whole industry changes. There are advancements in healthcare and medicine, new diagnostic tools and machinery is being evolved, rapidly expanding ecosystem of healthcare and medicine. The future of dental technologies innovation is here. The question is how fast we are to adapt to this change. The 3D radiography, CAD/CAM dental systems are becoming the norm of every clinic, and today you see 10 years back, having a CAD/CAM or a CBCT system in your clinic was much of a thing. Today, it is becoming a necessity. Why? Because the consumer, the patient, is becoming very much aware. They expect this from you, and sometimes they demand from you. OPG systems were a norm, say 5 to 6 years back. Today, the next big thing is CBCT. Now, how fast you can find the game changers in your industry, how fast you can equip yourself with the knowledge, and how fast you can equip your clinics with these game changers will be the defining moment in your life and in the life of your patients. Artificial intelligence and machine learning is no more a gig word for the dental world. It's already there. The at-home aligners, the at-home teeth whitening systems, the corporates are coming into picture. So if you have that element of opening a clinic in near future, or if you have a clinic right now, you need to be abreast with the latest changes that are taking place. The medical and dental tourism. Now, this was the broad picture of how the game changers are taking over the industries, various businesses across various verticals. And sometimes we as doctors remain aloof that it is not going to affect us, it is not going to affect our industry. But let's face it, how many of you had heard of aligners or Invisalign, so to speak, 15 years back? 15 years back, no, right? 10 years back? 5 years back? Maybe yes. And today, I have a patient who comes from London. I give 56 aligners to him. He comes after 1.5 years. I open his mouth and I'm shocked. The treatment is done. This is the power of aligners. And if 15 years back, some patient would have asked me, Doc, can the treatment be done without the braces? I would have thought that the patient is in a different world altogether, right? So these days, if the patient even says that can the treatment be done without Invisalign, I don't say yes or no. I just say right now it cannot be done. We do not know that the industry is changing so fast. And now at-home aligners is a new big thing. Many of you must have noticed that you just give a scan, the scanner will come to your home, although I don't back those practices, but the scanner will come to your home or come to the home of the patient. The aligners are delivered and the treatment is taking place. So if you have to open a private practice or you are in a private practice, where the industry is going. So that's a question that we need to ponder upon. And see, we can criticize the market, we can criticize everybody. When I started my practice, I was criticizing everybody. I was criticizing the market, I was criticizing the economy, I was criticizing the patient doesn't pay, X, Y, Z. And guess who was not on my list? Any guesses? Who was not on my list of criticism?
You yourself.
Me. Perfect. Great answer. Thank you. I was not on my list. I was not wishing to change. I was not wishing to find the game changers. I was not wishing to find the way to expand my being. The corporates will always be there. The market disruptors will always be there. Unethical practices will always be there. What we can do as doctors, as qualified dentists, as orthodontists, as oral surgeons, is find ways to adapt to change. And that is what we can do. And that is why we are here understanding this game. Now, in orthodontics, we have really come a long way. Initially, and we have a quantum leap. We have faced a quantum leap and a quantum shift in time vis-a-vis the development of new techniques and the way we have come forwards. Initially, we used to place bands, the metal bands. Then came the bonded brackets, which were metal. Then, as the need for invisibility increased, we went to ceramic braces. And as the humans had evolved from apes and now to humanoids, with many things being artificially customized for human beings, similarly, the field of orthodontics has also evolved in similar ways. The orthodontics is moving from highly visible to being less visible to being invisible, and practically it's like totally invisible now with the Invisalign and other clear aligners. Then the mini implants. Earlier, we had to place extraoral anchorage devices, which look very ugly, so to speak, to the patient. Now, with the increased demand of patient in terms of invisibility, now we are moving towards the temporary anchorage devices that can be screwed in and removed after the treatment, and there is no need of headgears anymore. So now, this is the core of the seminar. Traditional braces versus self-ligating braces. And as I showed you my case, self-ligating braces has proven to be a game changer and in various ways. And now I'm coming to the second half of the seminar, where we'll be discussing how self-ligation can be a game changer for your practice. For your practice, and even if you are not in private practice, you can spread the message that how a dentist, how an orthodontist, or how a collaboration of a dentist and an orthodontist can empower the treatment plans and change the lives of patients in a much better way. How? We'll see just now. This is a small video of the latest that is going in the field of orthodontics. A 3D scan is made. The patient will not be expecting these things from us, but now, as you must have seen, especially after COVID, the consumer behavior of dental patient has totally changed. When a patient comes to us in private clinics or in colleges, the patient has already done their research on Google, and sometimes I find that many of the doctors who are sitting over here who are actually practicing in clinics, the patient sometimes tells us things that we also have to look like where this patient has read up about this thing. And one of my patient, I was devising a treatment plan to her. She actually read an article and she came to me like, doctor, I want the tip of the canine to be 2 degrees more. So like this is the crazy thing that is happening, and you have to deal with this patient. You cannot say yes, you cannot say no. The patient's making sense, and she has read the article. So we as doctors need to be much more in terms of what we actually consume and how we deliver those results. And let's face it, change is fast and change is here. The pace of change is pretty fast. Are we able to cope up with that fast-paced change regarding our curriculums, our clinics, our workforce? Soon CBCT will become a norm in the clinics. OPGs already have become a baseline investment for any new clinic. Intraoral scanners are becoming the new normal. And corporate world across the globe is directly targeting the patients as they can't afford to miss the billion B. Once I was having a talk with the CEO of a company, the international dental conglomerate, and he said that, doc, we cannot afford to miss you guys because you are a billion people. So this is how the West is looking towards us from the consumer point of view. So the change is fast. Are the visiting orthodontic practices providing the right environment for upgradation and updation in relation to quality of orthodontic services to the patients and in an optimized way? This is a question that you have to ask yourself as a general dentist, to your orthodontist that is coming to you for rendering consultation services. And this is a question that is the essential primary question these days. Are we able to provide value to the patients? Because let's face it, the patient needs it, the patient is demanding it. Sometimes the patients will not even tell you. And the patient will go to some other clinic who is offering that. So you need to know all these things before you open a clinic. And even if you have a clinic, you need to upgrade yourself with all these things. And why do we need a game changer in the first place for our orthodontic practice? Anyways, to act as a practice differentiator, to enhance the value delivered to the patient, to stay updated, relevant, and profitable, to not be eaten up by the competition. Earlier, this was a more of a corporate terminology, not to be eaten up, but the kind of the market we have, you have to survive in the market. How many of you have seen that in COVID times, many of the clinics were shut down? And in Delhi, in one locality, more than 13 clinics were shut down. They could not bear the brunt of COVID and the EMIs. So not to be eaten up by the competition has become much more of a practical word in the dental industry as well, which was not the case earlier. To enhance the quality of orthodontic care to the patient and to increase the efficiency, efficacy, predictability of orthodontic treatment. So this is why we need a game changer for ourselves. And why change is a must now? Why should we change? How many of you know the things that you require for losing weight? Show of hands. I mean, you know, like less calorie intake, more calorie burnout. Everybody knows that. It is not a sacred science, some cult. But how many of you actually are able to practice that? How many of you are able to actually practice that with consistency? Not many of us, right? So where is the gap? We know the tools, we know the technology, we know the strategies, but we are not able to follow it. Why? Similarly, you know that we should be having game changers, CBCT, CAD-CAM is becoming the norm. We need to have some really good, solid treatment plans that we give to our patients. But would we actually do that? Why? There's a sense of urgency. How many of you have seen the movie Avengers? All of us, right? So it's good we are on the same page. Who is this guy? Anybody? Thanos. Wow, we're so updated. Thank you. So what happened was, the change happens in a heartbeat. What did Thanos do? And half of the population was wiped off. What I saw in COVID times, and what a metaphorical analogy I can give is, in COVID times, many of the clinics were shut down. Many of the dentists left the profession. Many of the dentists quit their jobs. Why? They could not keep up change. They could not keep up pace with the change. Whose fault? The industry's fault, COVID's fault, corporate's fault, economy's fault, or their own fault of not keeping up pace with the change. So this is what is the gap between knowing and doing. Until you believe that you can be a part of your own rescue, you will not be able to lose weight in some other aspect of your life, and you will not be able to have game changers in your private practice in field of dentistry. Gone. So again, coming to the basics, how the corporates view this picture. Today, the patient searches for you online. You need to be present online. Just Dial, Practo, different platforms. The patient searches for you, sees your reviews, just like they see the review of Sikh kebab in a restaurant. So you are being reviewed by the patients. And let's face it, whether right or wrong, ethical or unethical, this is the part of the game. You have to be present. Right? One of my patients calls me, doctor, your rating was 5 earlier and it is now 4.5. Should it make a difference to me? Should it make a difference to me? The answer is yes and no. It should not make a difference to me, not make a difference to me internally, the way I feel about myself. But yes, it should make a difference to me regarding the dynamics of my practice. So I would have to take measures to increase the rating so that the patient footfall is not affected. But internally, obviously, it should not affect me. Otherwise, like if your internal system, how you believe in yourself is guided by a rating, then it will be like a tide of emotions about yourself, and you'll not be able to be in the practice in the long run. Now, these are the questions. You may write down these questions. You can just remember these questions. These are the essential questions I found out that as an orthodontist, as a dentist, we need to ponder over these questions to find the game changers in the practice. Number one, are we enhancing the value that we are rendering to our patients and not limiting our growth just to number of new cases started per month? The normal lingo is how many new orthodontic cases you started, 50, 100, 10, 5. Are we limited to that numerical value, or are we finding that what is the actual value we are delivering to the patient in terms of better treatment plans, less painful treatment, quick treatment, more hygienic treatment? So what is the metrics of our adding value to the patient? Point number one. Second, is the delivery of our orthodontic care to the patients in sync with the corporates? Because let's face it, in our general dental clinics, we are the CEO, we are the marketing guy, we are the HR, we are the accounts, we are the operations, we are everything. In the corporates, they have different departments, operations, marketing, HR, different heads working towards a common cause. So if we have to do dentistry in the best way possible, we need to look at the corporate way of working. And are we actually doing it? And are we doing it for ourselves? Or are we doing it for the benefit of the patient? So that the patient can get better services. And the third is, are our curriculums enabling the young graduates or the postgraduates to be well equipped with the technologies and newer modalities of treatment? So once a dental graduate or a postgraduate comes into the clinics, is he or she well equipped with these things, or they have to again go through a learning curve, or are curriculums in the colleges equipping these young minds with the new games and new tricks of the market? So these are the questions. I don't have the answers. I ponder over these questions. You may contact me after the lecture if you find some answers, because obviously the brilliance is in the room. So many minds, different thought processes along your own timelines. Let's deliberate over it at a later point in time. I call the today's patient as the enlightened patient. Earlier, we used to go to ashrams, to monasteries to find the enlightened beings, the awakened souls. Every patient is an enlightened patient today. So whenever the patient is sitting in the consultation chair, I find that this patient knows a lot, and we have a conversation now. It's not a consultation anymore, it's a conversation now. Because the patient is also giving you nuggets, what is going on in the industry and how we can improve upon our practices and our own beings. So this is a very important slide. Getting towards the next half of the lecture, why? Why should we change? We are trying to market our practices with a myopic vision of just more marketing. One fine day, the dentist will rise up, social media updates, marketing, this and that, and it will die down for the next 6 months. So it's just for marketing, or we are adding value. We are missing on the value addition part of our practices. Many times I meet doctors, he say, everything is going fine, let it be this way. I don't want to disrupt the entropy and the balance. So are we just trying to work out the way it is, going on since long, or we want a game changer so that we can scale and be more profitable. Orthodontics is often a neglected child, wherein it is not utilized to the fullest potential. And the 3D face-centered diagnosis and self-ligation is the game changer. Now, these are the things which we need to know, understand, and go about when we talk about game changer for our orthodontic practice. Are we giving biologically sensible forces to the patient? Are we just loading the teeth with the brackets and the wires, or are we giving light forces? Light forces directly respond to decreased pain perception. Now, do you want a patient who is coming to your clinic, hey doc, the wire was put in on my teeth and it's paining like hell? Or do you want a patient who has a smooth experience with braces? How many of you want a smooth experience of the patient with the braces, right? Pretty much all of us, right? Better oral hygiene. In self-ligating braces, the oral hygiene is better because the elastic modules are not there and there's a shutter system. So obviously, in a private practice, if the patient is having good oral hygiene, the treatment will be faster, there will be less gum swelling, and the patient will be having less pain perception. Good or good? Good, right? And then lower extraction rates. In self-ligating braces, since the forces are less, and the philosophy is such that we can expand the arches in a particular way so that we can decrease the chance of extractions. So again, this is also a game changer. Less orthodontic side effects, faster treatment time, airway considerations, because when we are expanding the arches, the tongue occupies a better posture in the oral cavity, so the airway is a bit expanded. So it's seen that sometimes the braces treatment is being done to expand the constricted arches so that the tongue occupies a better position and the airway is enhanced. TMJ considerations and the novelty factor for the patient, because let's see, many times a patient is yearning in the dental chair for you to tell them that what latest, what better, and what best you have in store for them. Sometimes we as orthodontists are restrictive, thinking that the patient is not knowing, but sometimes the patient is knowing everything. They just want you to tell them that this kind of particular new technology is there for you to serve them in a better way. So again, novelty factor, and again, let's face it, who is your biggest brand ambassador? You or the patient? The patient, right? So if you are putting self-ligating braces, if you are putting the latest technology onto the braces, onto the patients, and the braces are there for 1 to 1.5 years, the patient is the walking brand ambassador of your practice. Wherever the patient is going, the patient is letting other people in their circle of influence know that they are having the latest technology that my well-wishing orthodontist has put on me to deliver better results. Is it good? Right? Amazing. So these are the high-value game changers which are patient-centric. Now these are from the side of the clinician, from the side of the dentist, from the side of the orthodontist. Less chair-side time. Now how many of you want to work on one patient for 1 hour versus one patient for 15 minutes? 15 minutes, right? Because you can have adventurism earlier in the day, maybe when you start your practice, but as your practice grows and the number of patients increases, you want less chair-side time. Then comes reduced appointment frequency. How many of you want your patients, the braces patient, to come every 21 days versus once in 2 months or 3 months? Once in 2 months or 3 months, so that you can have better time for taking care of more patients. The practice differentiator for dentists and orthodontists. So there are 10 patients visiting a particular practice. They're offering self-ligating braces, which are obviously having a lot of high value things for the patient, versus a practice that tells we are not giving self-ligating braces or the latest things because we are happy with the way we are working. Obviously, a patient would definitely like to go to a practice which is offering self-ligating braces or a new technology for that matter. The marketing edge, it can be used as a marketing gig, lower extraction rates. I've seen that the fathers and the mothers have a very different way of approaching towards having a consultation for their child. And this is very logical actually. How many of you have read about marketing psychology? Anybody? Like these corporates give a lot of thought to it. So they say that if a mother has come for a consultation, she'll be more concerned about the pain that the child may go through, the extractions, the more emotional part of the equation. I don't say that fathers are not emotional. I'm a father, but fathers are more concerned about the treatment time, how much will it cost, the discounts, and all these things. So this is my perception as well. It may vary. Obviously, human beings are intricate beings, but so it can be a marketing edge as well. So if you're designing your Facebook advertisement strategy, if you're designing your strategy, lower extraction rates. So this will appeal more to a mother, right? Because the moment a mother sees that the extractions are less and the doctor may not pull teeth on my child, so it can help you get more cases and deliver more value. Then high ticket monetarily, obviously you can place it higher up in the chain of value that you're delivering and the profitability ratio as well. The power of variable talk, which is not actually a part of this seminar, the patient compliance is really good. Since it's quite obvious. If the pain is less, the treatment time is less, number of visits to the orthodontist are less, the oral hygiene is better, then obviously the compliance of the patient or the acceptance of the patient towards the appliance will be better. Lower bond failures. How many of you want that a patient you have bonded does not visit you again for a broken bracket? Perfect, great. So again, the lower bond failure rates make sure that the patients will be coming less and they will be coming just for the activation appointments. And avoiding retreatment for gaining aesthetic smile. So these are the high value patient centered things. So we have discussed two things. One is high value game changers for the patient and high value game changers for the clinician. Now this is one of my case, highly placed canine, and maybe 10 years back, I would have preferred to extract the first premolar, which is normally the case that when the canine is highly placed, we have space deficit, we want to extract teeth. That is the normal thing we do in orthodontics. But I placed the braces, the patient did not come for 6 months. Now, normally what happens is that my orthodontic colleagues will, resonate with me. When a patient has come after 3 to 6 months and has a no-show, we do remember God at that point in time. Because when we are opening the mouth of the patient, we can see anything. We can see cross displacements, or we can see something like this, that the canine has beautifully come into the arch. So in self-ligating braces, the philosophy is such, the physiologic adaptation of the arches, the gaining of the space, that the canine, most of the times we don't have to extract first premolars and we can very well proceed with the cases being non-extractionary done. You see? Yep.
So in what kind of cases would the self-ligating braces be contraindicated?
See, again, there is no absolute contraindication, so to speak, but this will come in a later part of the seminar. So the question will be dealt in the later part. It's a very good question, first of all, because sometimes we see that where this thing can be applied, but where it cannot be applied. So if you talk about contraindications, so wherever the contraindication is for orthodontics, that stands good for self-ligating braces as well. But yes, self-ligating braces expand the horizon to a certain limit. So we can do certain challenging cases which we were not being able to do with the traditional or the conventional braces. So for example, extraction. If we do not want to extract on the patient is a horizontal grower. So if the patient is a horizontal grower, we generally want to avoid extraction. So in those cases, we can use the self-ligating braces. So this generally expands, but if you talk about contraindications, there is no absolute contraindication, wherein self-ligating braces would actually help in cases which were earlier contraindicated with the conventional braces systems. So that's the point. Does it answer your query? Okay, thanks. So again, this is the case progression. You see the left side picture, the canine is out of the arch, the right side, canine is totally into the arch. The arches are beautifully expanded, and we are not just treating teeth. We are doing a functional treatment. We are expanding the arches. The tongue is occupying a better posture in the oral cavity. The airway is perhaps enhanced. So this is in totality a more favorable treatment for the whole stomatognathing system. And let's face it, if we are delivering this kind of results, if we are delivering this kind of treatment, it's whose benefit? Is it just ours, or is it a win-win? Is it a high-value treatment for the patient and a high-value, thing for our practice and we as dentists and orthodontists? So just a refresher, there are two kinds of braces: active self-ligating braces and passive self-ligating braces. And when I'm talking about this flexion relationship, I'm talking more about the passive self-ligating braces. The basic methodology is that the self-ligating braces have very less friction and binding, and very less forces are required. So these two things amount to all the things that we are talking about in terms of less pain perception, less forces applied. So the basic core of the thing is very less friction and binding and very less forces required. In the traditional braces, how many of you had a braces experience any time in your life? Can you raise your hands up and high? Although obviously it might have been painful, I can understand that. So most of you might be having like conventional braces. So they had modules, elastic ties, which needed to be changed every 21 days or every month. So it leads to more of the forces being applied, more of friction, more force to be applied on the teeth, and thereby more pain, more time to be taken, and poor oral hygiene. This was the usual case. Bungee cord like a thing of elastic modules being placed between on the way the wire was secured into the bracket. And what happens in self-ligating braces, the lumen to wire ratio is less. There's very less friction, very less forces, and just enough forces applied to stimulate the cellular activity without completely occluding the fragile vascular architecture of the periodontium. Now, this might be a biological concept, but how it reciprocates in the clinical scenario? Less forces means better treatment, frontal resorption, faster treatment, less pain, good oral hygiene. So this one thing, that is a core thing, reciprocates in the whole philosophy and how it emulates in the clinical outcomes. And when I talked about the functional aspect of treatment, this treatment also allows muscles of face and tongue, bone and soft tissue to determine the position of teeth in arch form, and we attain a more physiologically determined tooth positioning in arch form. So finally, to wrap it up, the very less friction and binding and very less forces, what and how they help us. There's a rapid tooth movement, little proclination of the teeth, less anchorage demand, better arch development, wider arches which may be more aesthetic, and wider arches have better periodontal health than those resulting from more rapid and forceful expansion. So if you get this for the patient, is it a win for the patient? Yes? Good. Again, decreased pain perception. There are various studies which have corroborated. Many of you have more of a logical mind who want to research, who want to go into the depth of the articles. Various articles are published over the internet regarding decreased pain perception with self-ligating braces, better periodontal health, lower extraction rates. The orthodontists are always in a dilemma whether to extract or not to extract, and this has been a controversy since ages. And sometimes we know the metaphor like the life comes in full circles, and sometimes we start from some place and we come back to the same place. So there was a great controversy in orthodontics. Initially it was non-extraction, then it came to extraction, and extraction became the norm, and it was like 4 premolar extraction was the order of the day. And now we have come back full circle and we are propagating non-extraction. So if you see overseas as well, the extraction rates have been greatly diminished, and we are more on a face-centered diagnosis these days and a face-centered treatment plan. And extraction means that we have totally like given up on all the ways which can be deployed for a non-extraction treatment plan. So we have come full circle from extraction to from non-extraction to extraction, and now again to non-extraction. Airway considerations. As I told you, in the whole philosophy, the airway is also enhanced in the majority of the cases. Less chances of orthodontic side effect, faster treatment time. Again, some research. The clinician-centric point of view, which I've already told you, less chairside time, reduced appointment frequency, practice differentiator or marketing edge, high ticket monetarily, smile improvement is the case, pre-treatment on the right side, post-treatment on the left side. The whole facial structure we can influence with braces, and this is one living example of that. The arch with gain. See the incisor proclamation and the reduction in the incisor proclamation. Lower incisor leveling. Again, caution. To wrap it up, self-ligation is not a magic pill. We need to have a sound biomechanics. No experimentation, trial and error. High cost, if you're taking high fee from the patient, you have a high responsibility. So you need to know how to deliver the treatment in the best possible way with self-ligation. It's not that you put the brackets and magic will happen. You need to have a proper, if you are a general dentist, you need to have a proper word with your orthodontist, how to go about the treatment. If you are an orthodontist yourself, you should be abreast with the latest developments going in the field of self-ligation to deliver better treatment to the patient. It's technique sensitive. And now, how many of you have read this book, Who Moved My Cheese? Anybody? Fine. And most of you might already be knowing the essence of it based on your timeline. It says that the change is always there, right? And the change is around us as well. We have been seeing, how many of you know the term or the word Nokia? N-O-K-I-A, Nokia. Because there's a very timeline over here. So Nokia, right? So Nokia was the company who started the mobile phone revolution, right? Do you often hear the term Nokia now vis-a-vis Apple, Samsungs, and other things? Why? Sometimes the change is fast and the change is much. So this applies to us as well, whether we are general dentists, whether we are in a corporate setup, we have private clinic, whether we are a consultant orthodontist, or for that matter, any specialty. The change is happening. How fast we can adapt to the change will determine how relevant we can be in the market. Because let's face it, the consumer or the patient is the judge, and that judge is having a magnifying lens these days to assess you in every way possible. So, who moved my cheese? So, if you are careful about your cheese, it's your cheese ultimately, right? Your practice, your private practice, your profitability is your cheese. So, you have to be careful about smell the cheese and move on to a new market, move on to a new strategy, pull out a new rabbit from your hat. Patients these days want something new, some new addition in your clinic every time they visit. Maybe they visit after 6 months, they visit after 1 year, and they applaud you for that. The doctor, you have incorporated this new technology and you are serving us in a better way, and they feel connected. To conclude, with a self-ligation appliance system, by treating the tissues more gently and creating less cellular trauma, we are making strides in improving treatment for our patients. Less trauma means greater comfort and, conveniently enough, a quicker finish from start to finish. Our patients trust us to be doing what we can do best to continually make advancements in these areas and to be best doctors we can be. And by offering more value to the patients, we can truly make it a win-win game changer for both dentists and orthodontists and the patient. For those of you who want to connect with me, I'm available on Instagram and Facebook. You can drop in your queries, you can connect with me, and you can have more queries resolved even after this lecture. So I hope you find this lecture value addition in your armamentarium, in your toolbox. And again, I would like to applaud you for taking out time and invest this time in learning. And from here, you'll listen to many speakers, multiple speakers, and thanks to the organizers for creating this platform wherein we all can meet and share our learnings. And these are just like various tools in your tool belt of a dentist, and you can pull out different tools to enhance your life, to enhance the life of the patients, and make it a win-win game changer for all of us. Thank you, and thanks for being a patient listener. Any questions?
Thank you, sir, for your valuable time. Put your hands together for sir. Now we will invite Dr. Imran Khan and Dr. Anupam Agrawal for the felicitation ceremony. I would like to invite Dr. Anmol Bagari, Dr. Ashish Chandra to felicitate both of them. Please, sir. Put a big round of applause. Seems like everyone is sleeping.
જેવું થાય તો તેમાં અહીંયા સહાય કરીને કલર બી સેટ કરી દો થાય જ
थैंक यू सर, थैंक यू मैम। ना संघर्ष ना तकलीफें, क्या मजा फिर जीने में, तूफान भी थम जाएगा जब लक्ष्य रहेगा सीने में। क्या बात है। Now I would like to invite our next speaker, Dr. V. Srinivasan upon the stage, a renowned personality, Dean at Bharati Vidyapith Dental College and Hospital, Navi Mumbai, to speak upon PMT demystified beyond and rehabilitation. Put a huge round of applause.
દીવું કરો ને થોડું
The quality.
A very, very warm good morning to all young and senior delegates present over here, some guest speakers, and many eminent personalities in dentistry. At the outset, I would like to thank the organizers for giving me this platform to talk to such a diverse audience on a topic that I have been meaning to talk for a very, very long time. And it's the first time I'm presenting this idea in any public forum when I have been wanting to present this for a very, very long time. And this is actually a counterpoint. So, for those of you who don't know the point, we will also introduce you to the point. So, we first start with a doha from Kabir. So, Kabir says that it's very easy, it's very easy to create the allure of something that is not true. So the irony is that alcohol is sold where people stand in a line outside and collect it, whereas milk is delivered to your doorstep because that's how truth is. So here I have come to deliver truth at your doorstep because it's important for you to learn and hear something that is healthy. So this presentation is on something called, as I titled it, Beyond T-Scans and Full Mouth Rehabilitations. And to understand what do I mean by Beyond T-Scans and Full Mouth Rehabilitations, you have to realize that there is a new idea that has come into dentistry, which is called as neuromuscular dentistry, which has emphasized the importance of occlusion in temporomandibular joint disorders, and not just identified it as important, but found it critical and now an entire branch of dentistry which deals with temporomandibular joint is centered around identifying minor and major occlusal problems, of which one of them is one method of identifying is something called T-scans, and there's a lot of information on splints, and there's a lot of information on bruxism, and there's a lot of information on full mouth rehabilitation. And I am going to tell you what science is all about. What does today's science say on the subject? So we will quickly have
the quality of time. You are trying to make physics out of time. No, you can't make physics out of time.
just wait. Can I request the organizers to just check the video connection? No, it's not good.
The quality of
Yeah. Videos. Yeah.
time. You are trying to make
who is a big name, a leading name in dentistry. He has a lot of wealth. He has all the trappings of power, of knowledge. And he says something that is beyond your comprehension. And you find that fascinating. And you immediately clap hands and play the role. This is not good even in religion. But it becomes absolutely dangerous when it comes to science. Science requires you to question and question authority, including me, myself, the speaker. So unless you contest, and there is a certain basic dimension to science, there is something called peer review. That means you must present your findings to people who are knowledgeable on the subject, and you must get their critical comments on it. And most important, your science must be reproducible. If you do something and it works, and somebody else who does not subscribe to your thought, not those who believe in your thought, the people who don't subscribe to your thought, they repeat the same experiment and they find it working, then you know that it is science. If it works only for you, it's at best magic, or it can even be considered to be conning people. So the aim of the presentation is fairly simple. I will state it right in the beginning so that we don't waste too much of time. That occlusion has a very limited role and a very minor one in temporal mandibular joint disease. It is important for us to understand this, and this is not just my views. No. So it's fine. So first is this, the emphasis on occlusal therapy in what we call as neuromuscular dentistry is unscientific. Executing a treatment for patients without a scientific basis is both illegal and unethical. And we make false claims which sound good, सच के आसपास का झूठ पकड़ने में बहुत मुश्किल होता है. It's very difficult for you to catch an untruth which is a lie which is very close to the truth. So although there is some truth in what people say, the way it is presented, the way it's projected is different. And sometimes we don't hear, we hear it if it is something that we are aware of. So we play one more video. If you will see the inconsistencies in the presentation here, but you may not see it when other speakers speak. I need somebody to just handle this part for me. Somebody just help me do this. There's one more video. Maybe he can.
उसके नाम पर भी खूब विज्ञापन बनाते हैं लोग, बावले होकर के खरीद लाते हैं. कोई मंजन नहीं बाजार में, कोई टूथपेस्ट नहीं, कोई ऐसा डेंटल केयर नहीं है जो आपको पारिया से मुक्ति दिला दे. हमने दिव्य दंत मंजन से, दंत कांति एडवांस मंजन से, दंत कांति टूथपेस्ट से करोड़ों लोगों का पायरिया, करोड़ों लोगों के मसरूड़े ठीक किए हैं.
Dental care, okay, maybe dental care, there is some genetic predilection. And then there is a claim that, okay, I have a solution which takes care of crore logo. So suddenly it sounds impressive. If you believe, now what happens is here, you have not set your belief on the individual. And so you're trained in this particular area of dentistry. But the moment you come to an area of dentistry which you're not familiar with, and you put your faith into that individual, then you can be taken for a ride. So it's important to find out how you are not being taken for a ride. And one of the things over here is something called evidence-based medicine or evidence-based dentistry. So you need to search in an area called PubMed. So those of you who are not familiar with PubMed, the students, please make a note, because PubMed is the scientific or the medical Google. Right? It's something that ascertains the validity of the claim. So the basic principle of temporomandibular joint is that joints adapt. Whether it is the cervical joint, whether it is joint anywhere in the body, the knee joint, joints intrinsically adapt. Otherwise, people who are flat, who are fat, who are plump, they will all develop problems in their knee, and those who are carrying heavy weights would all become unwell. So it's important for you to understand the intrinsic adaptability of joint. There are also a lot of false claims that are made, like drinking 8 glasses of water are important. It's harmless. Some of these claims are harmless, but some of the claims can lead to unethical practice. So the problem of the myth of occlusion in the TM joint is, first is that the evidence contradicts it. It's not that nobody thought of occlusion. Way back Costel, when he discussed temporomandibular joint, a lot of dentists thought that occlusion should be important. It sounded logical because TM joint is directly impacted by the way teeth meet. And so a lot of research started right in the early 1950s to check and prove that occlusion is the key. And again, each research disproved it. So it was eventually discarded as an idea. It doesn't mean that we should not research it. I'm not saying, because even if we discard an idea, science requires itself to be open to challenge. But we must be ready to accept that the idea has already been discussed for 50 years, and repeatedly we have come to the conclusion that occlusion is a small role. And what's worse, any such treatment that we embark on, like full mouth rehabilitation, is both expensive and it is invasive. So there is an idea called traumatic occlusion, something called malocclusion. Most of you would know the difference between the two of them. Malocclusion would be just malalignment of teeth or the way the molar is related, and traumatic occlusion is what it causes. And trauma can be caused in the periodontium, in the teeth, and some of them in the temporomandibular joint. And each part adapts in its own way. Teeth get ground off, periodontal ligament ensures strengthening of that area or movement of teeth to accommodate the additional force. So it causes mobility of teeth, and the temporomandibular joint adapts in its own way. As it adapts, it goes through phases. So that's one more quote on the truth. So the truth about occlusion is this. See, the prosthodontists, there is one school of neuromuscular therapy that holds the orthodontist responsible for many of the problems, including airway restriction. They say when you take in the teeth, the natural teeth were outside. You've taken the teeth, the tongue falls back, person can't breathe, so you're causing a problem to such a person. And therefore you must now realign and reorient the entire jaw condition. So most malocclusion does not really affect temporomandibular joint. Orthodontists who undertake orthodontic treatment saying that this will improve your TM joint health are not doing the right thing. At the same time, forbidding orthodontic treatment, saying that will hurt the TM joint, that's also not pretty true. There is some damage, but most of the time the joint adapts. Now, why do I say that? Likewise in occlusion, okay, you have that occlusion, it requires us to be respected when we are constructing prosthesis. At the same time, it doesn't mean we reconstruct the entire occlusion in the process of creating a prosthesis. So those of you who would like to go the scientific way can click photographs of this. These are just a few of the major researches on the subject, on whether orthodontia helps correct TM joint. That's also not true. Enough research, and something called systematic reviews. Systematic reviews is considered as the pinnacle of evidence, which say that no, orthodontic problems do not give rise to TM joint. Correction of the orthodontic problems does not heal the TM joint. Doing orthodontic treatment does not hurt the TM joint. So those of you who are referring patients to orthodontia can be clear that you are neither benefiting nor harming the patient by that particular treatment. Whereas this is not the position of neuromuscular dentistry. Likewise, when you raise a bite, most of us know that we can raise a bite because the joint adapts. If the joint were not to be able to adapt, likewise in bruxism, the loss of vertical dimension happens over a period of time. And even here, the joint adapts. So any change in the vertical dimension which is done over a period of time causes the joint to adapt. Likewise, the latest issue there has been of JPD, Journal of Prosthetic Dentistry, a very, very reputed journal in prosthetic dentistry, talks that it questions the idea based on a lot of research done on whether bruxism is a pathology or a normal finding. So one must be aware that what we are looking at is a paradigm shift on the role of occlusion on the TM joint, and we have one small cult, a small group of people who have broken away and who say no, that occlusion is the key. So it's important for you to understand that we need to sit together. You can't have that you pray your way, I pray my way. This is not religion. Science requires us to sit in a common position and win each other's trust and confidence. So that at present is not enjoyed by neuromuscular dentistry. And the problem of such a system is that they are not satisfied by merely saying that it affects the temporomandibular joint. If you look at some of the neuromuscular dentistry claims, they now say that they can claim they can cure migraine, they can claim they can cure trigeminal neuralgia, they can cure diabetes. Okay, now all these such claims that are being made are something like this. प्राणायाम करने से कपालभाति don't know about it. You see, शायद होता रहेगा. So, average person, what differentiates us from the common man is that we ask questions. कि भाई आपका proof क्या है? Right? Yeah. So we have a similar case. I think we made a point. Basic point is that you need to have evidence. You will have people claiming things, and they'll be doing something else. And then finally, when you're dealing with the temporomandibular joint, diagnosis becomes important. Okay, there are a lot of diseases that you will not be familiar with, like say a synovial condylomatosis or a rheumatoid arthritis that can be identified by you because you don't have that experience. So getting into occlusion and managing occlusion when your basic diagnosis is wrong is a dangerous attempt. So you need to know what are the common disorders. They can be handled by most dentists. Then the last thing that we discuss is imaging. Now many of these people are so concerned is that they ask for extensive imaging. If you learn neurovascular dentistry, typically you will be asked to get CT and MRI for all patients. But this is not supported by evidence. So you have you have got two of the references. One is 2006, and no clear evidence or relationship between clinical and MRI diagnosis. And the other, Journal of Oral Rehabilitation, again a very good journal for prosthetics, which talks the absence of studies on the therapeutic efficacy of imaging on temperament. कि imaging करके क्या impact हुआ आपका treatment. So it's important for you to justify the kind of imaging that you're doing. Otherwise, you're likely to get into medical legal trouble. So you have to realize that advanced imaging is restricted only to cases which are refractory, which are difficult to treat. And imaging may not mirror finding. Just like we know that a patient may have a periapical abscess, but may not show radiographic changes. They may show only mild widening of period space. There is always a lag between or difference between clinical and radiological findings. So imaging is usually good for prognostication, quantifying the disease, but it does not really, and sometimes to rule out serious disease like synovial condylomatosis. But it may not, or say a CNS tumor, but it may not be always possible for you to treat the case based on your treatment. So in short, it is better that this is initially looked at by an oral physician and then considered for any advanced treatment rather than directly looking at full mouth rehabilitation or T scans, because there is something called access to. It's been considered that emotional component of the patient is an important part of TM joint diseases in a lot of chronic diseases. And if you don't deal with that part, then dealing with the occlusion is not going to make a big impact. And if you still feel that you have doubts on the matter, do unto your patient as you would have done unto yourself. We all know that we would like to have conservative treatment as far as possible. And wherever there is clear evidence that extensive treatment is not required or can actually be harmful, and you find that extensive treatment is expensive, you will certainly not choose it. So the long and short is that we need to be responsible, because as dentists, we claim to be understanding occlusion, which we must, and using responsibility when we are working with occlusion, which we must both in orthodontics and prosthodontics. But we must know exactly what its role is when it comes to the temporomandibular joint. So just to give you a few parting shots, because we've criticized a certain system. So what do? So give a patient the time, because time is a great healer. Most of these, the simple TM joint disorders are self-limiting. There is an important role for the doctor and for the patient. The doctor needs to reassure the patient that there is going to be generally a good recovery and there is a favorable natural course. A word of reassurance from the doctor goes a long way in helping the recovery of the temporomandibular joint. You need to educate the patient on joint mechanics. What has gone wrong? What you must have done? And what you can do to keep your joint healthy. A good mix of rest and exercise is a great way of managing any joint. Patient should be aware of what habits he is undertaking that can harm the joint, whether it is any hard foods or any habits that is not giving his joint rest. So you have to identify from the patient's habits and food habits where the patient is not getting joint rest, including some of the parafunctional habits. If you make them aware, this is called biofeedback, a big name for a small thing, but you increase the awareness of the patient about the disease. Counsel the patient. Again, this is a systematic review. You can identify, I'm not given the reference, but in 2013, there is a systematic review that counseling and self-management by the patient is a conservative, low-cost and beneficial treatment alternative to even splints. Okay. So usually the immediate treatment consists of taking care of the etiology, maybe a little bit of muscle relaxants, a spray massage, biofeedback, and a host of other medicines and procedures which include ultrasound, hypnosis, and so on and so forth to take care of that acute phase of the disease. And delayed treatment could involve a little bit of replacement of missing teeth or correction of a prosthesis which has been faulty, or a cognitive behavioral therapy for access to an isotonic and isometric exercises. The long and short is that temporomandibular joint has been advertised as something very painful, complex, and difficult to treat. But in reality, good patient-doctor relationship, good communication, informing the patient about joint mechanics, and a little bit of common sense about occlusion as to what to correct and what not to correct could go a long way in treating more than 99.99% patients. The chances of you getting a rheumatoid arthritis or a synovial chondromatosis is very, very low. They are overall, by and large, TM joints are self-limiting. And health is natural. Our job as a physician is to gently nudge the patient back to health. The patient is a partner in his or her own health. So we need to make the patient a partner, just like we look at brushing and other methods and good diet as a partnership in dental health. There is a partnership the patient plays even in temporomandibular joint health. And there is a role of reassurance and confidence building in the role from the point of the physician. So I want to use this platform to influence young minds and guest speakers here to make them aware of the overemphasis on neuromuscular dentistry and occlusion, and also make them aware of the area, the bus that we missed in terms of patient participation and the role of the physician in self-assurance and confidence building. So with this, I again thank you all for being a partner to this in spite of the technical glitches that we faced. And I, for one, enjoyed presenting my views, and I hope that you also enjoyed it. Thank you so much.
Thank you very much, sir, for your valuable time. Every tooth in a man's head is more valuable than a diamond. So, to know more about the advancement in dentistry and oral pathology, we would like to call upon Dr. Venkata Subramanian to share his answers.
Okay, I know. Thank you very much. Very good morning to all of you. Oh, thank you all. Thank you so much. Greetings from Gandhinagar Hospital. First and foremost, let me thank the organizers for inviting me to do a talk here. When we talk about oral pathology, all we remember is pink and blue. So that is what we remember as. And most of the time, the diagnosis which we give is not microscopic, it is macroscopic. No, we look at the slide whether the corner is broken. No? Is there a small mark here, and that is how we give the diagnosis. So it's all pink and purple for us. Who is a good oral pathologist? She's a good-looking oral pathologist. I really do not know whether she is a good oral pathologist. The answer to my question is that it is third period students. So how many third period and final period students are here? The reason why I'm saying that third period students are the best oral pathologists is that in case of the MDS students, when they appear for the examination, they get at least 20 minutes for each slide. They can see the entire slide under the microscope. They are given a history. They don't have to draw any diagrams. They don't have to label any parts. And the diagnosis need not be right. All they have is just to describe the slide, and if the description is quite good, they still get their marks. But the third period students, they just get 5 minutes, or sometimes even 4 minutes. They cannot move the slide. The field is fixed. They have to look at the slide. Okay? They are not given any history. They have to draw the diagram, label the parts, and give the exact diagnosis. Then only they get their marks. So in my opinion, the third period students are the best oral pathologists. Well, you don't have to be an oral pathologist always to give certain diagnosis. For example, when you want to diagnose dental caries or periodontal disease, we don't have to be an oral pathologist. We don't have to extract the tooth, make a crown section of it, and then say, yes, there is enamel caries in this, right? Okay. So for certain conditions, we do not have to be an oral pathologist to give the diagnosis. But for other conditions, we need to be. And the common misconception about an oral pathologist is that one is always looking under the microscope. There is something called as clinical oral pathology also, which is unfortunately, not realized by many. That there is something called clinical oral pathology. And even while taking admissions, we keep on talking about conservative dentistry, orthodontics, oral surgery as clinical subjects. And unfortunately, subjects like community dentistry, oral medicine and radiology, oral pathology, they are considered non-clinical subjects. Okay, but there's something called clinical oral pathology. And how many of you know what you mean of DIY? Do it yourself, right? So, but this is not about do it yourself. This is about diagnose it yourself oral pathology. Okay, so I generally start with Latin quotation because most of us do not understand Latin and Greek. So it's good to start with the Latin quotation. Ad sanitatum greatus est novis mormum. So what does it mean? It means that the first step toward cure is to know what the disease is. Okay. So if you look at most of the oral pathology lesions, they can be categorized to any of these following lesions. They can be because of color change, loss of integrity, could be a growth of the swelling, could be intra-bony or a disease related to the tooth or syndrome. Most of the diseases can be categorized to one of these. So let us start one by one. Color change. The change of color could be white, red, blue, pigmented, or mixed colors. So let us start with the first one, the white lesions. Okay. Of course, I'm not going to talk about the entire gamut of lesions. White lesions can be basically classified as scrapable and non-scrapable. Okay. So on scrapable lesions, if you look at the most common ones are acute pseudomembranous candidiasis, which is also called the road thrush, chemical burns, and pseudomembrane over ulcers. So I'm just going to show some clinical pictures which will be very easy to diagnose. Scrapable means we just have to take a gauze piece and then see whether the white lesion can be scraped off or not. Okay, one of the most common ones which can be scraped off is a pseudomembrane over an ulcer. Okay, the other common ones are like these candidiasis. In fact, if you suspect candidiasis, you can always ask, get the history of the patient, whether it's HIV positive or something like that. But more importantly, you can just use the scrapings and place it on the slide, okay? And just the small preparation using KOH should be able to identify the candidal species on it. Chemical burns, again, by taking history, you can easily find out whether the patient recently had any kind of a chemical burn. Sometimes you also might find an ulcer forming on the palate because of hot pizzas or beverages. Okay. So that is the pseudomembrane over an ulcer. Okay, that gives a whitish color, but once you remove that, you'll be able to actually visualize the ulcer. Coming to non-scrapable white lesions, they can be unilateral or bilateral. First, look at the bilateral ones where they are present on either side. Okay, one of the most common ones is the presence of linea alba. Okay, linea alba is a white line which is seen at the occlusal level. Nothing to be worried about. Okay, in fact, if you all go back and check your mouth, probably you'll be having the same white line in your mouth also. Okay, so that is linea alba, which means white line. Nothing to be bothered about. But something else we have is lichen planus. Lichen planus can be bilateral, it can be unilateral, not necessarily always bilateral. Lichen planus can be easily identified because of the fact that the periphery of the lesion you have fine striae. Okay. In fact, this lesion may not be biopsied at all. The current view is that to diagnose lichen planus, we don't have to take a biopsy and then give the diagnosis of lichen planus. The only other lesion, in my opinion, which can be confused clinically with lichen planus is lupus erythematosus and, of course, lichenoid reaction. So only when you have that kind of a confusion, then you need to go in for a biopsy just to confirm a few changes. But otherwise, lichen planus can be easily diagnosed clinically. We don't have to actually do a biopsy for lichen planus. And the other one is, which is not very common, is Luke edema. Okay? Because of edematous accumulation within the tissue, it appears whitish, but the advantage of this is that you just have to stretch the mucosa and it disappears. Okay, so that is a very easy way to diagnose leukedema. If you suspect leukedema, just stretch the cheeks of the patient, and if it disappears, then it is leukedema. White spontaneous again is not very common, but it's seen in the young adults or children. Again, this is a bilateral lesion. Okay, so the entire surface is like having a rough texture, fissured texture, and that will be easily able to identify it. So that is about non-scrapable white lesions which are bilateral. If you look at the unilateral ones, they are present only on one side of the cheeks, like frictional keratosis. I'm just talking about the common ones: leukoplakia, oral leukoplakia, etc. Frictional keratosis is because of friction. Okay, it will be because of chronic trauma to it, and you will usually have a thick white lesion. Okay, so that can be easily identified because of the fact that the patient usually has some kind of a sharp tooth or history of cheek biting and so forth. Okay, so that will be able to easily help to identify frictional keratosis, but a thick one. This is a white lesion which we see because of smokeless tobacco, snuff dippers lesion. Again, this has got a characteristic clinical appearance where we have an eptide kind of an appearance. No? So the like waves, when they come and approach the beach, that kind of an eptide appearance you can be observed in case of snuff dippers lesion. The leukoplakia, we need to do a biopsy here, not for diagnosis, but to see the amount of dysplasia. Okay, otherwise leukoplakia is easy to diagnose. We have a white patch. Okay, the reason we need to do a diagnosis because sometimes, especially those which are mixed erythroplakic, leukoplakic lesions might turn out to be cancer when you actually take a biopsy. So biopsy is necessary not for diagnosis, but for estimating the amount or type of epithelial dysplasia. Okay. Oral hairy leukoplakia again need not do any biopsy, but if you suspect it, where you have usually seen on the lateral aspect of the tongue, again seen in patients who are probably HIV positive. So lichen node reaction, something similar to lichen planus, but the history will probably give some kind of drugs which the patient is taking, because of which we feel this lichen node reactions are present. Okay. So that is about white lesions. The next group of lesions which we are going to look at are red lesions. So red lesions are those which are red in color. Okay. So different kinds of red lesions which are commonly seen are traumatic erythema, this is basically because of trauma, candidiasis, which also includes median rhomboid glossitis and denture stomatitis. Earlier, median rhomboid glossitis was thought to be developmental disorders because of presence of tubercular impar, which was supposed to go away, did not go away. Okay. Denture stomatitis are all candidal infections, erythroplakia and yeast coming to gingivitis. Traumatic erythema basically because of trauma, so that reddish area is clean. Erythematous candidiasis can be seen again, especially in relation to denture wearers who are not maintaining hygiene of the dentures. Again, if a suspecting candidiasis, all we need to do is just scrape off the top tissue, spread it on a slide, and send it for a microvisual examination. Erythroplakia, again, based on the history of the patient, you easily diagnose erythroplakia, especially because it's red, velvety kind of appearance. So that is again can be diagnosed. But if you're suspecting erythroplakia, again you have to do a biopsy to make sure about its histopathological appearance, because nearly 10 to 20% of erythroplakic lesions turn out to be oral cancers. So that is about erythroplakia. Deepose familial gingivitis is not a disease. It is actually a name given to oral manifestation of many other skin disorders like pemphigus, pemphigoid, even erosive lichen planus. So they all have this clinical appearance of these combination of gingivitis. So again, here, strictly speaking, we don't have to do a biopsy, because whether it is pemphigoid or pemphigus or erosive lichen planus, the treatment is quite similar. Okay? Giving topical steroids or sometimes systemic steroids. But for the purpose of academic reasons, we can probably do a biopsy to find out whether it's actually pemphigus or pemphigoid. So that is about the red lesions. So next we are going to look at blue colored lesions like hematoma, amalgam tattoo, and so forth. See, amalgam tattoo again clinically can be diagnosed because you look at the history, you find out that maybe the person has a recent amalgam restoration, and usually the place where it is present, the tooth will be having an amalgam restoration. Okay, so you really don't have to do a biopsy to confirm that it is amalgam, but in case you're really worried whether it is because any pigmented lesion in the oral cavity needs to be biopsied to make sure that it's not melanoma. Okay. But in case you are worried about it, if you take a biopsy, all you see is blank particles. Okay. You might think that this is melanin pigment. The oral pathologist can always use polarized light microscope to make sure that it is not melanin pigment. Hemangioma looks bluish in color because of the overlying tissue. Okay, so of course again this is quite obvious the diagnosis. So that is about hemangioma. Eruption hematoma is nothing but the oral soft tissue counterpart of dentigenesis. It is usually seen in relation to unerupted teeth. Okay, again that appears quite bluish in color. That's why this has also been called as blue dome cyst of Seward. Okay, so that is an eruption hematoma. Okay, or eruption cyst. Mucosals are again very easy to diagnose and quite commonly found, which might have this bluish tinge. Again, it's a mucosal, the cyst of the salivary glands quite soft, so can be easily diagnosed. And some of them are so small, and once they rupture, nothing will happen. You don't have to actually take a biopsy of a mucosal to give the diagnosis as mucosal. Most of the time, it's left, it automatically rupture after a few days, and it will not be a problem. This is a blue nevus. Again, nevus is actually a very harmless lesion. It's not much of a problem. But one dictum is that any intraoral pigmented lesion has to be biopsied to rule out melanoma. We don't do that in case of skin lesions. But in case of oral lesions, any pigmented oral lesion, okay, suspected melanotic pigmented oral lesions, we need to take a biopsy to make sure that it is not melanoma. Okay. So, of course, what lesion is this? It is not particular lesion at all. Okay, so that's why all that is blue is not pathology. But so this is not because the person has been using some kind of candy because of which tongue is blue in color. It's not cyanosis or something like that. Okay? So that finishes the blue lesions and coming to pigmented lesions. So pigmented lesions again could be physiologic or pathologic. Okay, so physiologic pigmentation is when you find pigments in the mouth, or sometimes it's also called as lingua nigra. Okay, so that is physiologic pigmentation. In fact, people who have pigmentation on their tongue, according to our Indian thing, it's known that people who have that pigmentation on their tongue, whatever they say, happens. So I do not know that kind of features there in the north, but down south we have that thing that a person has got a black tongue. Okay, whatever he says happens. So if you want to diagnose lingua nigra, you can just ask him to find out who's going to win the next elections and then check it out. Okay, and if it happens to be true, then you know that person has got lingua nigra. The next one is melanotic macule. See, melanotic macule is a pigmented lesion which is flat. Macule means a discolored flat lesion. Okay, not elevated. Okay, so that is melanotic macule. Again, intraorally, if it is formed, we need a biopsy. If it is present on the lips or rest on the skin, we don't have to worry about it. But melanotic nevi, intraorally, we need to biopsy because they can be confused with melanoma. So how do we distinguish? Usually, normal nevi, they are uniform pigmentation. Okay, no surface ulceration. Usually the edge is quite uniform and well circumscribed. But in case of melanoma, as it is shown here, the pigmentation is usually uneven, the surface is rough, the edges are not even, and sometimes you might also find ulceration. Okay, so that gives indication that it could be melanoma. But even otherwise, even if it is uniform, you feel it is nevus, still we need to do a biopsy to make sure that it is not melanoma. Okay, of course, drug-induced incident are also bad, like tetracycline-induced, minocycline-induced, even drugs like chloroquine, they can also cause pigmentation. Taking history about recent any drug therapy will help us to find out the diagnosis. Regarding systemic conditions, there are good number of systemic conditions like Addison's disease, Peutz-Jeghers syndrome, where there could be intraoral pigmentation or at least circumoral pigmentation. So that completes about nearly the color change except for the last one. Mixed, of course, it means combination of color. It's not necessarily that everything will be nice blue color, nice black color, or nice brown color, or nice white color. Sometimes there could be a combination. Like for example, erythroleucoplakia, combination of leukoplakia and erythroplakia. So that is similarly, oral lichen planus can have pigmentation. And that's a very normal thing for oral lichen planus to have post-inflammatory pigmentation. Okay, so in fact, if you are coming across a lesion which has got all features of those style, and then you have pigmentation, then probably it is oral lichen planus, which is unlikely with, as I said, with systemic lupus erythematosus. So that is about the color change. The next one is loss of integrity. Loss of integrity means where the surface epithelium, for example, is gone. Okay, of course we could just take as ulcers, but we have ulcers, fissures, and erosion. All the three are quite similar, but not the same. Erosion is present only within the superficial layers of the epithelium, not exposing the underlying connective tissue. Fissures is a long, deep cut into the epithelium and into the connective tissue. That is, and ulcer, of course, involves both the epithelium and connective tissue, where raw connective tissue is exposed. And these lesions can be either primary or secondary. Okay, so basically, primary means we can classify as acute or chronic, or it can be healing ulcers or non-healing ulcers, or it can be based on the etiology, like because of infections or because of trauma, or even because of chemicals and so forth. Okay, so basically, primary ulcers are ulcers which are seen as ulcers. That means they do not have a stage where they are found as vesicles and then rupture to form an ulcer. Okay, so if vesicles are formed and then they rupture into an ulcer, okay, so then that would be secondary ulceration. Okay, but primarily itself they are seen, like for example, aphthous ulcer. Okay, it does not have a vesicular stage, but directly it is seen as ulcer. So those are called as primary ulcers. Okay, so when primary ulcers, the common ones are traumatic ulcer, aphthous ulcer, UNUG, nowadays of course is being called as NUG, just necrotizing ulcerative gingivitis, syphilitic ulcer. These are of course some examples of
primary ulcers. Okay. So traumatic ulcer, as the name suggests, because of trauma. Just look out if the patient has got any sharp tooth or something, which is irritating that particular location, and then you will know that it's a traumatic ulcer. Okay. Aphthous ulcer, of course, this is something which most of us are familiar with. One good thing about aphthous ulcer is that it is always seen only on lining mucosa. Okay. Unlike the herpes, secondary herpetic ulcers, which are seen always on keratinized mucosa. Okay. Whereas this aphthous ulcers are always seen only on lining mucosa. Okay. So, and they are usually, nice erythematous halo around the ulcers, so that will be help us to diagnose it. And of course, we keep on asking the question to the patient whether they have any stress or anything like that. But studies have shown that probably aphthous ulcer is not related to stress. After seeing the aphthous ulcer, the patient gets stressed. Okay. So that is about aphthous ulcer. This is of course aphthous ulcer of the other type, the major aphthous ulcer, where you have larger ulcerations. Okay. And as I told you, earlier it used to be called as acute necrotizing ulcerative gingivitis. Okay, but now it's just called as necrotizing ulcerative gingivitis because not always it is acute. Okay. Syphilitic ulcer, again, the history of the ulcer will be probably very useful in getting a diagnosis. Okay. So of course, nowadays syphilitic ulcer is not much of a problem, but during my time, no, it was a problem because it was a sexually transmitted disorder. Okay. So being a sexually transmitted disorder, it's very difficult to elicit history from the patient sometimes to find out, about the sexual history of the patient. Okay. So if time control, I'll just tell you a small anecdote which has happened during my days in my medical college, where a student in the oral surgery department happened to know this. Gentlemen, if you don't mind, can you please stop talking? Thank you so much. Okay, because your voice seems to be louder than mine. I know more emphatic about it. Thank you. Anyway, I'm just relating an anecdote which took place in Nagar quite some time back, where the patient happened to notice an ulcer on the palate of the patient in this oral surgery department. So the student was just had read about the syphilitic gamma. So we thought maybe this patient has got syphilitic gamma. How do I go and find out whether this diagnosis is the right diagnosis? Okay. So the student went to the teacher, who happens to be a lady. Okay. So the lady said, there is a way by which we can find out the diagnosis in these patients. You have to ask the right questions and then you get the right answers. Okay. So look at me how I ask my questions to the patient and you will come to know. So she walks up to the patient and then she says in chaste Hindi that Bahar jaake aaya kya. Okay. So the patient said, nahi madam, seedha aapke paas aaya. Okay. So the right reason is that like sometimes your questions should be in such a way that they do not embarrass both the patient and the doctor. So that is about the primary lesions. Regarding secondary lesions, we have herpes and other viral infections, erythema multiforme, pemphigus or pemphigoid, even lichen planus can show ulcerations. Okay, the adhesive type of lichen planus. So one on this side, on the left side, is the intraoral herpes. On the other side is herpes zoster. One thing about herpes zoster is that it does not cross the midline. Okay? Whether it is lesions on the skin or outside of the body, especially that's seen on the waist area. That's why it's also called as shingles. Okay? So that is herpes zoster. You can see in intraoral. So most of the time, history will definitely be able to give us the diagnosis. Viral ulcers, see, most of the time they are seen in children, usually involve the oral cavity, especially the pharynx and so forth. There's always a history of fever, malaise, headache, all these prodromal symptoms are present, and then the patient has got a history of having vesicles which are ruptured to form ulcerations in the mouth. Okay? So that way you can easily find out, and usually they have other symptoms, like for example, if it is a hand, foot, and mouth disease, so they'll also have lesions of the hand and the foot also along with them. So that will be useful to easily diagnose viral ulcers. Erythema multiforme, again, there are a vast number of etiological factors which are involved with erythema multiforme. It could be viral infection, bacterial infection, drugs, and so forth. But the way these ulcers are present in the mouth, one can easily diagnose erythema multiforme. Okay? And not only that, etiology probably becomes of less importance here. How to manage this patient? And most of these kind of ulcerations, the treatment is topical steroids or sometimes even systemic steroids. Okay? Again, pemphigus, pemphigoid, the diagnosis is basically, histologically, we can diagnose these two lesions. But clinically, it's very difficult to diagnose pemphigus and pemphigoid. Basically, pemphigus is an intraepithelial vesicle. Pemphigoid is subepithelial. So if you are likely to see unruptured vesicle or bulla in the mouth, it is more likely to be pemphigoid. Okay, if it's already ruptured in the mouth, less likely to be pemphigoid, more likely to be pemphigus, because pemphigus is intraepithelial vesicle where the roof is very thin, easily likely to rupture. Okay, so we are unlikely to see a vesicular stage in case of pemphigus, more likely to see a vesicular stage in case of pemphigoid. So for only academic reasons, you need to probably find out whether it is pemphigus or pemphigoid, because the treatment is quite similar. And in fact, if they are also having skin lesions, it's better to refer to a dermatologist. No, that would be an easier solution. Okay. So this is pemphigus. As I told you earlier, erosive lichen planus, pemphigus, pemphigoid, they all involve gingiva a lot. That is the reason why they are called as desquamative gingivitis. Okay. So that completes the color change as well as the loss of integrity. Interchangeable. Okay. So this is the growth on the left hand side, and the right hand side is the swelling. So this can be developmental, inflammatory, cystic, or neoplastic. See, one thing about these growth and swellings is that some of them are obvious diagnosis, okay, like mandibular or maxillary tori, palatal torus. But others, sometimes you need to take a biopsy to give the diagnosis. Okay, so developmental, for example, torus, we can diagnose it on your own. You don't have to require no taking a biopsy, saying it to an oral pathologist to give the diagnosis of palatal or mandibular tori. Lingual thyroid again is easy to diagnose. Okay, of course, these are clinical pictures of bilateral mandibular tori and palatal torus. Okay, lingual thyroid again, you have a swelling in the middle of them. Here, probably we need to confirm the diagnosis, and before you do the biopsy, you need to be careful, because lingual thyroid probably could be the only thyroid gland which is present in the individual, in which case probably you cannot just like that excise it and throw it away. Okay, so you need to take the advice in case you suspect that it is lingual thyroid. Epstein's Pearl Pons nodules, again this is seen in very young people, okay, less than 1 year of age, where you have, in case in the middle of the palate, if you see white swellings, it is Epstein's pearls, okay, sort of fissural cyst. But if you see similar white creamy structured cysts on the buccal aspect or on the lingual aspect of the alveolar ridge of infants, then it is Bond's nodules. Now these two lesions really don't require any treatment at all. Just recognizing that and assuring the parents of the child that nothing is going to happen, okay, because usually they just resolve on their own spontaneously. Okay. So inflammatory, again, we have good numbers on which can be easily diagnosed without any biopsy. Like for example, Epulis fissuratum, which is related to irritating dentures, the border of dentures. Giant granuloma, pyogenic granuloma, both appear quite similar clinically. Anyway, they are going to be excised. Because they are going to be excised anyway, okay, you can send it to an oral pathologist just to confirm your diagnosis. But otherwise, pyogenic granuloma and giant cell granuloma, also called giant cell epilis, both have similar clinical appearance. Traumatic neuroma or traumatic fibroma is nothing but it's actually not a true neoplasm. It's also reactive lesion in reaction to some kind of a trauma. Again, diagnosis is usually quite obvious, but only thing is probably we need to send it to the pathologist for just to confirm the diagnosis. Okay. Traumatic neuroma, unlike traumatic fibroma, is painful. That could be usually one indication that probably it is involving the nerves because it's very painful. Okay. So again, this is more for academic importance, the diagnosis rather than anything else. Okay. Coming to the cystic lesions, again, those which can be easily diagnosed by us, the mucocele, the eruption cyst, and dermal cyst. Eruption cyst I've already mentioned about. Mucocele, if it's present in the floor of the mouth, is also called as a ranula. Okay. Again, quite easy to diagnose it. Most of it just be to surgically puncture it and remove it rather than actually excising the entire lesion. Dermal cyst in the oral cavity is very, very rare. Okay. But I just, for sake of academic reason, just put it here. And dermoid cyst, when you take the biopsy, it looks just exactly like odontogenic keratocyst. But odontogenic keratocyst, of course, is from within the jaw bones, dermoids is within the soft tissues. So that is regarding the cystic lesions of growth and swelling. Neoplastic lesions, again, clinically, you can really diagnose most of these lesions like papilloma, okay. Lipoma can be easily diagnosed on the skin, because when it is there on the skin, no, when you try to palpate it, it's like it's got slippery margins, easy to diagnose it. Because, but in the oral cavity, this is also soft, so it can be confused with mucosal. But one thing about it is usually they might have an yellowish tinge in the oral cavity, in the lipoma, and of course not very common like mucosals. Neurofibroma again just looks like fibroma. Okay, so the treatment is excision, and only after excising it, probably you will realize that it is neurofibroma. Okay, and varicose carcinoma is quite obvious, diagnosis because of its varicose appearance. It can be easily diagnosed. Squamous cell carcinoma also is quite easy to diagnose it clinically, but you need to confirm the diagnosis. Okay, that's the reason we need to take a to find out what is the staging of the cancer. Okay, is it well differentiated? Is it poorly differentiated? Because that is what decides the treatment. Okay, but at least clinically you'll be able to diagnose that this is probably squamous cell carcinoma. Okay, and of course all these salivary gland tumors again, as I told you, this is just for the purpose of knowing that these all could be the various growths and swellings which you might come across. Diagnosis is by histopathology, not entirely by clinical measurement. So that is about the growth and swellings. Regarding tooth, basically we can divide them as developmental lesions related to the tooth and non-developmental lesions. Developmental lesions, probably these are the most easy ones to find out, because they are based on number, size, shape, structure, eruption, and so forth. I'll just give some clinical pictures which will help us to easily diagnose, like hypoodontia, okay, less number of teeth. Supernumerary teeth, more number of teeth. These are quite easy to diagnose. In fact, when you take OPG, you'll be able to see good number of these lesions. Teeth which are present in the whole cavity. Okay. Sometimes a single one, sometimes multiple one. They could be part of a syndrome, like Gardner's syndrome. Amelogenesis imperfecta, dentinogenesis imperfecta. Okay. These are again you can easily diagnose both clinically as well as using the radiograph. Okay. And there are so many other developmental lesions which are probably easy to diagnose, like dense invaginators and so forth. Fusion and concretions. Okay, but related to all these development disorders, there are certain points which all of us can remember here. One, always count the number of teeth and correlate with the age of the patient. That is point number one. Two, if there is any development anomaly of the teeth, take an OPG to make sure that if there is any other developmental anomaly present within the bone, which you probably might have missed, and also make sure that it is not part of a syndrome. Okay, so usually these development anomalies can be part of syndrome. Like for example, ectodermal dysplasia. Okay, if you just look at the mouth, probably you'll be noticing only hypodontia. But just look at the eyebrows, look at the sparse hair. Okay, then you'll find out that it is part of a syndrome. So any developmental anomaly you come across, just make sure that it is not part of a syndrome. And if it is an intrabony lesion, it can be any of these three: radiopaque, radiolucent, or mixed. Of course, that's going to radiological part, okay, which is not the clinical diagnosis. Okay, but I just mentioned about it because if you're going to diagnose it both based on clinical appearance as well as radiological appearance, this will be useful. So if you have a radiopaque lesion, or if you have a radiolucent lesion, or if you have mixed radiolucent radio opacities, that is an entirely different topic, how to diagnose those lesions which are having a radiological appearance. Okay, that is beyond the scope of this presentation. And finally, we are talking about syndromes. Again, there are so many syndromes, and probably you should be in a position to realize that it is a syndrome, even though you do not know what syndrome it is. Okay, so at least as general dental surgeons, we should be in a position to find out what syndrome it is. Okay, so that sort of completes my presentation on an overview of do diagnose it yourself. So what does this mean? Okay, this does not mean that you don't require the services of an oral pathologist. So all those oral pathologists will start coming and hampering me. No. I don't mean that you don't require the service of an oral pathologist. On most occasions, probably you can diagnose it yourself, but definitely you require the service of an oral pathologist because whatever tissue you remove from the patient's mouth, even if it's a gingival tissue, okay, send it to an oral pathologist, okay, and send it in 10% formalin, not in saline. Saline is not a fixator. Okay, generally some of the oral surgeons or any dental surgeon, they might send it in saline thinking that no, it is a preservative. Okay? It might be a preservative, but definitely not a fixative. Okay? So that is the second point. The third point, when you're sending the biopsy to the oral pathologist, describe the reason, okay? Give a detailed history and also the site of biopsy, because sometimes if it's a bilateral lesion, we should know whether it's from the right side or the left side. Okay, sometimes both are same, but sometimes it could be different. Okay, so always mention the site of the lesion. And finally, diagnosis by intuition or hunch is the swiftest way to disaster. Okay, so this was quoted by Robert Moyers. I don't know how many people know about Robert Moyers here. Does anybody know who is Robert Moyers? Anybody here? Robert Moyers is an orthodontist. In fact, famous for his book, Handbook of Orthodontics. Of course, during my time, it was a handbook, but now it's become a very big book. Okay, orthodontists here probably might vouch for the fact. It's quite a big book. Okay, Handbook of Orthodontics, Robert Moyers. So there is a very good quote that no, don't guess the diagnosis. Okay, if you do not know the diagnosis, consult an expert like me. Okay, but don't give diagnosis on your own. Okay, don't guess the diagnosis. The only place where you can guess the diagnosis is in your examination. Okay, but otherwise, don't guess the diagnosis. Okay, so would you like to be Sherlock Holmes or Sherlock Holmes? Okay, so why I'm talking about Sherlock Holmes? I don't think all of you know about Sherlock Holmes, right? Of course, Sherlock Holmes became very popular to the present generation after the movie by Robert Downey Jr. But Sherlock Holmes is, do we have time? Okay. Sherlock Holmes is a character created by Sir Arthur Conan Doyle. Okay. So Arthur Conan Doyle, after he came back from India, so he started his practice, and when he started his practice, he was not getting good number of patients. So he didn't know what to do. So that is how he started writing novels. Okay. So he created this character Sherlock Holmes based on his teacher, Sir John Bell, if I'm not wrong. So this teacher was a professor of medicine. Okay. So when this professor of medicine used to take lectures for them and give them the diagnosis, he used to talk about all the possible causes, and then he asked them to keep on eliminating the causes which are not responsible. So whatever remains is the final diagnosis. So that is how this character also was created. The Sherlock Holmes approach is that, is it a variation from normal? When you look at the patient, you see linea alba, it's just okay. No, it's normal, physiological, chalta hai. Okay. But if it is a variation from it, then you can just start categorizing according to your primary manifestation. As I told you, is it a color change? Is it loss of integrity? Is it a growth? Is it a swelling? Okay. Is it a lesion related to feel like that? You can categorize it according to the categorize the lesion, and then you start listing all the possible causes. What could have caused it? Is it genetic? Is it developmental? Is it inflammatory? Is it neoplastic? Is it cystic? Is it metabolic? Is it systemic? Like that. List of all the possible causes. Eliminate all the unlikely causes, and then you arrive at a tentative diagnosis. Okay, and you can end the final diagnosis. Because as I told you, sometimes clinically you can arrive at the final diagnosis. If you cannot arrive at the diagnosis clinically, all you can do is probably take a biopsy or something like that, send it to the oral pathologist, and then you can confirm your diagnosis. The final word is never assume. So all of you know about this word assume. You must be wondering why the donkey is there, because if you assume, it makes an ass of you and me. Okay, so never assume the diagnosis. Okay, so the take-home message is that without history, diagnosis is a mystery. Okay, so always take the history of the patient. Nowadays, we are all so busy with our lives. As soon as the patient enters into the clinic, they say, okay, I think you have this, so you do this. Or of course, nowadays even the patient tells a diagnosis to us. And tells her, no, so doctor, I've already seen everything on Google, so this is probably the treatment, so what do you think I should do? Okay, so always take the history from the patient. 2, not all lesions are cancerous. Okay, of all the lesions, when you look at white lesion or red lesions are far more dangerous than the white lesions. Okay, and third and the most important one, when in doubt, take a biopsy or consult an oral pathologist. So thank you all. Thank you so much for your hearing. Any questions, doubts, clarifications, you may kindly ask me. This is like my lectures. At the end of my lectures, I ask my students any doubts, any clarifications. They just take attendance and go stuff. No? So thank you all. And that is the question. Yes, Martin. Thank you so much. Thanks a lot. Okay. Okay. I think frankly it depends on what other relations you are seeing along with your endodontic treatment. Is it related to that particular tooth, or let's say, for example, it's a lichen planus? Okay. So if it's not going to be related to your endodontic treatment, I don't think it should be a problem. No, because let's say lichen planus on the cheeks or something, it should not be a problem. No, unless you irritate that lichen planus, I don't think it should be. Okay. So there is a systemic condition. Herpes simplex virus you're talking about. Okay. Herpes simplex virus, it depends again the where the lesions are. If you're doing endodontic treatment, it's not a problem because it's going to be seen usually on the correctness mucosa. You're going to see a lesion. So topical application of acyclovir, I think, should be good enough. Okay. Okay. See, in case of no herpes simplex virus, if you're seeing it in an adult patient, it's most probably because of reactivation of the virus. The virus gets reactivated and usually keeps on coming to the same location. Most often it's on the correctness because of sometimes even the corner of the lips or something like that. So if you are taking adequate care, it's highly unlikely that it will be, infecting or contagious to the individual working. Okay, unless they become really intimate with the patient. So that is highly unlikely. So it should not be a problem in my opinion. So even Dr. Srinivasan is here, the working with the person. If he has got a different opinion, he can also say that.
Essentially, you need to see whether the condition is finite or not. Suppose it's going to finish off. Lichen planus, leukoplakia is not going to get over in a 2 days or 4 days. So you can't deny the patient treatment. Whereas if somebody is having a episode of gingival otitis or a recurrent herpes labialis, you may choose to defer the treatment, because you know that in 5 or 6 days, the patient may get better. So you do not want to cause distress to the patient. So you do a usual kind of case-by-case choice. So general guideline would be how long is it oral lesions or oral condition will continue, and how invasive or how symptomatic the patient is for the dental problem concerned, and how much invasive is your lesion. You got to these circles will have to. I hope that answers your question. Not complicated.
I think Dr. Srinivasan follows that dictum. If you cannot convince them, confuse them. Yeah, thank you. Any other questions? Thank you.
Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir for felicitation of Dr. Subramaniam. Please put your hands together. like to welcome Dr. Anmol Bagaya and Ashish Chandra sir for the felicitation of Dr. Venkata and along with Vinny sir. A big round of applause, people. Unfortunately, Dr. Subramanian was not with us yesterday, so we'd like to present the award of Best Oral Pathologist of the Year. And now for felicitation, we would like to welcome Dr. Srinivasan sir on the stage. Please put your hands together for sir.
Yes, sir.
Thank you so much, sir. Ma'am. As Mahatma Gandhi once said, live as if you were to die tomorrow, learn as if you were to live forever. So hereby presenting Dr. Nikhil Verma, Dean of Gitanjali Dental College from Udaipur. Please put your hands together for him.
Well, when you have a seniors like Dr. Subramanian, Dr. Shahi Chandra, and Dr. Srinivasan, who is my teacher also, it's very difficult to stand with them and walk the talk with them. But I still try to do my best, and I was requested by one of the speakers that Dr. Shahi that after a lesion, we want to repeat one more lesion. There will be too many lesions on us. So please pay us for post and call. So I'm going to talk because the crowd was of undergraduates only. That I just want to talk on endodontic course, which are the basics of it. And the historical perspective is really very, very interesting on it. As I'll start with that. Anyone of you know this person? I'm sure that your knowledge is equal to mine. Pierre Fortune. Okay, he's called as father of modern dentistry. And in 1747, when the teeth were half broken, I don't know, there are not many books and that there are not many research done on that, half broken teeth. I don't know for what reason in those 1700s or 1800s the teeth were broken in half. And they used to pivot the teeth. They used to, put the pivots into the teeth to build it up. So, Pierre Fortune, what he used to do, he used to take the hippopotamus teeth, seahorse teeth, and all those teeth, and he used to put it in the canal. Okay, they knew that time, if you cut the tooth in half, there will be a canal and you can pivot inside. After 100 years, okay, in 1839, the captain came with a suggestion that by providing artificial crowns to natural teeth were much better than inserting the seahorses and other teeth because they were not really replicating the same thing. Okay, so he also recommended the removal of the remaining part of the anatomic crown with excising forceps. If any part is remaining, So he said that you chop it off. Okay, the existing excising faucet and extirpation of the nerve by rapid rotation with the help of silver wire into the canal. So that time there was no terminology called as pulp. They used to say that tooth is lined outer by a periosteum and inner by a periosteum. So they used to say that you can remove it with the help of silver wire, and then after that you can place a pivot inside. So this is the pivot I was talking about. Okay, this is tooth, and you can see that there is a screw. So the screw came later on. This gold screw came later on. Before that, they used to use the hickory. Yeah. So these all consist of well-seasoned hickory. Hickory is a wood. So what will happen when you put the hickory inside? That will swell up. So once it swell up, the tooth which you have attached to it will not come out. But the problem with that is people are thinking that it is wood. But what happened with that? The hickory, when it was swelling up, it was making prone for the fracture. Okay, so that time endodontic fracture was invented that time in 1839. Also, the teeth were prone for caries due to this. So they suggested we should go for a material which can definitely will not expand and it will not go into any kind of deterioration. So Dr. F.H. Clark in 1949 proposed use of metal tube in the canal. Okay, what he said, while you are doing you are extirpating the inner periosteum or so-called pulp. Okay, there will be some kind of inflammation which will exist. So after extirpation of the pulp, you should remain there for 4 to 8 days. So you don't do anything for 4 to 8 days. You wait for 4 to 8 days, and after that you attach your double coat there. Okay, and now because there can be any kind of thing which separation might come out later on. So they use the spring-loaded dowel that time. Okay, so spring-loaded dowel was given by F.H. Clark. I don't know, very classical picture. But this is one of the pictures which I got it from 1845 publication of F.H. Clark only. So that's it. That's how it was attacked. The artificial teeth were attacked. Okay. Then Sir John Toms in 1894 represented. So Sir John, 1894 he had given that, John Toms. And then in 1869, the G.V. Black suggested the filling of the canal space with the gold foil and threaded gold bolt, which contained the RCT. It means still the RCT instruments and all were not defined that time. Richmond crown, it is one of the earliest crowns which was given. Okay, it was similar to G.V. Black what he gave, and he introduced them the year 1880. This design consisted of threaded tube in the canal, which held the screw in place through the crown, which I have already shown the picture of you. So, if a tooth is broken, if a tooth is fractured, and patient is coming to you, what are the benefits of post to the patient? Now, I have seen the patient when he comes to the private health, more than the patient is sad that my tooth is fractured, the dentist is very happy. Why is the dentist happy? Because he doesn't want to do the post and core. What he wants to do is to place the extract the tooth and place implant, which is more benefit to the doctor than to the patient. Many a times I've seen that. No. Our goal as a dentist is to provide the biggest psychological advantage to the patient that my natural teeth is remaining as good as possible. That is the major goal of ours. Okay. It's also if you tell the patient, I'm going to say the truth only though it is fractured, patient is really going to trust you. Patient is really not going to leave you. Okay. I have had the patient where patient, just mental trauma, he came to me, he has gone to other dentists and he told, aapke teenon daant nikalne padenge. And I told them, no problem, we'll save them post and core, however time they can last, they will last, and probably we can do something good to them. Okay. So, as a prosthodontist or as a dentist, our main goal is to save the tooth, not to salvage or extract the tooth. So, I'm sorry for the wrong depiction of it. But I think the other way around. Okay, this is the condition of the tooth. Okay, and this is how the post and core can save the tooth. I mean, if you can see the picture, they could have been easily salvaged. So what are the benefits of this? Yeah, definitely a psychological approach. Patient really trusts you, And there are mechanical advantages also because you are saving a tooth, you are saving the implant for the future, you are saving the bone for the future. Retention. How do you retain your post? Okay, a really important critical part of dentistry. Retention is really important in every part. Retention is a bigger problem when we are students also. Because अगर वाइवा में जाते हो कि सर याद नहीं आ रहा, retention नहीं हो रहा है. Start from there. So retention is a really big goal. Okay, and retention is a bigger goal in any kind of endodontic practice and a prosthodontic practice. Okay, retention is absolutely not required in oral surgery. They want to remove all the retained roots rather. Okay, so retention of any kind of process, whether it's complete denture, fixed partial denture, macromagic prosthodontic, or a removed partial denture, it's a big problem. Okay, so posts are used in the in a chamber of the canal or in a skull chamber or in a canal. Okay, in restaurant tooth or also as a over-denture abutment. There are different types of posts are there. You have custom-made posts, you have pre-fabricated posts. Okay, we'll discuss them. We have pre-fabricated posts. They are metal, serrated, threaded, smooth, vented, and then we have metal-free posts. They are carbon fiber posts. They are glass fiber posts. There are further classification of the fibers, and based on those fibers, you have different kind of fibers, glass fiber posts and a carbon fiber post also. There are many research done on it. Okay, you can go ahead with whatever post you feel, but I think the cross-section fibers are really very, very important. Okay, there are many disadvantages of fiber posts also, and there are many disadvantages of metal posts also. We'll discuss them later on. Metal posts. Advantages: they are really very economical. They are easier technique. They can be cemented directly. They can be of a very good strength. They can be used for over-denture abutment also. What are disadvantages of it? They have the fracture of bending forces. They have loss of retention. They have own corrosion and fatigue strength. Cannot be removed easily. Site of fracture is below the bone. The last 2 points are very, very important. A patient comes to you saying that my crown has again fractured after you have placed the post. Now, what do you do? The site of fracture, if it is above the crown or if it is above the bone level or in the anatomical crown only, okay, or clinical crown only, then it is really very difficult to, very easy to place it again. Okay, you can do the core build-up again, you can modify the occlusion and you can place the same crown again. But if you are having a fracture below the bone crest, then it is difficult to restore. It is very, very difficult to restore it. You will have to extract the tooth only. Okay. So if there is a refracture occurs, the refracture in the metal post will occur always below the bone, wherever the metal post is ending. Whereas in glass fiber post, it is proven that the fracture will always occur above the crest of the bone. So it is very, to think like that, it's very easy. It is easy to understand that glass fiber posts are very, very beneficial to the patient. Okay. We see the disadvantage of glass metal-free posts also, and we'll discuss the same point again. Metal-free post. So you have resistance to corrosion and fatigue. There is no metal involved, so there is no corrosion and fatigue. The mechanical properties closely matches to that is your modulus of elasticity, the modulus of elasticity of denti, and of your metal fiber post is almost similar. So it flexes in a similar direction. You know that teeth are going to teeth flexes whenever you bite, whenever the forces are acting on, your teeth are flexing on. It is bonded, so becomes a part of tooth. So it is not a cemented restoration, it is a bonded restoration. Then it can be removed easily if fracture occurs. You have to just drill through it. But a metal post cannot be drilled through it. Okay. You have to use a lot of scaler and scaler tape. You have to really run down a lot many scaler tapes that you have to remove in anti-rotational direction if the serrated post and then try to take it out, praying to God that the tooth doesn't fracture. The fracture site is always above the bone now. Okay. So whenever the refracture occurs, it is above the bone level, it is not below the bone level, so that it can be repaired again. It is definitely a biocompatible material. Disadvantage. They have a lesser strength as compared to the metal post. The second point is important. Why? Because that outtakes them as an inferior post as compared to the metal post. Okay, this is my take. Okay. The potential to flexure of the fiber post on loading could result in cement lues or a bonding seal, which may result in secondary gearing. So whenever there is a fracture going to happen, so that time the bond easily. I was, I was a very good fan of the cyber post. I was placing this post for almost 4-5 years. I placed the post and suddenly I started seeing my failures that all my posts are, demanding and they're coming up. The carbon fiber post was indicated for the posterior teeth and glass fiber post was indicated for the anterior teeth. But when I saw that all the posts are demanding and they're coming out, I got to realize what was the reason. Then I saw this sign, the potential flexion of the fiber post on loading could result in a loss of bonding. Okay, so this is a major reason where your glass fiber post or carbon fiber post will fail. And if you are having an abutment for an SPD or an abutment for an RPD, I am sure that don't use this fiber post. They are not good. They are not good when you are using it in the abutment to any of the two, whether it is an RPD or SPD. Okay, so they are basically good enough for your anterior teeth where the forces are not going to be acting on. Okay, they definitely, glass fiber posts, they cannot be used in the old anterior abutment. Okay, I mean, no company designs it that way. Okay, so let's go for the fundamentals. So this is the typical diagram of a post and core. Okay, you have this line. Yeah, this is the post, and above it is the core. Okay, so it retain and support the core. That is the post role of a post, and it aids in transferring the functional forces to as wide area as possible. So whenever the forces are acting in this direction, okay, the forces are dissipated in all the teeth. Okay, whereas in the fiber post, what will happen? The forces will lead to breakage of bond between this area. So Engel, who started the first school of orthodontics in 1901, created a simple classification for crooked teeth in the late 1800s, a system still in use today. You know what is class 1, class 3 malocclusion? Okay. So now these, how it is related? Because the occlusion has to be considered while you are using it. Class 2, there are no forces. Class 1, there are no forces. Class 3, there are no forces. So when you are using the fiber post, you have to take them into consideration. Technique, you have a pin, you have a keyway, you have a ferrule effect, you have post diameter, that is surrounding diameter, how much surrounding dentine, how much is remaining around the post, okay, and then the post layer. We'll discuss in this diagram only. Okay, so this is the post which is going inside the canal, okay, and you have the pin here, okay. You can either take a pin or you can make a pin way for there, and you can, so that it makes it anti-rotation, it doesn't rotate that way. You can have a ferrule all around. We'll discuss the ferrule later also. Okay. All most important is you should have a crown which should be gripping over the post and core. Okay. So this part is really important, that a crown should be going below the post and core. Okay. Then post length and your diameter, that will be depending upon the teeth which you are having. Okay. But you should be below enough so that you can engage the length. But you should be above enough so that you can have enough of dentine surrounding the post, so that this area which is thin should not fracture. If this fractures, there is no point in using post and core. Okay. Now, if I compare between a natural tooth and just a tooth which is having root canal treated and a post retained tooth, which will be more stronger. Okay, there are so many studies done on that. They have just done a root canal to the anterior tooth, okay, and they have done a post and core, okay, and then they put a crown. They applied the post. What they realized is the tooth which was only endodontically treated was having good amount of strength to your fracture. Then the post retained tooth. Okay, so post and core should be judiciously used when you don't have enough of tooth structure to give a crown. That's the whole goal of the post and core. What is ferrule effect? We know that the log of wood is there, and if you have an X and it goes through, what will happen? You just split. If you have a ferrule around, okay, this is not going to split. That's ferrule. Okay. So you need to have a ferrule all around. So the crown is doing what? This crown is giving a ferrule all over 360 degrees. So when you have this is the yellow is the core, you have a post, but the crown is going below. Now how much is the thickness of this? This should be at least 1.5 mm. Okay, if you have 0.5 mm, also it is okay, but at some areas it should be more than 1.5 mm. Okay, so try and take the peru because that is at least required. Then second point is biological weight or dental complex, a very complex area. Biological weight, I'm sure that you must be knowing why it's called biological weight. It is called a biological weight because this area of dental gingival complex, okay, that was given by graduate tab, okay, I'll discuss this. If you have a gingival sulcus of 0.69 mm and a junctional epithelium of 0.97 mm, then the connective tissue is 1.07 mm. So now combined width of junctional epithelium and of your connective tissue is 2.04 mm. The moment you go inside that junctional epithelium, what will happen? The apical bone here, okay, this bone is going to get resolved. And this will resolve till the time from the base of sulcus to the stretch of the bone is at least 1.5 to 2 mm. So it is maintaining its width biologically. So that's why whenever you are going inside the sulcus, if I say that you have to go subgingivality, I mean, how much subgingivality you are supposed to go? I mean, that is a big question. And how do you place your margin subgingivality? Probably we'll see it next. I mean, sometime when we read next how to place your margin subgingivality. But when we say subgingivality, please don't try to go more than 0.5 mm in the sulcus. Please see the sulcus, the depth, evaluate the depth of sulcus with your periodical probe, and don't try to go more than 0.5 mm sulcus. And it is easy, just place the retraction cord there. Okay, retraction cord is going to retract, place your margin, remove retraction cord, record your pressure, that is how you go subgingivality. Okay, but if you go beneath that, if you go beneath the junctional epithelium, this biological width, this area of bone is going to get resolved, and finally what will lead to? You will lead to more width of the clinical crown. Okay, your clinical crown is going to increase, and or sometimes will lead to pocket also, which is not a good idea. So please respect the biological width. The third point, crown to root ratio. Okay, so whenever you are doing a posted core, we should have 1:1 ratio. You cannot have less than this ratio. Okay, you cannot have more of an anatomical crown than the root. Okay, so X and Y should be equal. You cannot have more than that. Now, if you have an inadequate tooth structure, if the ratio is not 1:1, then what do you do? Okay, so that's a bigger question for us. Okay, let's see what we do. When you don't have inadequate tooth structure there, you try to take out the tooth with an orthodontic movement. Okay, now this part is really very difficult because for orthodontist you will have to give us post space there. You will place a post there, then he'll put a bracket on the post. Okay, then he will pull out the tooth. That will take at least 3 to 4 months, or probably with a good technique also you can do it in 2 months also, depending on the patient and the condition of the bone there. But orthodontic force reduction have been a good successful technique. Secondly, crown lengthening procedure. You can lengthen the crown, but you lose what? You lose bone there. Okay, the root has not come forward. The root is there only. What you have increased now? You have increased the clinical crown. You increase the clinical crown means 4 factors have increased. Okay, so again it is done. It is again a good technique, but you need to have a crown root ratio has to be decided. Sometimes it has to be combination both. I'll show you a case of later on where I use the crown lengthening method. Very important point is which post we should use. There are a lot many posts which are available in the market, whether you should use the parallel post or you should use the tapering post. Okay, let's see this. Let's see this picture. Which is having more denting around it. Okay, this is having more denting around here, but sometimes the anatomical configuration is like that, where you have to go for a tapered post. Those are which areas? There are areas where the anterior teeth are there, your central surface. You have a taper, too much of canal taper is there. That time you really cannot go for a parallel post. Okay, if I have to make this, if this is the canal, if I have to make a parallel post, how do I make it parallel? I have to cut more into, I have to go more aperture to make a retention of the post. Okay, so post and core in these kind of very decisions, try to go for a parallel post, but If you don't have parallel post, if you have not many taper, then your choice of going for a glass fiber post, but that is only in the anterior region, not in the posterior region. This will happen if you have a post in core, okay, which is not having a ferrule and having a tapered. So tapered post can create a wedging effect. Okay, I mean tapered post along with the non-ferrule will have a wedging effect like what we discussed before. You have a log of wood and we put an axe to split. Okay, so try and avoid the post which is tapered and without the ferrule. Post and core procedure. Okay, you have these kind of flow chart. We'll discuss them. So this is the post which we have placed. First of all, what you are supposed to do. This was the existing crown which came off when patient came. Okay, so we just take this, and then what we did was we did the electrobody. We remove this much of part. The thing changes. The thing really changes before this and after this. The crown is now we can see the clinical crown. We can place a post. We can place a crown on this. Okay. So clinical case of prefabricated parallel post. So this is the area through the root canal done. Okay. There was a GP was removed using a GD. Okay. And then you have those sequential post-based preparation. You try and leave at least 3 to 4 mm of gutta percha apical. At least 3 to 4 mm you have to leave it. Okay. If you leave more, that is good. I mean, there might be cases where you have a longer length of root. Okay. But if you leave more, you have good amount of dentine around it. So how much depth you go, it is not a rule that you should go for 4 mm only. You can leave 6 mm also. If you are happy that core factors are not going to exist. Okay. So at least 3 to 4 mm post to gutta percha, that is the minimum, not a maximum. Okay. So 3 to 4 mm GP should be saved behind. Okay. And you see the ferrule. The ferrule is again how much? It is 1.5 mm. So you have made this post space. You do the trying. This post trial is done. After that, the keyway is definitely made. The keyway is only as a key for the it is aiding in anti-rotational feature for us. So that post and your core doesn't rotate. Now this is the rinsing and drying of the cavity. Whatever we made, this is the absorbent point. Okay. And after that, just use it with the lenticular spiral. You can use that clockwise, anti-clockwise, whatever your choice is, or you can sometimes use the absorbent point only and just take it and just snap it over. The post, putting the post in the cement and then putting the post inside the canal and then building up the post. Okay? So this is how. This is again a clinical case of a defective bridge. Remove that. And then again a core builder was done. This post-op radiograph. Now steps for custom made post. The custom made post, you really cannot avoid it sometimes. If you have too much of taper, okay, and posted piece is there, and there is too much of taper, you don't have choice. You cannot go for a class fiber post. You have to go for a custom made post. If there is a lot of taper, which I told you, okay, and you cannot make it parallel. Just cannot make it parallel because canal configuration is not like that. Okay. So how do you make it? I have just depicted and show you the later on the cases also. So you just prepare the tooth, okay, remove the GP, okay, put a any post which can be a zero-free emission, okay, where the post will be when you are putting it to the front end, there will be no residual left, okay. So you can put any kind of post, you do a build up with the resin, okay. Now this is again a resin which will not have any residue. This is like shofu, where you have post. So you have taken it out, okay. You have a direct casting technique again, where you prepare the post space, okay. You prepare the canal, okay. You place the post, you make it impression, you go for a casting, you get the post, you cement it back, you put a crown. So that is the direct casting technique. Post space preparation, keyway, direct backup, provisional crown and put the temporary post and a final casting crown. So this is again a technique where post, we build up the core, you shape it, you can cut and prepare the patient mouth. This is pattern breathing. Pattern breathing can be easily prepared in the patient mouth. Okay, take out the entire thing, go for casting. After the casting done, just cement it to the patient mouth. Okay, and give a crown on it. Indirect casting method in which you will have to make the impression. So you need an impression post for this. Okay, so there are direct technique, there is a indirect technique. Indirect technique, you again make a post paste, you place the impression post, and then you spread more impression. Okay, so you make the impression system. Okay, then you pour the cast. Okay, and then you wax up this all the entire thing on the cast. This is wax up. Okay, this is a wax up with the burnout post, and then the casting is done. So post wax up is done where it is done on the cast. So it is done indirectly. That's why it is called as indirect technique. So this is called a burnout post, which will have a residual, no zero residue when you are doing a burnout. Because at higher temperature, if it is leaving a residue, your post, whatever metal is going inside the furnace or in the mold cavity, will get affected. The stress will not be enough. Okay. So this is a temporization post or temporary posts are there, not much in India. These are the aesthetic posts. Okay. We have already discussed, I will not go much in detail. But here I really you can appreciate the left side post and the right side post, which is more darker. The metal post is more darker than the glass fiber post. Okay. So when you are giving an anterior teeth, when you are restoring the anterior teeth, this inside is really very, very important because you have done a very good shade selection. Okay, you have done a shade selection of A1, and now you have zirconia crowns. But zirconia crown, lot many people are fans of zirconia, but as a professional, we are fan of EMAC. Okay, that is pressable ceramic. Pressable ceramic doesn't give you any kind of warranty, but zirconia gives you warranty. But what is the disadvantage of zirconia? Any zirconia, any ceramic crown giving you more amount of strength will be opaque. So zirconia in the anterior teeth will give you lot of whitish appearance in comparison to your natural teeth. So always go for EMAX crown. But EMAX crown has a chameleon kind of effect. Okay, what will happen? Whatever is inside, it will reflect outside. So this white is inside, the white will be reflected outside. If there is a dark inside, it will be dark outside. Whatever shade selection you have done, it will be more darker. Okay, so that is a now they have again started they have also started using opaquer and all those things there to give the result. But still, if you are using a EMAX restoration, okay, go for a glass fiber post because if you are using a metal post, that inside back is you will not give you good result. Okay, now the ginjava, sometimes there is a thin ginjava. The ginjava prototype is thin. What happens with that? If ginjava prototype is thin, in the root area, the show through of metal will be there through the dentine. So if you place a fiber post in that area, the ginjava in here will not be seen as a dark if you place a fiber post. So go for the glass fiber post in the anterior tooth. So this is one case. This post is prepared. GD and your piezo's, trial of post. This is paracode system. Okay, so you ask for 15 seconds. You have a paracode, they have addition, conditioning, they give you material like that. Okay, just place it like this. The same material is being used for cementation of post also, and the same material is being used for build up of core also. Okay, this is post paste, and after that you inject that. These are core formers are there. This can be used. Okay, they have a technique. Okay, this is how the core is formed, and a beautiful, preparation is there. And you can give a good temporary, cool temp temporary are there. This is pre-op and post-op. Again, a glass fiber post. Okay, the entire procedure in one of the posterior teeth next to the implant. Okay, this is one of the cases. I am ending up with this two cases that good enough. Here you see the crown length is enough. Well, they are not enough, sorry. The crown length is not enough. Okay. Patient has reported like this to the department. We did the post-it course. This is the build-up which you have. Okay. We were not happy with the crown length. We were not happy with the crown length. We were not happy with the gingival width. Again, you see this gingival genic is unequal. Okay, the genic is unequal. Okay, so here the length is more, here the length is less. Okay, so we did a cautery. Okay, we created equal length on all 4 teeth, and then we placed the post. Okay, and we gave a crown. So this was the post place which was prepared in all teeth. Okay, and this was post done. Now in this area, if you see, I had enough of length of the post only. I didn't need more length. So we left it more than 5 to 6 mm of length here. So it's not required that you go for the entire length of post. Okay, this is one beautiful case of posterior teeth. Anyone could have asked for an extraction of the same tooth. It's difficult to restore otherwise. Okay. So what we did was we did a split post in the metal. We can do a split post. So we placed the medial buccal canal, we placed on post, and on a distal canal we placed on post. So we placed the post, and here you can see there is a step. There is a step here. Okay. So next post went in this canal, and core was built up till here. So this is how the second post was placed. Now this is basically of your toothpick. Okay, so we just placed the toothpick and the pattern as if we did it. This is how this entire thing was done up. And you can see the split between 2 posts here and here. Okay, and then they were taken out separately. Now you can see the split here. There is a split, and the other part, the other side part, will go and sit here. Okay, so it's like interlocking. This was the casting done, and this was the entire post and core which was completed. Okay, so we did what? We did bracket mix to cement both the posts, plus and the areas which are left, that was used as a core builder. Okay, and this was the pre-radiograph, and this is after preparation. You can see this one canal. Medial buccal canal is used because that was the white canal. Distal canal, medial lingual canal was not touched. Okay, so this radiograph here taken so that you can see all 3 post space. All 3 canals just for depiction. So one canal in a place. Okay, it seems that other canal will not go. Okay, I'm sorry. Yeah. You see that the second canal there is no space, but you remember this is a 2-dimensional, depiction of a 3-dimensional thing, your radiograph. Okay, so this is the placement of the second post. Okay, and it is interlocking. Then you did the build-up, and this was the crown. Okay, so thank you, and I'm ready to take the question. No, ma'am, it wasn't raised because you can raise the bite only if it is required. I show the picture of the case directly. It was not required, ma'am. I'll show you now. When we prepare, that time you see. When we took the Niswanga technique, ma'am, there is no space which was left. We could raise the slab. You cannot just, raise the, if Niswanga technique doesn't allow, if it is not allowed, we cannot go for it. So this is what we did. Pardon? We make it, there was no old jet that time. Now we make the old jet. That's why we lengthen the ground.
But when the patient is incising, that time there will be no contact on the posterior.
There will be contact on the posterior, definitely. That is the rule.
No, but
See, this is the condition after this, after we did that. So your posterior teeth patient wanted to go for anterior only. Okay. So this is how we did it. No? Why? No, because we have in moment. We did the electrophysiology was not done for upper, it was done for lower also. Okay. I knew this is the controversial one. I'll show you the last ground pictures. I'll show you, so that time you'll be more happy to do it. If I get those ground pictures in this. Yeah. Yeah. You tell me now. Where is required? When posterior discrimination will occur. Which one? When you no, what will striking? When you strike? They will be striking, that is the rule. Our speak of the strike, sir. No. No. Let me tell you. When you protrude, your anterior teeth are supposed to meet and posterior distribution has to occur. Okay, that will happen. Okay, we planned this case on a semi-anterior attitude. Okay, so believe me, if you are saying that we didn't maintain the overjet, we maintained good amount of overjet and overbite. Without seeing semi-anterior articulate probably you cannot do that. I'll take your mobile number and send you the WhatsApp number. Okay. This is how we maintain the lower height. They were all middle ground. So we didn't give you good overbite because we maintained the lower. That's why we did the ground dancing for the lower ones also. This was a trial procedure. I'll show you one more picture here. Yeah. So if you see here, we have hardly a overbite of 1 mm. We have hardly a overbite of 1 mm. Okay. And we have increased the overjet. What will happen when you have less overbite and you have more overjet? What will happen? That striking what you are calling will not be there. Ma'am, when we show you the picture again. Yeah, you see here. Now, if you see this picture, you can normally make it out very easy to make. You see this, sir. If you see this picture, when this is just before giving a temporary, I could have incised more and given you good amount of overjet and overbiting.
So we discuss this on the first
100%. Now I'll show you more cases of this kind where you'll believe that where the space is gone. I can show you those kind of cases also where there was full diastema is there of one finger. Okay, I have not placed the single tooth, but the diastema is gone. See that?
We will discuss this on a personal.
Sure. But I would like to show that. Miracles happen when you have good prosthodontists, sir. Yeah. Didn't go for anyone. It seems like, na? The vitality was there. Don't do anything. This is a very old lady from Belgium. She came to me for the treatment and she required a lower denture. So we placed the lower denture. She came back after 2 years in 2016 just before demonetization and she was not happy with the anterior teeth. So you one more case. Okay. One more case for you. This is again postman got treated. Okay. This was my failure of a lady. Orthodontic failure. This was a final process. I wanted to do a root coverage, but patient was not happy. Now the patient looks her age. So, and many cases are available. Any other questions? I know my seniors will give me. My juniors should give me others.
Thank you, sir, for this wonderful lecture. Again, we would like to welcome Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir for the felicitation of Nikhil Verma sir. Please welcome us. Along with them, Dr. Yash sir. Come on, people, clapping should not stop.
After so many lectures, they are sitting here. That is to be appreciated. Okay.
One hour of class audience.
Put your hands together for yourself. Thank you so much, sir and ma'am, for this wonderful honor. Now, for our next speaker, we will be learning about how to and how not to submit biopsy specimens from Dr. Shalin Chandra, Professor and Head of Oral Pathology and Microbiology in King George's Medical University, all the way from Lucknow. A huge round of applause for Dr. Shalin.
सेट कर मेरे भाई थोड़ी फ्रेम बनी जगह छोड़ी મને બંધ કરીને ચાલુ કરો જલ્દી વપરાય શું છે આમ કાઉન્ટમાં બે આ તો
Good afternoon. Good morning. Good morning. So good afternoon. I'll be speaking about a little bit extension of what my teacher told you about lot of lesions in oral pathology. This will be an extension to that. A little bit was already covered. However, I'll be covering and skipping the parts which have already been covered. So, how to and I'll be talking about what mistakes not to do and what to do when submitting a biopsy specimen, and also a little bit about how to take biopsy for special cases, because some cases warrant different techniques while taking biopsies. I'm Shalin Chandra. I'm working as I took my graduation from KG Medical University, KG Medical College at that time, and I did my post graduation from STM College of Dental Sciences. Right now, I'm heading the department of oral pathology at KGMU. So, pathology is the trunk of tree of medicine, because whenever a clinician gets stuck, they will be sending it to us for pathological diagnosis. It may be clinical, it may be histopathological, it may be even advanced like molecular or proteomics or genomics. So, forensic pathology and cytopathology, hematopathology. On the left side, I have put the traditional branches. On the right side are all the modern branches: proteomics, genetics, immunopathology, and molecular pathology. However, they all rely on ultimately histopathology. Now, for histopathology, we need something which is to be supplied by a clinician, known as biopsy. Without a biopsy, there cannot be a histopathology. Because biopsy basically is when you take out a small bit of live tissue, and then you send it across to us. We treat it with some chemicals so that it becomes stiff, and we can cut a section of that, and then we see it under a microscope to see what is inside. Now, biopsy is not autopsy and not cytology. Cytology does not consider qualified to be biopsy. Cytology is just a scraping of tissue. However, we do receive biopsy specimens which look like a scraping. I'll be coming to that later on. And autopsy is when we do it in dead people, in a corpse, in a morgue. Actually, it is done in forensic pathology department. Now, indications for biopsy: any lesion persisting for more than 2 weeks has to be biopsied. However, there should be no apparent etiological basis. That is, if there is an irritating tooth causing an ulcer which is not healing, then that doesn't need to be biopsies unless you have removed the irritation. The irritant has to be removed first. That's why the second point, any inflammatory lesion which is appearing inflammatory. Inflammatory means, what is an inflammatory lesion? Any red lesion is most probably inflammatory and very less chances of becoming its being a malignancy. First instinct should be an inflammatory. If it does not heal after the removal of local irritant in 10 to 14 days, then we need to do biopsy. Second, any hyperkeratotic surface change. That is, any white lesion which is having excess of keratin, then you need to do biopsy. Then any lesion which is interfering with local function, like swelling on the lips, swelling on gingiva, swelling on cheek, example fibroma, papilloma, then we need to do biopsy. Then lesion where differential diagnosis will affect the treatment. Before my lecture, a lot of lesions were covered where biopsy is not required, because like pemphigoid and pemphigus, the treatment is same. We give steroids. However, if there is a possibility that there may be some other lesion apart from these two, then to differentiate, we need to do a biopsy. Then any lesion which may have characteristics of malignancy. Here I would like to discuss some of the characteristics of malignancy. First is erythroplasia, that is a red lesion. A white lesion has less chances of being malignant. A red lesion or a speckled lesion has more chances of being malignant. Then ulceration. Any ulceration, again not healing, needs to be biopsied. Then growth rate. If it is having rapid growth rate, then we have to biopsy. If it is having slow growth rate, we may wait and watch for some time. Then bleeding. Any lesion bleeding at gentle palpation is a warning sign. There is something wrong with the tissues. Then induration, that is lesion in which the lesion and the surrounding tissue is firm to touch, then there is something wrong. Or the lesion is fixed to the adjacent structures. You cannot move the lesion. If you do how do you check whether the lesion is moving or not? You have to do a bimanual palpation in case of oral cavity. You wear gloves, put one finger inside mouth, try to hold the lesion between your two hands. And then if it is moving, then it is not that dangerous. If it is not moving, it is again fixed to the underlying tissues, then it is a dangerous lesion because it is invading the underlying tissues. Invasion means malignancy. So methods of biopsy: scalpel biopsy, gold standard, supposed to give the best results. Then there can be cautery, there can be laser. Cautery and laser, for your information, are not recommended for diagnostic biopsy because cautery as well as laser will actually boil the tissue just adjacent to your blade. Okay. So it will give a false histopathological picture when we see it on the slide. So please avoid cautery and laser for the diagnostic histopathology specimen. However, if you are doing a total excision, then you may go ahead and use a cautery and laser, because in that case we will get some main tissue in the center to give you a proper diagnosis. Then removal by biopsy punch. My old medicine colleagues have gone Dr. Srinivasan, but biopsy punch is not very standard because unless you are using a punch of at least 5 to 6 millimeter diameter, we will not get any tissue to give you a diagnosis, because using a 2 millimeter punch will give us a tissue in bottle which will be around 1.5 millimeter in size, because there is shrinkage and so many changes in tissue which take place. So it will be very difficult to orient and check what it is. So if you are using a punch, please use a punch at least 4 to 5 millimeter diameter. Then curettage, aspiration through needle, and scraping of surface for cytology. Then scalpel biopsy, best method is to just skip 1, 2 things. Yeah. Types of biopsy. One is excisional biopsy and second is incisional biopsy. I will be discussing a little in detail about these two. That's why these are a little highlighted. Excisional, when you remove the entire lesion. Now, when you should remove the entire lesion? When you are 100% sure what is the lesion. Like in case of fibroma or a papilloma, you can almost clinically decide that it is a papilloma, it is a fibroma. You don't suspect any malignancy associated. Then you can go with an excisional biopsy. And while doing excisional biopsy, always try to remove at least 2 to 3 millimeter of normal tissue surrounding the lesion. It's very important, because if you are not able to remove the full surrounding lesion, then it may recur again. Even papilloma can recur if you are leaving some of it behind. Then incisional biopsy, also called as diagnostic biopsy. I would like to give a little pointers about incisional biopsy. When to do when the lesion is too large and you are not sure about diagnosis, or when the diagnosis will alter the course of treatment, then you have to do an incisional biopsy. Then different location have different characteristics. Now in such lesion, actually you should be doing multiple biopsy of different locations. Then a lesion which is suspected of malignancy, never try to do excisional in first go. Yeah. Principles of incisional biopsy. Principles of incisional biopsy, आप लोगों को सबको oral pathology और general pathology में पढ़ाए गए होंगे. Always include part of normal surrounding tissue. आधा incision lesion के अंदर, आधा incision lesion के बाहर, so that you include a part of surrounding tissue. Or I'll be adding a little bit to that. Apart from including half of normal and half of abnormal, you should also be focusing on the depth of lesion. And depth should be a minimum of 1 millimeter. However, this 1 millimeter is not always fixed. There are cases where this 1 millimeter is to be altered, and there are cases where the biopsy should not be taken from main lesion. I'll be coming to that. Like in this slide, you can see here in this area we can see some necrosis taking place. So this is a wrong biopsy. Necrotic tissue will not give us any result. So we have to take a biopsy where necrosis is minimal so that you get a proper diagnosis. And always include a part of normal along with abnormal and try to reach the full depth to include some connective tissue. You can see this. This is one incision, this is another incision in which we are reaching the full depth. Then it is not important to take a huge bit of tissue and not reach the depth of lesion. This is undesirable. Rather, a narrow incision having a full depth is desirable. Then some clinical considerations where biopsy has to be given proper due so that you get a diagnosis. Like vertebropapillary lesions, like your verrucous carcinoma. Now, verrucous carcinoma we all know has lot of keratin on top. It looks in histology something like this or like this. There's a lot of keratin. After this, I am going to put up a biopsy specimen of verrucous lesion received by us. This is a lesion. If you see on the scale, the lesion size is almost 2.5 millimeter height wise. And if you see the this is your junction of epithelium and connective tissue. Now, epithelium and connective tissue are located at 17 mm from top of the lesion. So, if we stick to the regular biopsy in which we take about 1 millimeter of depth, 1 centimeter of depth, then we will be reaching only till here. That is just the keratin. So, always see what tissue you are biopsying and try to reach at least the connective tissue. Because what we have to see in verrucous lesion or verrucous carcinoma, that there is no invasion of connective tissue. And if we don't get connective tissue, then we will not be able to comment on invasion. Because verrucous carcinoma treatment is easy. Local excision. No requirement of any neck dissection, nothing great is required. Just local excision with white margins is enough for verrucous carcinoma. However, if it is reaching the connective tissue, then the approach is totally different. We are actually going to treat it as a squamous cell carcinoma. So, always try to include some of the connective tissue in the biopsy. 1 centimeter depth is fine, but it is not always true in all the lesions. Next, lesions with heterogeneous surface characteristics. Now, this lesion has whitish appearance here, reddish appearance here. So, if we take a biopsy of 1 centimeter size, then it will not include the reddish area here. So, we have to take a biopsy. This is a wrong biopsy, okay? Because we are just seeing the white area. I already told you, the red part is the dangerous part. So, we need to focus on the red part also here. So, how we should take biopsy? To include red, white as well as the normal tissue. This is the right approach. Now, how to see whether what I said was right. ये same lesion का हमने एक और टेस्ट किया है just for your clinical confirmation. सबको मालूम होगा कि प्रीमैग्नेंट लीजन में डेंजरस पार्ट देखने के लिए कोई डाई यूज कर सकते हैं क्लिनिकली. Anybody answer that? Toluidine blue. We can also use glucoside in case toluidine blue is absent. Now, we have done toluidine blue. You see, all the toluidine blue is taken up by the red parts, not by white part. And this is the part which we wanted to see, not this part. Okay. So that's why the biopsy has to be done from the center of the lesion to include the red part. Another lesion having heterogeneous appearance. So, please do 2 biopsies instead of 1, so that we can see the whole picture and give you a better diagnosis. And one more thing important for present and would-be oral surgeons: please send these 2 tissues to same laboratory, not to 2 laboratories, because we as oral pathologists suffer a lot because we receive specimen from oral surgery. एक स्पेसिमेन निकाला 2 सेंटीमीटर का, उसका आधा भेज दिया एक पैथोलॉजी में, आधा भेज दिया मेरे पास। मैं देता हूँ डायग्नोसिस नॉर्मल टिश्यू, वहां से डायग्नोसिस आती है स्क्वामस सेल कार्सिनोमा। नाउ सर्जन इज इन द लर्ज, व्हाट टू डू? जब आधा मेरे पास भेजा है, मेरे पास नॉर्मल टिश्यू भेजा है, तो मैं नॉर्मल रिपोर्ट करूंगा। I don't have vision to see the slide what you have sent to the other pathology. So please send the whole tissue to one pathology. If you believe in me, send to me. If you don't believe in me, send to the other one. At least let him be happy. Okay. Okay. Now a little point about vasculobullous lesions. Vasculobullous lesions में कौन-कौन से आते हैं, नाम बताओ? Go say. Pemphigus, pemphigoid. Okay. So, what is important about pemphigus and pemphigoid? Pemphigus and pemphigoid and vasculobullous lesions are diseases where there is ulceration on oral mucous membrane as well as skin. But why does the ulceration occur? Ulceration occurs because of separation of epithelium from underlying tissue. It may be subepithelial or it may be intraepithelial. Now, if we want to see where is the split, if you take a biopsy like this, like it is recommended for an ulcerated lesion, then what we will see? We will see an ulcer, and southern surrounding area we will see some inflammatory tissue with lot of blood. Okay, nothing else will be seen. So we have to take biopsy not from here, but rather from perilesional tissue. Lesion के surrounding tissue से हमें biopsy लेनी चाहिए when we are sure that it is a vasculobullous lesion. Another logic why it should be taken from surrounding tissue. Nikolsky's sign पढ़ा है? Where it is tested? In the ulcer, in the area surrounding the ulcer, because that is the area where the split has taken place. तो जब हम वहाँ पे स्किन को lateral pressure लगाएंगे या mucosa को lateral pressure लगाएंगे, there will be separation because inside there is already separation and there will be ulceration. Sorry, not separation. So that is the logic why the biopsy should be taken from the perilesional area, not from the lesional area. Now, considerations before performing biopsy: medical history and investigation. Investigation for 2 reasons. One, for your own sake, because a patient may be having some bleeding disorder. So if you are not done the diagnostic investigations, you will end up in problem after biopsy or during biopsy. Second, investigations for your safety again, because if the patient is diabetic or suffering with some systemic disorder, then you need to know that before doing biopsy. History, so that you know the patient is not on any bleeding कब ज़्यादा होगी? Any antiplatelet agents, any antiplatelet like ecosprin. If the patient is on any antiplatelet agent, you don't want to do the biopsy because who will control the bleeding after that? Then correct armamentarium is there, consent should be there, and there should always be. Hello. Yeah. There should always be provisional or differential diagnosis present. You can have 3 diagnoses, no problem, but try to make a provisional diagnosis. Yeah, try to make a provisional diagnosis. Then care should be taken while doing biopsy. Don't use tooth forceps. आर्मामेंटेरियम की लिस्ट में हर किताब में टूथ टिश्यू फॉसेप दी हुई है बायोप्सी के लिए. लेकिन जब आप टूथ टिश्यू फॉर्सेप्स से पकड़ के बायोप्सी का टिश्यू खींचते हैं तो एक्चुअली व्हाट यू सेंड अस इज अ मेटसेलेटेड टिश्यू पूरा क्रश हो जाता है. So instead of that, a better method is आपने एक बार इंसिजन लगा लिया, take the needle and thread, and even needle and thread आपके पास रखा ही होता है, put a thread in the tissue, pull it with that and complete the incision and put it in the bottle along with the thread. ठीक है? So tooth tissue फॉसेट की जगह आप thread यूज करो. Then handling of biopsy specimen. Now, as soon as the tissue is removed from oral cavity, two things can take place. If it is fixed in fixative, that will start absorbing the fixative and start getting fixed. If it is not get put in fixative, then what will happen? क्या होगा अगर fixative में नहीं डाला है? What happens after death? Putrefaction. Tissue सड़ना शुरू हो जाएगा. So that is why always it has to be put under in a fixative. The standard fixative for routine is 10% neutral buffer formalin. Now, what to do if formalin is not available? What are the options? Only one option. Only one option, no other option. Saline doesn't work. If you put in saline, what will happen is we will get a bloated tissue, having a lot of fluid inside. So all diagnosis will be impossible. However, for some cases, some particular cases, special reagents are required. Like, you use Michel's for fixative for particular cases. If you want to do immunofluorescence, because if you do immunofluorescence on a formalin fixed tissue, then what will happen is there will be lot of extra fluorescence because of formalin. Then handling of biopsy specimen. Now, if it is a large specimen, don't try to put it in a small necked bottle. Ideal volume of specimen bottle is at least 10 to 20 times of the size of a specimen. Because as the specimen starts absorbing formalin, the formalin content goes down in the surrounding fluid. तो अगर आपके fluid कम होगा, formalin कम होगी, तो tissue fix नहीं हो पाएगा. And if you are then sending a large piece of tissue, then try to put some incisions in it so that formalin reaches deep inside. Like this is a huge tissue, you can put incisions in it like there are incisions in the bread. So loafing can be done so that adequate volume of fixative can reach the depth of tissue to prevent putrefaction. Then tissue should not be allowed to dry. अपने ओटी में हमारे यहाँ जो ओटी है उसमें मैं बोलता हूँ जब कभी रिसेक्शन करो तो हमारे यहाँ से एक रेजिडेंट को बुला के खड़ा कर लो, आप निकाल के देते जाओ, हमारा रेजिडेंट जो है उसको फिक्सेशन के लिए रखा जाएगा. बिकॉज वरना क्या होता है, सर्जन जो है निकाल के उसको रखता जाता है, usually on a gauze piece of gauze or in a tray, and the tissue keeps drying. So my resident will go and take the tissue as it is removed and put it in fixative in different bottles. Then specimen collected from different sites should be there in different bottles. I received tissue from left buccal mucosa and right buccal mucosa in same bottle. Even today I do it. I do receive it. I don't know how to guess which is left, which is right. Because now, if there is squamous cell carcinoma in one tissue and just leukoplakia in another, how do I communicate to the surgeon which side is carcinoma, which side is not? So always put different site of biopsy tissue in different bottles. That should be stored in room temperature, refrigeration not required. And before putting them in bottle, especially for large tissues, always tag. Tagging is done in two cases. One, when there is a large tissue and you want us to orient so that we are able to give you a proper report. Single suture for lateral margins and two suture for the caudal, that is posterior margins. This is the industry standard. Another thing where tagging is done, which is not there on this slide, when you are doing a resection, that is block dissection of neck, then you dissect the chain of wall layers, like then level 1, level 2 lymph nodes should be marked with 1 knot, 2 for 2 knot, 3 for 3 knot, and 4 for 4 knot, so that you know exactly till what layer the malignant cells have spread, so that you can know whether the excision is complete or not. Then a word about biopsy of container. This I have actually already covered, so I'll just skip it here. This is not a biopsy container. Don't send tissue in a polythene, okay? Because there is no way it will hold 10 to 20 times formalin. And this is also not a biopsy container. We are lucky we live in India, where we have a flourishing kebab business. Okay? Give this to Kabadi. He will be happy to take it and give you some money also. So please, and from that money you can invest in containers like this, which are in market sold as urine bottles, urine sample bottles. 100 ml and 50 ml is easily available. Okay. So store in these. Seal should be good, should not be leaking. Because if it is leaking, two things will happen. Your label will get destroyed and your tissue will get destroyed. Because tissue will get destroyed because fixation will not be proper, because half the formalin would have leaked. And sometimes we may even lose the sample in case of leaking tissue and there is scraping. Transportation, put the bottle in a huge container. Right now we are getting so much food from outside through Swiggy and Zomato. We get a lot of containers like this. So use these and pack it properly with some paper, loose paper, and then send it. Now paperwork should never be put in the same container. Put it in a separate plastic bag. Otherwise, we get labeling like paperwork like this, in which half the content is ineligible. You cannot read it. Okay. Then labeling. What should be labeled? Name, age, sex, OPD number, registration. Very important in today's time where NATH and NAC are there. So in OPD, case of OPD number, what we have now is क्या होता है हॉस्पिटल में? OPD number नहीं होता है. OPD number used to change with every visit of patient. Patient आज दिखाने आया नंबर 1 होता था और 1 साल बाद दिखाने आएगा नंबर चेंज होता था. और अब नंबर चेंज नहीं होता, उसको क्या कहते हैं? UID, यूनिक आइडेंटिफिकेशन. हम लोग यूनिक आइडेंटिफिकेशन प्रोवाइड करते हैं पेशेंट को, जो कि जितनी भी विजिट होंगी उसमें सेम रहेगी. एंड इट इज यूजुअली लिंक्ड विद पेशेंट सरनेम एज वेल एज मोबाइल नंबर एज वेल एज ईमेल. तो अगर पेशेंट आता है तो उससे मोबाइल नंबर पूछा जाता है. मोबाइल नंबर पंच किया, यूजुअली पुराना रिकॉर्ड निकल आएगा. देन देयर शुड बी कहां से निकाला, anatomical site of specimen. Then date of biopsy as well as date of dispatch. Because कई बार होता है बायोप्सी निकल के टिश्यू पड़ा रहा बहुत टाइम तक एंड आया हमारे पास 3 महीने बाद. ठीक है. सो डेट ऑफ बायोप्सी एज वेल एज डेट ऑफ डिस्पैच. रिक्वेशन फॉर्म पे क्या होगा? फुल नेम ऑफ पेशेंट, एज, सेक्स, रजिस्ट्रेशन नंबर, स्पेसिमेन साइट एंड पर्टिनेंट क्लिनिकल इंफॉर्मेशन, दैट इज हिस्ट्री. Along with that, what is usually missed? मेरे पास जितने पेशेंट बायोप्सी रिक्वेशन फॉर्म आते हैं उसमें लेफ्ट पार्ट तो काफी कुछ होता है till last but one point. Okay, but ये टोटली मिसिंग होता है क्योंकि बायोप्सी निकाली कंसल्टेंट ने, उसने बोला JR3 को या सीनियर रेजिडेंट को ये बायोप्सी यहाँ भेज देना. ठीक है. उसने बोला JR1 को, JR1 ने अपना नाम लिखकर बायोप्सी भेज दी. Now if I have some confusion, I have to ask my JR1 to contact that JR1 to find out who was the surgeon. And then I have to call up the surgeon कि ये problem है इसमें, इसका क्या करना. And it happens quite often. It happens quite often that we have to contact, especially because many times आधा tissue हमारे पास आता है, आधा जनरल रह जाता है, तो अलग-अलग रिपोर्ट होती है. So we need to contact the surgeon. So please put your information. Don't be scared. We are not going to penalize you or demean you in any way or show you in bad light. We want to contact you in case of any confusion. So put your full information. And in this, I would also like to add your mobile number in case you are not regularly referring to me or to your pathologist. So this presentation came to you from King George Medical University. This is the picture of our administrative block using some function because there is some red cloth there. And thank you very much for patient listening. Any questions I can answer? No questions? Then I was overly lucid in my presentation. Thank you.
Thank you, sir, for sharing your knowledge with us. One woman can make a difference, but together we can rock the world.
So now, introducing an inspirational individual among us, one of the most renowned person in dentistry, who has paved a way for other women. She is a professor in Department of Endodontics, also from King George Medical University, Lucknow. A huge round of applause for her. Dr. Goenka.
મેડમ છે ચલો બધા ખાલી જમ્યા શું યાર 1 વાગે
A very good afternoon to all of you, and I thank you, the organizer, for inviting me as a keynote speaker here. As we all know that being an endodontist, doing a root canal treatment is an easy task for us. But sometimes we also face problems and we may lead into a dilemma what to do and what not to do. So today my topic of presentation is endodontic emergency and endodontist dilemma. I myself, Dr. Promila Verma, from the Department of Conservative Dentistry and Endodontic, King George's Medical University, Lucknow. It's all about pain and swelling. There is a line in Davidson, the book of medicine. He says that the pain brings the patient to a doctor. And yes, he's right. If the patient does not have any pain or any swelling, he will never approach a clinician. It is the pain and swelling or any discomfort which will bring the patient to a doctor. So what is an emergency? An unforeseen combination of circumstances or the resulting state that calls for immediate action is an emergency. And endodontic emergency is defined as an unscheduled visit associated with pain or swelling ensuing from pulpoperipheral pathosis requiring immediate diagnosis and treatment. Now, before going with detail of endodontic emergency, let us first classify what are endodontic emergency. Endodontic emergency classified into 3 parts, that is emergency arising before the initiation of this treatment, during treatment and after treatment. Before treatment, the patient may approach to you for pulpal pain of reversible pulpitis, versus irreversible pulpitis, acute periapical abscess, or crack tooth syndrome. During treatment, maybe a patient may complain of the recent restorative procedure done or periodontal treatment, exposure of the pearl during endodontic treatment, fracture of the root or crown, pain as a result of instrumentation, acute apical periodontitis or pharynx abscess, and post-endodontic restoration may be high restoration, maybe overfilling, underfilling, or root fracture. So when a patient comes to you, first of all, we must inquire something from the patient that what is the nature of the pain, when did he notice the pain, at the what is the description of the pain, whether it is a lacerating pain or a pulsating pain, under what circumstances does this pain occur, that is on while eating or while taking a cold water or while lying down, you should inquire all this. Does anything relieve it, any analgesic or any other method that he get relief from the patient, any associated tenderness or swelling, and previous dental history is must. Now let us take the first, the before treatment, it must be a acute periapical abscess. What is acute periapical abscess? It is defined as an inflammatory reaction to pulpal infection and necrosis characterized by rapid onset, spontaneous pain, tenderness to pressure, pus formation and swelling of the associated tissue. So what are the signs and symptoms with the patient? You will find there will be a pain on biting, percussion and palpation. There is no response to the pulp vitality test. Varying degrees of mobility will be present, varying degrees of associated swelling. The patient may be in a debilitating condition. There will be enlargement of the cervical lymph nodes or submandibular. And on radiograph, we will see the binding of the periodontal ligament. The first and the primary goal of acute apical abscess in the management is that you have to first do the drainage of this abscess. That can be achieved by opening the pulp chamber. And if the drainage is not immediate, that you should perforate the apical foramen with the help of a 0.8 or 10 number 5. But you should not widen the apical foramen. If abscess is in the form of a subtissue swelling, then you should palpate for the most fluctuant point and do an incision so that drainage can be established. Sometimes if the pulse is not image, take the shape of a cellulitis, that you should always try to refer the patient to an oral surgeon. Don't try to do yourself. It will be better if it is handled by an oral surgeon. Before further instrumentation, the pulp chamber should be thoroughly irrigated with a solution of sodium hypochlorite. Debridement of the canal should be done, plus canals dried with paper points. I stress that it should be dried with the paper points and dry with sterile cotton wool pledgets in the pulp chamber. The SS cavity is the never open, make the cavity open. So if the complete debridement is not possible, then you should recall the patient within 48 hours, and by this time, there may be possible that a complete instrumentation and place a calcium hydride dressing in the canals. The temptation to leave the tooth open to drain the most restricted at all cost. So the microbial flora of the canal will be changed. So try to give a close dressing to the patient. And there should be and role of antibiotic in acute apical abscess. The minimal inhibitory concentration of antibiotic may not reach the source of infection because of the decreased blood flow. So not recommended until the patient has a cellulitis, fever, malaise, or unexplained trismus or lymphadenopathy. So antibiotics are not an alternative to appropriate cleaning and disinfection of the root canal, but are indicated as an adjunct to debridement of the root canal system. There is one case which was reported in our department. The 27-year female patient reported with a chief complaint of extreme pain and palatal swelling in relation to 1-1 and 1-2. And the tooth 1-1 and 1-2 was tender or percussion, and radiographic examination really shows the periapical radiolucency in relation to 1-1 and 1-2. So the patient in our clinic was planned for emergency incision under 2% local anesthesia. And after giving an incision, a corrugated drain was placed so that the drainage can take place. So this is the pictures where the incision was given and a corrugated drain was placed. In the fourth picture you can see. So this is 1 week after the drainage. The lesion subsided. Another is the cracked tooth syndrome, which may sometimes occur and the patient may approach to you. The cracked tooth syndrome is defined as an incomplete fracture of the dentine in posterior teeth that involves the dentine and occasionally extend into the pulp. The term cracked tooth syndrome was first introduced by Cameron in 1964. However, this term is now replaced by crown originating fracture, which is abbreviated as COF. The patient with a cracked tooth syndrome or crown originating fracture, the patient may present with a whole range of symptoms which may be similar to those of irreversible pulpitis like pain on chewing, sensitivity to hot and cold, pain which is difficult to localize, pain referred along with the areas served by the fifth cranial nerve, and acute pulpal and alveolar abscess. The cracks and incomplete fractures are difficult to detect, and their detection is an important component in the management of acute dental emergency. So there are various types of fracture which you have to detect, which may be visually with your naked eye, or you have to feel it with your tactile sensation by doing an instrumentation, by running the instrumentation on the tooth, or by preparing the cavity, you may detect a fracture line, or other methods of fiber optic illumination or bite dye test, and another last is the bite test. The radiograph of little use in this, as the fracture line may propagate in a mesodistal direction parallel to that of the plane of the tooth. But sometimes when it is a horizontal fracture, it may be visible on the tooth, but the vertical fractures are very difficult to detect, and the microscope may be very useful in detecting the fracture lines. The management depends on the location of the fracture. If the location of the fracture or the fracture size is small or peripheral crack, then you should remove the compromised portion and restore it with the composite. And if the large central cracks are present, if there is no pulpal involvement, then stabilize the tooth with the help of an orthodontic band or acrylic crown and then stabilize it. And if there is a pulpal involvement, first stabilize the tooth and do a root canal treatment. And if the vertical fracture is there, then there is no chance that you have to go for extraction. Now I will present some few cases, interesting cases, which we have faced during the treatment. This is a picture which is showing a lady with a 65-year female lady with chief reported to our clinic with a chief complaint of redness in the eye and a discoloration over the cheeks. And when the dental history was taken, she said that she has went to a private practitioner for the treatment of maxillary second premolar, and after the treatment, when she went home, she developed the redness in the conjunctiva and a discoloration over the skin. It may be that the dentist may have given an infraorbital nerve block, and the needle may have gone beyond that infraorbital foramen, and they have hit the orbital region where there was a laceration. There's an inward deposition of the anesthetic solution into the infraorbital vessels, and which may have caused bleeding into the orbit and at the adjoining area. So we have to be very careful while administering local anesthesia to the patient, and we have to be very thorough in the natural anatomy of the vessels. So our medication was that the patient was reassured and that nothing will happen, and patient was advised cold pack for 20 minutes 4 to 8 times a day. Anti-inflammatory along with proteolytic enzymes were given. Ophthalmic opinion was also taken, and the ophthalmic says that he should not rub her eyes, and eye drop containing nefazoline and phenylephrine was given. This is after 1 week of the treatment, the patient was completely asymptomatic. Another case which is reported in journals, the amaurosis. Amaurosis is a transient loss of the vision, a complete loss of vision. So there's a this reported case, a 37-year male patient was when given a local anesthesia for the treatment of 302, the inferior alveolar nerve block. When the inferior alveolar nerve block was given, the patient immediately complained of blurred vision in the right eye, and after 25 to 30 seconds, there was a complete loss of vision in the patient eye. What may be the etiology? The amaurosis result from the intramuscular administration of local anesthetic agent into the maxillary artery. Inferior alveolar artery lies very proximity to the inferior alveolar nerve and runs posterior to it. So accidental injection into the inferior alveolar artery under pressure forces the anesthetic solution into the maxillary artery and middle meningeal artery where retrograde flow. The temporary amaurosis result from the local anesthetic agent being carried to the central artery of the retina, where anastomosis of the ophthalmic and middle meningeal artery, where recurrent meningeal branch of the lacrimal artery. Additionally, inadvertent administration of the anesthetic agent into the inferior alveolar vein can allow the flow of anesthetic agent into the cavernous sinus, leading to multiple ocular complications. So the management was the patient was reassured and kept in a supine position. Vital signs were observed, and patient was asked to do the motility of the ocular motility so that there is no changes in the eye. After 15 minutes, all the symptoms disappeared, and there was a complete vision resolved after 30 minutes. So the main thing is that while administering anesthesia, that you have to aspirate all the three planes before deposition of the anesthetic solution. And 25 or 27 gauge needle with not more than 16 mm needle should be used to minimize hematoma. Sometimes that sodium hypochlorite accident may occur, and the literature is full of various authors have reported sodium hypochlorite accident in the literature. I've taken one case, the patient, where when the patient was given irrigated with sodium hypochlorite, the patient develops instant swelling and hematoma in the adjacent area. So what is the reason that why this patient, the sodium hypochlorite has been set as a gold standard, in irrigating solution? But this solution is also very toxic. When this sodium hypochlorite comes in contact with the vital tissue, it causes hemolysis and ulceration, which inhibit the neutrophil migration and damages the endothelial and the fibroblast cells. This toxic effect of sodium hypochlorite occurs because of its high alkalinity. It is very alkaline in nature. This is 10.8 to 12.9 has a pH of this, and the hypertonicity, which causes injury predominantly by oxidation of proteins and lipid membrane. Clinically, the patient will report a severe pain and present ecchymosis, hematoma, and swelling. And some patient may also have a temporary nerve paresthesia. So the prevention of sodium hypochlorite accident is that there should be a proper state line assay should be prepared and with adequate coronal preparation. Pre-operative radiographs should be taken and to assess the root canal anatomy. use of the specified needles like Lear lock needle should be used, or side vented needles can also be used so that it should not go beyond the apical foramen. And you should not gauge the needle near to the apical region. You should place somewhat loose into the canal. It should be above the apical region. You should not wedge the needle into the apical area. And avoid using the digital pressure, especially with the thumb. Constant in and out movement of the needle, irrigating needle, should be done. So management of sodium hypochlorite accident is that you should, if the patient will immediately complain of pain, so you should irrigate the canal with multiple syringes of normal saline, so that you have to dilute the concentration of sodium chloride, and let the bleeding response continue to flush the irritant out. Adequate pack compression, cold pack compression should be given for 24 hours, 15 minutes after each 15 minutes of interval to minimize the swelling. Recommended warm moist compresses after 24 hours for 15 minutes interval, and prescribed acetaminophen and based narcotic analgesics for 7 days. Prophylactic antibiotic should be given for 10 days to prevent the development of the secondary infection. Steroid therapy should be given for 2-3 days to control the inflammatory reaction. And we have the first and the foremost important that you have to reassure the patient that nothing will happen, and he or she should follow your instruction, and you should always monitor the patient periodically. Another complication which may occur, I think most of you will use the formocrystal for giving in a root canal dressing, and this formocrystal dressing has to be used very cautiously. It may lead to some ulceration, and you may lead into a bizarre situation. This was the case was done in our undergraduate clinic by our intern, and when he was doing a root canal treatment of the left maxillary first premolar, where first premolar, the root canal was open, and the intern has given a formocrystal pack loosely into the chamber. This formocrystal was not the excess formocrystal was not removed from the cotton, and that drooled into the oral cavity, causing ulcer, like a chemical burns on the surface it has touched. So the management in the case was that analgesic was prescribed, betadine goggles was given, a mixture of steroid-based cream and hexagens was applied on the ulceration surface, and antihistaminic was given along with multivitamins. This formocrystal causes burns usually present as a superficial white to the yellow ringed lesions. As the duration of the exposure increases, the necrosis progresses, and the affected epithelium is separated from the underlying tissue, leading to disc formation. So this is the picture is showing the initial after 7 days of the treatment, all the symptoms subsided. So it is very important that you should take care while using your intracanal medicament. This is a very dangerous situation when sometimes you are doing a root canal and the instrument slips with your hand and it goes inside the patient trachea, or may cause a very dicey situation for endodontist as well as for the patient also. So there is an accidental swallowing of endodontic instrument. So here a 20-year-old patient was systemically healthy female patient who has come for the X-ray showed an endodontically treated maxillary right septal incisor. The canal was being prepared to receive the fibropost with post drill when suddenly the drill got unattached from the latch of the micromotor handpiece and fell into the patient floor and the mouth and was swallowed by the patient. So, if the patient swallows any of the instrument, it is that immediate action that you should give. If it has stuck into the esophagus region, you should give immediately consult the ENT surgeon so that there is no harm to the esophagus or trachea, and monitor with the help of an X-ray. So the patient was immediately seated. You should always seat the patient in a supine position and ask to curve vigorously if it is in the trachea, and a high of his diet should be given so that it may go beyond the trachea and may reach your stomach. The PA view of the radiograph of the abdomen should be taken and it should be monitored regularly so that you can see the passage of the instrument, and it should pass through your stool. And if it get stuck in somewhere, then a surgical procedure may be needed. So you can see that it has reached the lower part of the alimentary canal, and then it was passed through the stool. All of you might be, while doing the root canal treatment, you dry the canal with the help of a 3-way syringe. All of you do it now. So it is, my advice will be that you should avoid using a 3-way syringe to dry the canal, whether you should use a paper point, because this is in case sometimes you may also come across air emphysema. So this air emphysema or tissue space emphysema is defined as a passage and collection of gas in a tissue space or the facial planes. So what is the etiology of air emphysema? The compressed air being forced into the tissue spaces, and during canal preparation, a blast of air to dry the canal. I think everyone do it here, but you should avoid it. During the apical surgery also, you should avoid the high-speed drill, which can lead to air emphysema. And anytime the stream of air is directed toward the exposed soft tissue, the potential for a problem exists. So this is a case which is reported in a department where the patient went to a private clinic, and next day he reported to our OPD with a swelling on the face, and the dental history said that he has taken the help of the private clinician for the treatment of root canal treatment of the 2-2 and 2-4. And when he has given the blast of air, the patient develops a periorbital swelling and the swelling in the adjacent area of the tooth. So the management was to avoid increase the intraoral pressure, such as blowing of the nose vigorously or playing musical instrument, which could introduce the more air. So patient has to be reassured and the symptoms will subside. But it is your duty that you should avoid using your 3-way syringes in this manner. Thus, to conclude that the initial management should follow the principle of 3 Ds, that is diagnosis, definitive dental treatment, and drug in the sequence. The take-home message is that in order to reduce the effect of the increased inflammation, a simple occlusion adjustment to remove the tooth from the contact in centric occlusion plus lateral and protrusive movement can help to reduce the post-operative discomfort. Antibiotics should be used when the patient has an infection that to cause a systemic symptoms or sign. Careful handling of the endodontic instrument and intraoral medicament or caustic medicament should be taken care. Most common emergency is of pain of endodontic origin, with almost 48.8% of the patient having irreversible pulpitis or acute apical periodontitis. Most frequent treatment provided is pulpectomy with or without the drainage of an abscess, follow up once the emergency situation has resolved. And the most important, when patient suffer from this type of the situation, it is the psychological management is the most important factor. You have to reassure the patient that you have to give the anxiety reduction is another important factor in reducing the operative and post-operative pain. Control the situation and gain the confidence of the patient. You should always that we are with you and nothing will happen, and we will do the best treatment. So you have to gain the confidence of the patient. Provide attention and sympathy and treat the patient as an important individual. Thank you.
Thank you so much, ma'am, for an incredible lecture. Joining us here today, we have Dr. Kaushal Kishore Agrawal from KGMU Lucknow. He is an additional professor in the Department of Prosthodontics. Please, sir, we welcome you on the stage.
Hello. Hello. Good afternoon, respected DN Kapoor sir, delegates, faculty members, students, and organizing committee members. And I am very thankful for the organizing committee members for giving me the platform to speak about my work. My topic is believing into the art of governing various situations of ocular defects. Everybody will be surprised. This is a oral dental conference, but I am talking about the ocular defects. Because I am a prosthodontist, being a prosthodontist, I am a maxillofacial prosthodontist. I not only deal with the dental and oral problems, but also with the extraoral problems in this ocular defects comes. So I will tell you about the various situations of the ocular defect. In the first picture, if you can see the eyeball is missing. And in the second picture, there is a white appearance. Orbital implant has been placed after the removal of the eyeball and orbital implant has been exposed. In third picture, you can see eyeball has been removed, but socket is small or shrinking. Okay. And in fourth picture, eyeball is missing and eyelids are also missing. Means we will give the ocular prosthesis, a maxillofacial prosthesis that replaces the artificial eye, but does not replace the adjacent skin or mucosa or the muscles. Such type of the prosthesis is given to the patients after certain modifications according to the problems. In history, these prostheses has been made from the gold, rock crystal, shell, colored stones, glass, porcelain, and acrylic resin. Most commonly, being a prosthodontist, we deal mostly with the acrylic resin, and presently, acrylic resin is the most common material for the fabrication of the ocular prosthesis because of its aesthetic and ease of the fabrication. Now, why the need of the ocular prosthesis? Because of surgical defects that has been created due to the trauma, tumors, and malformations. And retinoblastoma is the most common tumor occurring in poor children. And in such type of a patient, a adequate size prosthesis at the time of the inflammation is given, and it has been replaced according to the growth until the normal orbital growth occurs. Complete of the orbital growth occurs at the age of the 12 years. After that, we will deliver the permanent ocular prosthesis to that patient. These are the procedures for removal of the eyeballs. In the first procedure, this is the evisceration, you can see, in which only the eyeball is removed but leaving the sclera and cornea into the place. This is the picture that showing the process of enucleation. Along with the eyeball, we are removing the cornea. In this picture, you can see we have placed the orbital implant. After that, we have sutured both the sclera and the conjunctiva. Acceleration, this is the process in which the whole content of the orbit has been removed. Eyeball is removed, cornea is removed, extraocular muscles has been removed. This is the picture that shows the anatomy of the eye and after the removal of the eyeball. In this picture, you can see only there is a loss of the globe, but the anatomical features of the eyelid does not change in the cases of the enucleation. So, what is the need of rehabilitation after the eye loss? Because we are not restoring the vision, but we are increasing the confidence of the patient by improving the aesthetic, by improving the self-confidence and the acceptance into the society. It means we are improving the quality of the life of the patient. It is very, very important. Before going to the rehabilitation, first of all, we will go for the examination of the patients. You can see in the examination part, we deal with surgical sites should be properly hid, dimensionally stable, and we should also notice the location of the implant, movement of the tissue bed, size and extent of the socket. Also, we notice the sensitivity into the ocular defect area. Because if there is a sensitivity, so first of all, we will go for the desensitization processes. For that, we will advise the patient to use the eye drop for the 15 days, having the composition chlorophenicol, dextromethasone, and polymyxin beads. After the 15 days, patient is recalled and sensitivity is checked. If there is desensitivity, then we can go for the different modalities of the ocular process. These are the different modalities. If eyeball is shrunken, if defect is shrunken, defect is small, we can go for the conformal expander therapy. Its main aim is to develop, to expand the contractile ocular socket for obtaining the optimal conformation. If socket is normal, it will resemble the contralateral eye, then we go for the modified prosthesis and the custom ocular prosthesis or clear reservoir prosthesis. If patient is having the dryness into the eye because of the meibomian gland dysfunction, and in case of the dry eye syndrome, so we go for the ocular prosthesis along with the clear reservoir. If patient is having the normal tears into the eye, but patient visit is not possible for the long interval of time, then we will go for the modified ocular prosthesis. But in the normal socket and having a normal tear, we will go for the custom-made ocular prosthesis because of its aesthetics and ease of the fabrication. First of all, we will discuss about the conformal expansion therapy. These are the temporary devices that maintain the shape of the eye and prevent the closure or adhesion during the healing process. Conformals are made from the clear acrylic resin, as you can see into the picture, or maybe the iris mesh ocular prosthesis. It should be evaluated periodically at least every 6 months and relied or refabricated. This is the picture. You can see this is the shrunken ocular socket, and this is the conformer that has been given to the patient, and progressive expansion therapy has been started to the patient. It involves the fitting of the prosthesis over the time to expand the contracted ocular socket for obtaining the optimal aesthetic results. In this picture, you can see the volumetric expansion of the ocular defect with progressive conformers. In the picture A, you can see the conformer that is the small and size of the conformer is increasing from the A to the B to the C. That denotes the volumetric expansion of the socket, and objective assessment has been done by putting the conformers into the test tube containing the water. Elevating into the water determines the volume of the conformer. So in the picture A, you can see the level of the water up to the mark of the tube, and in the picture 2, the level of the water is up to the mark of 2.5, and in the picture C, the level of the water is up to the mark of 3. So this is the expansion of the ocular socket, so that we can expand the socket to get the optimal aesthetic results. This is the first case. This case visited to our department having the loose artificial small eye. History was enucleation of the right eye has been done due to retinoblastoma a year ago, and patient was using the ocular prosthesis since 5 months. On socket examination, we noticed tissue bed is normal, no inflammation. Patient having an anastomosing socket with contracted orbital volume and inferior palpebral aperture in comparison to the conventional eye. So what is the treatment options? Patient is having the previous prosthesis, so we can design this, and we can also make the refabricate the prosthesis. We have decided for the refabrication of the prosthesis because of the dust and discoloration of the previous prosthesis. So in the procedure, first of all, we will go for taking the impression of the ocular defect. This is the impression. After that, we have poured the defect into the alginate. After set of the alginate mold was cut and wax pattern was fabricated into the mold. Wax pattern was tried into the patient eye for the proper size and the proper shape. There should be the proper closure of the eyelids because of the stimulation of the tissue beds. And you can see the proper positioning of the eyelids into the eyeball over the wax pattern. After that time, we will go in the same procedure that we follow for the complete denture cloning. We will go for the plastic, de-waxing, packing, and de-glassing. After that, we will after the processing, we will get the prosthesis and it right into the patient eye for the optimal size and shape. If required modification has been made, if the prosthesis has been modified, we will go for the characterization of the prosthesis. We will remove the inner and outer canvas of the eye, and acrylic painting will be made to incorporate the translucency, and red fibers were incorporated to simulate the waves. You can see the final ocular prosthesis into the eye, right eye and left eye. So we are following the progressive expander therapy for this child to obtain the aesthetic results. Now the modified stock eye prosthesis. These are the eyes that is available in the market. In the modified stock eye prosthesis, main advantage is short period of the time, but we cannot get the optimal aesthetic and functional results as we can obtain in the custom made ocular prosthesis. So this is a patient in which the modified ocular prosthesis has been given because patient is coming from the too much distances, so not able to come number of the times. For the modification of the stock ocular prosthesis, we select the stock eye, and stock eye has been modified according to the socket size. Impression has been made with the polyvinyl peroxide impression materials. You can see the picture having the tissue surface of the impression and impression.
Same thing, the impression has been invested after the defrosting, the impression material was moved and undercut the weight of the posterior surface of the stop eye to entanglement of the tooth acrylic acid. So you can see this is the pre-op and the post-op final ocular process is in place. Now the custom-made ocular processes. As I have told you that it is better than the modified stock ocular processes in the aesthetics, but it requires the skilled artistic hands for the iris and speed of application, and it is a time-consuming process. These are the steps for the fabrication of the ocular processes: impressions, fabrication of the mold, fabrication of the patch pattern of the sclera, iris selection and iris positioning, iris completion, and finally curing of the patch pattern of the sclera with the two colored acrylic acid that color match to the conjunctival eye. These are the impression materials that are used for the technical impression of the ocular defects, but most commonly is the irreversible hypoboloid and elastomeric impression materials. Or among the elastomeric impression materials is the polymerized luxury material is commonly used. These are the different techniques that has been followed for taking the impressions. We can take directly impression with the low viscosity aggregate with some reinforcement and light body with putty. We can take the impression with stock ocular tray and custom ocular tray, and we can also use the stock ocular processes to take the impression. You can see first picture. This is a conformer that has the perforations for entanglement of the impression materials that has been fitted to the entire end of the syringe, and the syringe was filled with the polymerized fluorescent impression material or modified engineered material and to take the impression. At the time of the impression, the plugger is pushed and this tray is placed into the ocular defect areas and the impression has been made. You can see the impression on the right side of the slide. After taking the impression, we will fabricate the mold and battery is over. Left of it. I have charged laptop or laptop charger.
इक्कीस मिनट से गाड़ी रखने वाली फिल्म
Now we are ready for with my topic. Sorry for interruption. Okay. So now we are going on the custom-made ocular processes. After taking the impression has been poured with the alginate for the fabrication of the mold. After the mold fabrications, A stalk eye has been selected, and stalk eye has been selected whose iris should match to the contralateral eye of the patient. So main step is that we are taking the iris from the stalk eye, but its size and shape should match to the contralateral eye of the patient. After the selection of the iris has been taken from the stalk eye and it should be positioned on the wax pattern. The positioning of the iris is very critical step. We will place the iris, first of all, we will insert the wax pattern into the ocular defect areas, and the size and shape of the wax pattern is modified according to the defect. After that, a horizontal line is drawn. Horizontal line is drawn, and it should have the distance similar to the distance from the midline of the face to the center of the pupil. And vertical positioning of the iris is determined by the inner tensor relationships. After the positioning of the iris, same pattern was followed as we follow in the complete tensor fabrications. De-wax mode and this is the final ocular prosthesis. And this is the ocular prosthesis and has been inserted into the patient's eye. You can see the both eyes are looking similar. There is no difference in the both eyes. This picture shows the rehabilitation of the same patient with the modified stalk eye prosthesis and the conventional ocular prosthesis. Which artificial eye is looking better? Audience? कौन सी आंख अच्छी लग रही है आपको आर्टिफिशियल? Which artificial eye is looking better? Second one, yes. Because this is the conventional ocular prosthesis and first one is the modified stalk eye prosthesis. Now the skeletal cell prosthesis. This is the thin plastic prosthesis used when eye is malformed as a result of the birth defect or become non-functional due to the subsequent illness or injury. For fabrication of the prosthesis, same pattern was followed. In this patient, first of all, we take the impression. Mold was fabricated for the wax pattern fabrications. After fabrication of the wax pattern, acrylic index was made for the repositioning of the iris after the de-waxing. And this is the de-wax mode and the final process is in the place. This is the patient having the orbital implant exposure. Orbital implant is placed at the time of the enucleation to establish the motility of the eye. But in this case, implant has been exposed, so the oculoplastic review was taken. After taking the review from the oculist and the plastic surgeon, we fabricated the new processes. Implant was placed to maintain in the same position with some relief on the posterior aspect. This is the impression. After the wax pattern fabrication, this is the wax time of the patient. This is the final process in the place, and this is the follow-up after the 6 months. In this case, you can see that there is a defect along with the missing of the eyelids. So in this patient, ocular process was fabricated in a similar manner as we have described previously. After that, eyelids were carved in the wax on the ocular surface of the prosthesis, which aim to simulate the position, contour, and texture of the contralateral eyelids. Shade making was done from the E-skin guide. Acrylic stump was made for the exact unification of the ocular component. De-waxing and retrieving the processes has been made from the glass. After that, a gas burr was used to get the cut on the posterior aspect of the ocular prosthesis for the entanglement of the acrylic resin. Prosthesis was replaced accurately into the flask with the help of the stump index and was patched with the molding base. After that, cooling has been made as per the manufacturer instructions and repeat the process. Now prosthesis has been inserted into the patient eye and eyelids was shoot using the patient natural hair and touch-up has been done with the extensive if required. You can see this is the ocular defect and the patient after the rehabilitation. You can see the change into the patient after the rehabilitation. A picture is showing the rehabilitation without finger of the prosthesis giving the stereo appearance, and B is showing the yoke of the prosthesis with improved aesthetics. Now, what is the importance of the tear that has been discussed? Now, the tear prosthesis is the tear reservoir where will be given in the case of the dry eye syndrome and the myopic gland dysfunctions. This is the case. This is a picture showing the myopic gland dysfunction. You can see the obstructive myopic gland in upper eyelid with wax myopium issuing from the myopium gland orifice, some of which are blocked. What is the importance of the tear reservoir? Tear reservoir is required to improve the dryness of the eye, and if dryness has been removed, so it can improve the compatibility of the sockets. Now, how can we fabricate the tear reservoir in the ocular prosthesis? This is we will discuss in the next case. We have taken the impression using the additional silicone. This is the next one, the tissue surface of the impression. That trial has been made. Iris selection and positioning has been done. After that, our 23 gauge wire was inserted into the wax pattern to form a channel for the lubricant to extrude. Flasking and dewaxing has been made for the tear prosthesis. You can see the iris button and the reservoir button into the place into the flask. And the packing was done using the lost call technique. You can see the picture of the ocular prosthesis with the tear reservoir made from the lost call technique. This is the final picture of the tear ocular prosthesis. We should not be confused with the iris. Iris is in the anterior part and the reservoir button in the posterior part of the prosthesis. This is the liquid gel that are used for creating the tears into the eye. Liquid gel has been dispensed into the reservoir, and you can see the prosthesis, the patient wearing the previous prosthesis into the place, and the patients having the ocular prosthesis with tear reservoir into the place. This is the tear reservoir prosthesis, the hollow ocular prosthesis with functional lubricant reservoir consisting of the reservoir for the lubricant in the superior aspect of the body of the prosthesis. Lubricant reservoir is connected to the assist opening on the posterior surface by the passage. Assist opening is closed with a removable cap, which allows the patient to load the lubricant in the reservoir as well as to clean the reservoir as and when required. Prosthesis also have the exit hole for the lubricant. 0.5 mm is the diameter on the anterior surface of the prosthesis. During the normal blinking action, upper eyelid creates a negative pressure which draws the lubricating fluid from the lubricant reservoir to the anterior surface of the prosthesis through the exit hole, which spreads over the prosthesis by the blinking action. In case of the bacterial infection, instead of the lubricant, antibacterial eye drops can be loaded into the reservoir. These are the references of my presentations. Now, first of all, what are the common questions of the layman? Layman always asks कि सर हमने prosthetic eye लगाई है, क्या हम इसको पहन करके सो सकते हैं? Yes, we can sleep. एक कॉमन क्वेश्चन हो रहा है कि सर क्या ये आंख आपने लगाई है, क्या इसके हम क्या ब्लिंक कर सकते हैं? Yes, we can able to blink properly. We can move the prosthesis. थर्ड क्वेश्चन ऑलवेज पूछा जाता है कि क्या जो आंख आपने लगाई है इसको क्या कभी बदलने की भी जरूरत है? जनरली क्या होता है कि इन एडल्ट ये आर्टिफिशियल आई को हम 3 से 5 साल में रिप्लेस कर सकते हैं, करते हैं। क्यों? क्योंकि वो कलर जो है वो ब्लू हो जाता है और सेकेंडरी जो पिगमेंटेशन है उसकी वजह से भी डिस्कलरेशन हो जाता है। तो इसलिए क्या है 3 से 5 साल बाद हमें आई को रिप्लेस करना चाहिए। बट इन conformer extraction therapy we replace the prosthesis within the 2 to 4 weeks because orbit will expand. एक होता है, एक क्वेश्चन पूछा जाता है कि क्या हम जो हमें आपने आर्टिफिशियल आई दी है क्या उसको हम साफ कैसे करेंगे? तो हम नॉर्मली जिस तरह डेंचर को साफ करते हैं उसी तरह हम आर्टिफिशियल आई को भी साफ कर सकते हैं। इसके लिए हमें क्या वाटर और माइल्ड सोप सॉल्यूशन का यूज करना है, एब्रेसिव्स यूज नहीं करने हैं। उससे क्या होगा कि उसका सरफेस जो रफ हो जाएगा और डिस्कलरेशन हो जाएगा। एक क्वेश्चन जो पूछा जाता है कि हाउ डू यू स्टोर द फेक आई, मींस जो आपकी नकली आंखों को कैसे स्टोर करेंगे? तो श्योर we can store the prosthesis into the water or soft contact lens solution. नॉर्मल जैसे डेंचर को पानी में रखते हैं उस तरीके से हम स्टॉप आई को भी पानी में रख सकते हैं और it will keep the deposits from drying on the surface. Okay. Thank you so much. This is my contact. If you are having any problem in the fabrication of the prosthesis in different scenarios, in different patients, you can contact me on my email ID. We can discuss. Any questions from the audience side? No questions? Thank you.
Thank you so much, sir, for sharing your knowledge. We welcome Dr. Anmol Bagaria and Dr. Ashish Chandra to proceed with the felicitation of the honorable speakers present over here today, beginning with Dr. Shaleen Chandra. For a huge round of applause.
Wait. ये प्रेजेंटेशन करने
Dr. Pramila Verma.
फटाफट प्रेजेंटेशन आवेला ना प्रेजेंट पे फिर प्रेजेंट आप पहला देना आया છે મેડમ હા આઈએ ફટાફટ ચાલુ થઈ ગયું
Next we have Dr. Kaushal Kishore Agrawal. A huge round of applause for him. Thank you, sir. Thank you, ma'am. Now we welcome Dr. Abraham Johnson, the Assistant Professor in National
Forensic Sciences University to give his exceptional insight on digital forensic dentistry. A big round of applause for Mr. Johnson, please.
Good afternoon. Good afternoon. Good afternoon. Good afternoon. Okay, I understand it's lunchtime, so you guys are quite waiting for the lunch. I'll quickly talk about I'll take you to my presentation. Okay, that's a digital forensic dentistry. I will not take much of your time. First of all, I am very much obliged and grateful to the organizers. That's the CynoDent, Dr. Anmol Bagaria, as well as Chris, Dr. Kamal Bangla for this, taking this particular initiative in organizing the 5th World Dental Science and Oral Health Conference and bringing me here. I am not from the health fraternity, I would say, for now. I'm a dentist, but now I work with the Ministry of Home Affairs as a forensic odontologist. Okay, so I do not belong to health ministry. I'll be talking about the academics, my research areas, how we have been taking forensic odontology to the next level, and with some of the consultations and the case works. I would request each and everyone who is sitting at the backbenches, to come forward so that you can have an interactive session. Can I request everyone? You can occupy the front rows. Yeah, thank you. So you have been listening about the clinical dentistry right from yesterday, today morning. Some parts of endodontics, some part of oral pathology, some oral surgery, and various aspects. But I will be taking you through the journey of forensic dentistry. Greetings from my institution, from where I belong, that's the National Forensic Science University. Now, as a kid, we have always been into crime scene serials, right? Like we might have read about the CSI files, or I would say watched certain movies related to crime scene investigation. And I am sure that nobody would have missed this Sony wala episode or serial, that's CID. So that's how I was also fascinated about this specialty of forensic dentistry. But as a dentist, how to get into forensic was a major challenge. So this is how I got more insights about forensic dentistry. That's the Sheffer's oral pathology book, and my gratitude, I would say, to my oral pathology mentors. Right away from 3rd year, they have been molding me to understand this subject in a better manner. So 3rd year was the oral pathologist who built up a kind of foundation for me. Then the radiologist build up the entire framework. So this is the place where I practice the laboratory forensic odontology and radiology. I have been fortunate enough to meet one of the finest forensic scientists of the globe, I would say Dr. Henry Lee. He is the one who has been investigating or who has investigated the John F. Kennedy assassination case. So he told one basic thing, that whenever a dentist or whenever a scientist goes to a scene of incident, he should allow the evidence to speak up. Okay, let's not just assume. That's how even whenever we are also a clinical investigator. When a patient comes to our dental clinic, we
let the patient speak up. We see what all are the signs and symptoms, right? And then we develop the entire provisional diagnosis. Okay, what exactly it is. So he has been stating that I always go with an open mind. I do not even believe what the police tells me. They always try to tell you their own story, but he allows the evidence to speak itself. And talking about our branch, dentistry, it's a very beautiful branch because right from our second year, third year, when we have been introduced about the amalgamation of science and art. Okay, so that's how even I believe forensic dentistry is an amalgamation of both the science as well as art and many other branches. So right from the prosthodontics, the conservative dentistry, the orthodontics, oral maxillofacial surgery, pathology, medicine, radiology, and pediatric dentistry, every discipline has taught me or is teaching me day in and day out in all my caseworks how to investigate. So talking about basics of forensic odontology, it's just the applied part of dental science in the legal framework or in the criminal investigation procedure. So when we talk about a complex definition, it's that branch of dentistry that deals with the proper handling, examination of the evidences and with the proper evaluation and presentation of dental findings. So you might have read the title. My title was Digital Forensic Dentistry. Okay, I'll talk about more of digitization because we are living in an era of digitization. We are having smartphones, we are having smartwatches. Okay, then why not smart dentistry, right? So even when we talk about forensic dentistry, we started with conventional practices where we had original specimens, okay, where we used to measure the things, we used to see how the things are, okay, we used to section it, okay, and do all kinds of conventional measurements with the help of calipers and so on and so forth. But when we talk about this present era, that's digitization, we have seen the acceptance of digitization in every sector, right from healthcare. We have been reading or seeing some of the robotic surgeries. Okay, we are talking about the guided surgery these days. Okay, with the surgical, I would say, plates and everything, right? When we talk about even in education, COVID was the best teacher for all of us. As an academician, I would give all credits to COVID in a better manner because sitting at home, I was able to connect with my students. Okay, I was able to do online teachings. Not only in academics, we were able to organize, participate in online conferences. So we can understand the acceptance of digitization is so important. And so we can see this kind of digitization even in dentistry. So talking about the intraoral RBG X-rays, we don't use now film-based X-rays, right? We're using more of an RBG system. We are doing a lot of documentation. So we have intraoral cameras, we have the DSLR cameras for patient photography. We use intraoral scanners for digitizing, okay, of the entire maxillary and the mandibular cast. We don't use nowadays the impression materials like the alginate or the gypsum products. We are into the patient management systems. We are using the surgical guides for our easy practices of implantology. But why I have taken tooth as a forensic evidence? Okay, now when we talk about the importance of the significance of tooth, whatever I'll be speaking is based upon my observation, based upon my researches, whatever we have done. So it is unique in nature, I believe. As a dentist, I totally believe I have seen there are no two individuals with same kind of dentition. If I take basic photograph, okay, if I ask everyone to take a selfie photograph with your lips parted, okay, I will be in a position to say that no two dentition are same. Okay. Also, when we talk about the dental science or the morphological structure, God has been very kind to dentists, I believe, because teeth is the only structure which is resistant to physical, chemical, and biological assaults. Okay, your face will get distorted in case of fire accident cases or burn cases, okay, mutilated body. It's very difficult to identify a person from the face, but your tooth resists. I normally give this particular statement. It is easy to break a bone, but but it is very difficult to break a teeth. I would believe, though it should not be documented, we are in a dry state, but I totally have seen men opening the beer bottles, okay, with the help of the teeth. Why? Because our teeth are much more stronger. The anatomy, the enamel dentine pulp is so strong. The thecodont, right? It's totally embedded in the jaw. So the presence of enamel has made it more resistant to physical, chemical, and the biological insights. Talking about the beauty of the tooth, right from the morphology to the histology, radiology, you apply any part of dentistry, you are able to examine the morphology, you are able to do the matrix part in the best manner. So talking about my role, how I do the investigation, that's the common modality. How even a law enforcement agency or the first officer goes to a crime scene, the first mode of identification is visual identification. Okay, so the moment I came here on the dais, I was like, I don't find people here. Okay, so that's my observation. We identify, we see through our eyes. So that's the common mode of identification. But in such cases, when we talk about human remains in mass disasters, when talking about the Mangalore air crash, Uttarakhand floods, the WTC attack, or we get this kind of bodies, right from the mutilated bodies, charred bodies, decomposed bodies, or skeletonized body. And it is next to impossible to identify a person based upon the visual traits. So we need to identify, we need to recognize such modality which helps us in identification. So apart from disaster, we have been seeing human skeletons plays an important role in even in criminal investigation procedure. So there have been skeletal remains in the parks, in the police stations, in the abandoned areas. So what we keep promoting, as a forensic dentist, I feel so privileged, I feel so happy to promote that even the highest body, when we talk about law enforcement, that's the Interpol, has clearly stated that dental can be used as one of the only sole indicator, I would say primary identifier, along with DNA and fingerprint. So how fingerprints are unique, so as the DNA and so as the dental. So we should be proud about our specialty. Talking about the investigation procedure, we have been routinely using our radiological methods of non-invasiveness. So, be it going to the scene of the incident. So, this is the Directorate of Forensic Science, where we have got some of the cases, and we use our portable X-ray units to scan, to do the radiography. And at times, it is very difficult to get the remains in-house. So, what we do is we inform the police, get the human remains to the nearby radiology center, and we get the files. That's how we do the investigation. Talking about the forensic odontology, the major role what a forensic dentist does is human identification. That's how we are not bothered about why the person died, how did the person die, the cause and the manner we are not, but who the person is. So if we are able to identify who the person is, we are giving the maximum answer to the entire investigation. So talking about the human identification in case of single body identification or mass fatalities, we as a dentist play an important role. We help in assessment of the age, the determination of the sex, collection and the analysis of the bite marks, which is an important area which I will be discussing in my prospective slides. Maintenance and the management of the dental records. Now, as a dentist, okay, I am sure that not everyone would like to be a forensic odontologist, but at least every dental surgeon is a clinician. Okay, so it's our mandate, it's our, I would say, a humble plea from my side that we need to focus more on the dental records. Because these days, what we are doing is we see the patients sitting outside in the dental clinic in the waiting lounge, and we start documenting the things. Okay, let's focus more on the treatment part, and we forget about the documentation. So management and the maintenance is something very important. Recognition of the signs and the symptoms of human abuse. Now, when I talk about human abuse, we have dealt with some of the geriatric abuse, talking about the abuse of the older individuals, women and child abuses. So I remember a case long back when I was practicing as a clinician after my internship. So there came a lady with a lot of marks on her face, with her tooth, like insides are broken. So I had a inquisitiveness. What exactly it is? It is not a pathology. Okay, this is something trauma. So I was practicing with my mentor. She's an oral pathologist. So we had a discussion. Madam, what needs to be done? So we had to report that particular case in with the police because it was a domestic violence case. So talking about the dental identification, which is an important area and our first line of, I would say, role in dentistry. So human identification is never same in two individuals, as I mentioned. The morphology and the arrangements are quite unique. Now, when I talk about the arrangement, we know we have class 1, class 2, class 3. Okay, we have so many different spacing, crowding. Okay, I'm unique in nature. Why? Because I have 2 dental implants. Okay, some might have veneers, some might have amalgam restoration, some might have some other restoration factors, right? So all these are some of the important areas that helps us to build up the entire profile of an individual. How we identify an individual? It's basically 2 mechanisms. One is comparative dental identification, so where we compare 2 records. We are doing the postmortem examinations of mouth. We record all the findings in one particular form, and we request the same information from the next of the kin of the relative. So they give some kind of information, and then we try to match it. So it's direct one is to one match. You might be having a question, Dr. Saab, अगर हमारे पास we don't have dental records, we don't maintain dental records, we are more money-oriented clinicians. Okay, we want to focus on implantology, we don't want to focus on dental records, no problem. You send the, so in such cases, we do a reconstructed profiling. So what we have some of the non-metric traits where we use and build up the entire profiling, age estimation that helps us in determining the age, determining the sex, and so on. Now, this is one of the case I remember, which was referred to us. It's very difficult to identify this kind of an individual. Forensic medical doctors definitely can identify, they can do the profilings, they can say age, sex, and so on. But when I say human identification, who the person is, X, Y, Z. So it was very easy to say because of the dental restoration. Here you can appreciate. So with the intraoral mirror, we were able to record it and we were able to say that, okay, there are 3 amalgam fillings in the upper jaw. We need the dental records, and that's how we were able to conclude that this is Mr. XYZ. Talking about the major area of our practices in the country, because when I talk about human identification, which is well practiced abroad, but not in India, because forensic medical doctors, they are not well versed with the dental practices, and also some of the dental colleagues, they are not happy working in the morgue. Okay, at times I remember, like as a dentist, like when we were doing our graduations, first, second year we were cautious about using the PPEs, the gloves, mask, and everything. Okay, but as a clinician, we will not use gloves also. We will not use mask. Open your mouth, we'll see. Okay, we are so super powerful at that. So just now examining such individuals in the morgue, that is something very different, where you are having a dead body. So talking about one particular incident, why dental age assessment is so important. You can recollect or remember this person, Mr. Ahmedabad, one of the prime suspect of or the person behind the Mumbai 26/11 terror attack. So where the judge had ordered for the dental age assessment along with the bone ossification test. So here you can understand the third molar status played an important role to confirm whether he is major or minor. So as a clinician, we know we can estimate the age. Okay, we know the radiology, we know the development factors, we know the maturation. Okay, so we can say, okay, this is not an adult. Okay, this belongs to 10 to 12, right? And when we talk about this, yes, this is again a kind of a mixed dentition period. So age assessment is one factor. Talking about the next important area, that is sex determination. Now, why sex determination is so important from a forensic investigative perspective? Because if I inform the police officer or the law enforcement agency, look, mister, the remains belongs to male. It does not belong to female. So their way of approach, it becomes narrow. It's more of a funneling process. So they have 1,000 missing reports. 500 male, 500 female. I say it belongs to male, not female. So they are just focusing on those 500 males and not the females. We are helping those agencies. So talking about the anatomy, both the skeletal part, first year, remember our first year, BD Chaurasia days, okay, and talking about wheelers, it's very important we understand the anatomy, even as a clinician. So supraorbital ridge, the mastoid process, they give an accuracy of more than 90%. If you understand the accuracy of teeth also, it is more than 75%, 75%. So you can relate that whatever we are giving, whatever report we are giving, it is more accurate. We use some of the biochemical methods of identification in terms of sex determination, the pulmonary tissue, Y chromosome, the melanin, and the bar body also. But again, those are invasive and biochemical part. One of the case report what I have incorporated is the Annigiri case. Here again, a forensic dentist was involved. This case happened long back in Hubli, in Dharwad, in near Karnataka area. So here you can appreciate more than 300 skeletal remains were recovered. Here you can appreciate these small. Can you see the skeletal remains? It looks like a coconut shell, but yeah, they are not coconut shells. They are actual skulls. So the major question was, इतने सारे skulls कहाँ से आए? किसके हैं? As I said, forensic dentist does not play an important role. कहाँ से आए? Okay, we help in किसके हैं? Who the person is. Okay. So the forensic dentist was involved along with the other forensic medical doctors, the forensic scientists, the archaeological department, and they gave a kind of a report stating that the skull belongs to both young group as well as adult, with the age group of 6 to 8 years and 30 to 50 years, which involved both male and female. Now, this is something very eye-catching to the press media, bite mark investigation. But it is so controversial, so taking sensitive, I would say. If a dentist can identify, but if a dentist cannot record or do the analysis, kindly do not do the analysis. Because when we talk about, there have been a lot of cases where the innocents have been put behind the bars. Okay. There was a major project called the Innocence Project. So when we talk about the bite marks, they are commonly seen in the sexual crimes, the violent files. Okay. Now, if I want to captivate someone, okay, the moment I just imagine there's a person, okay, मैंने उसका the next moment the reflex action is he'll try to make him free, he'll bite on my hand. So that's how the bite marks are very common these days. Apart from the animate objects, we also find the bite marks on the inanimate objects like chewing gum, the foodstuffs like apple, chocolates, and so on. Now, this is one of the important cases when you talk about the Ted Bundy case, where for the very first time, Dr. Richard Sobrin was able to identify, record, analyze, and give a report stating that this is a bite mark. Okay, now Ted Bundy is considered as a smart criminal. Okay, we forensic investigators, we always try to learn more, we try to evolve, because the more with the evolution of the time, even the criminals are getting smarter. Nowadays, you will not find people using any weapon to kill you. Okay, if they want to defame you, okay, they can put everything on the social media, or else you're sitting over here, within a fraction of time from your account, everything will go in a minus state. So that's how the frauds, or I would say the crimes, have been increasing. Talking about the acceptability of the bite marks, yes, in India, after the Nirbhaya case, where the DNA fingerprints, even the bite marks were used, so we can understand the acceptance in the Indian courts also. I was able to not only identify him, one of the senior most oral radiologists from Goa Medical College, where this lady had come, okay, and you can appreciate this kind of a bite mark. So we were able to use again a digital technique. Here, normally we use, we take the impression, we put one-to-one direct matching, but at the same time, what we did is more of a superimposition using digital techniques, the Adobe Photoshop. Now, this is the other area of my interest. We do a lot of non-human bite mark investigation. My area, like my research work was more on the non-human, because human bite marks are very well analyzed. So with the help of an oral radiologist, so you can appreciate that this entire examination was done with the help of CBCT and the entire analysis was done. We use a lot of prosthetic materials like the composite, the elastomeric impression materials for taking the impressions and creating the entire replicas. Whatever we do it in our cases, we first experiment. So all these are our experimental work. What we first do, we publish it. After it is validated by the scientific community, we then use it for our casework. So forensic facial superimposition, we use it in a maximum way. So here you can appreciate this skull is also it belongs to mine. This is a replica of my skull. So I got myself a CT scan. After getting my CT scan, I made sure that I create a replica of my skull. So got it 3D printed, and then we did a lot of image manipulation tool using the image enhancement and manipulation tool. We used it for forensic superimposition. Now, why forensic superimposition is used? When we talk about the older case, the Buck Ruxin jigsaw murder case, where the entire body was brutally cut into small pieces. Now here you can appreciate that very recently, even in Delhi, there has been one such incident, okay, where you find parts in the bodies, okay, and it's very difficult to identify whether these two parts belong to same unless and until you go for DNA. And when we talk about the DNA, it is technique sensitive, it is time consuming, and you need experts for that. So, Buck Ruxin jigsaw murder case was one such example where forensic superimposition was used. Again, when we talk about the first Indian case, not the first Indian case, but very recent was the Sheena Bora murder case. But the reason why I kept here is the analyst who did the entire analysis, he made a major blunder. He didn't use a proprietary software. It was an open source software, and plus scaling was not used. So these were the two challenges he had to face the trial in terms of the jury cross trial. Now, when we talk about the last approach, that is a forensic facial superimposition. Forensic facial reconstruction. Now, forensic facial reconstruction, we don't do it for scientific experts, for the investigating officers. We create the face so that the next of the kin can identify. Now, I'll just give you an example. You might have observed Amitabh Bachchan in Pa. Okay, so the moment I say Amitabh Bachchan in Pa, you get that kind of a figure. Amitabh Bachchan in Shahenshah. So you can imagine him with a lot of beard. In a similar manner, Hrithik Roshan in Boom. Okay, so he came in different avatars. Okay, old women image was also there, as well as old men, okay, with a lot of wrinkles. But you were in a position to identify him, recognize him. Okay, the moment he came on screen. Why? Because of your cognitive mindset. So you have seen Amitabh Bachchan, Hrithik Roshan in different avatars. So same principle we apply for forensic reconstruction. We do a lot of 2D image analysis, 2D reconstruction, 2D sketching. So maybe in CIDs you might have seen that people, kaisa dikhta hai, yahan mole hai, munche hai. So the forensic artists, they draw a sketch. What we do is we create the face with the 3-dimensional part. This is manual forensic facial reconstruction, and the next part is the digital reconstruction. Now, when we talk about the forensic facial reconstruction, whatever we are doing on a foundation, that is the skeletal element, that cannot be changed. You can change the soft tissue, but it is very difficult to change the hard tissue, right? So we use the cephalometric principles, again the orthodontics, the anatomy, okay, oral radiology, they go hand in hand, and then we do the analysis. Yeah, that's how we try to analyze after taking a lot of lateral cephalograms. Now, talking about the forensic facial reconstruction, which was being practiced mainly for archaeological samples, mummies. Okay, we have not seen how they look, but they create the entire face. But very recently, during COVID, Dubai police was were the first one to investigate this forensic facial reconstruction case, where they were able to prepare the entire face of this particular decomposed body. And later, even in Maharashtra, in India, they were able to create the face. Now, we have been discussing more about the digital innovations. So the innovative approaches has also been filtrated into, I would say, forensic dentistry in forensics, because where forensic and medico-legal experts have gradually started using the new domain called 3D. Now, as a clinician, you might have taught by your old radiologist that CBCT is one of the best imaging tools. Okay, so the professor guys might have taught about the intraoral scanners with 3D printers. So these are the things we have been using in our day-to-day teaching, research, and the case activities. We use 3D imaging, we use 2D and 3D modeling part, and 3D printing. Now, what exactly 3D is? Now, here you can appreciate on the left-hand side, this is two-dimensional, where you can just get the x and the y axis, but you don't know the depth. But nowadays, we have been seeing a lot of 3D avatars. Okay, talking about Mario, Spider-Man. Okay, it's more of the 3D avatars where we can understand the depth part. That's the spatial representation. So why I have been promoting 3D forensics? Because of its quickness. It has been, it's quick to capture, it's quick to analyze, and it is quick to transfer. Better quality than 2D, definitely, because I get the third dimension also. Ease of sharing, accuracy, and non-invasiveness. Pardon me for the next slide, because I have been keeping this slide mainly to make understand my law enforcement friends. Okay, because they are very hesitant. Doctor साहब क्यों हमें 2000-5000 खर्चा करना है? And I am like, वरना ऐसा होगा. This picture made an entire sensation in the print media. Now, do you know him? Yes, no. Prince who is from a very royal family, Prince Williams. Okay. Now, the news came in the print media stating that he has shown a very unroyal gesture coming from a royal family, right? But this was the reality. He was actually very happy to share that he is now a father of 3 children. So this is what we have been seeing if we keep taking 2D projections. If you don't, even it is happening in a clinical dentistry. That's the reason what if we want to analyze the object, where exactly it is we used a stock principle. Okay, before CBCT was utilized, but nowadays definitely CBCT is the best tool for image analysis. So that's how, even in forensics, what we have been promoting is we have to understand both X, Y, and Z axis. So what is 3D scanning? Where this is a process of data acquisition in XYZ coordinates that would represent an object in the virtual space. We have been, I have this particular scan in my lab. We keep it over here and we document it. Okay, so instead of taking photograph, we put the scanner and it gives an entire 3-dimensional picture of that entire room. As a forensic experts, we routinely perform CT scanning, that's the post-mortem computer tomography, as well as we use 3D surface scanners for accurate digitization. Now we have 2 different modalities. One is surface scanners, and the next is the volumetric scanners. Surface scanner, I'll be showing how I've been using, and volumetric scanner involves both CT and the CBCT. Talking about the CBCT, the forensic or the CT, forensic evidences, human cadavers can be scanned. Okay, because at times it is very difficult to open the entire body, get the things out, because if it is charred, remain your at the first stage it could be in toto, okay, but then everything would be fragmented. So we use a lot of CT and CBCT. Visualization of internal features becomes much more evident. So if at all we want to understand the bullet trajectory, if it's a bullet injury, we use the CBCT and CT. 3D reconstruction is possible both outside and the internal part. This is how we use the surface scanner in my lab. We don't give these days the human skeleton, or I would say cranium, mandible to the students. Okay, because they are in the learning phase. Okay, if you can recollect your first year, okay, when you were first given the skull, what you have done? Okay, you started playing with it. Okay, you might have even passed it. Okay, you have taken a lot of pictures. Okay, just for memories, but when we talk about from a forensic perspective, that's something wrong. It belongs to someone. It is unethical. It is not humanitarian. Just imagine our loved ones who had donated that body, and indirectly it comes as to, okay, for as a teaching aid. Can we start playing with it? It's wrong. Okay, so what we have been doing is we have been now digitizing the entire skeleton, the dental part for teaching learning purposes, which gives a higher resolution surface text and the color data. It is very affordable in terms of volumetric scanner. It does not emit harmful radiation. So if I want to scan my cranial mandible, I need to take the permission from my head, HOD. Okay, I have to take the permission from the dean that, sir, artifact आ गया है या अच्छे से scan नहीं हुआ. Can I expose the patient for the second time? And definitely will be true. Okay, your radiation exposure. But when we talk about this kind of a scanner, you can go for multiple scanners. So this scanner I normally give it to the student. They document it. Okay, so it does not emit harmful radiation, and it does not require any kind of a expert, radiologist or radiographer for processing and interpretation. We have different types of scanner we have been using, contact and non-contact. So here you can appreciate we have been using an intraoral scanner for documenting the dentures. These are faster in data acquisition, non-destructive, and because it does not comes in contact with the evidences or the object. This is how it works. We use our surface scanner to get the entire 3D model. We use CBCT to create the entire digital repository. And at times we go to the radiology imaging center to get our things scanned. Now talking about the basic research practices from the anthropology, anatomical, odontology perspective, it's basic. Like we go to the site, we recover the evidences, we start documenting all the inventory part, and then we have a tool for statistics. We have a lot of literatures available on in the journals, both international and Indian journals, for estimating age, for differentiating the sex, and then we establish the idea. But nowadays, when we talk about the advanced practices, we are understanding the 3D bone histology part. We are understanding the 3D taphonomical, the trauma part. We are understanding the 3D forensic facial reconstruction and the forensic facial recognition. So, in terms of 3D, it has helped me in documentation, analytical procedures, virtual reconstruction, and facial reconstruction. All these are the models you'll not find on any particular site, because these are my pictures. We have been we have been documenting, we have printed a smallest tooth to the entire mandible and the cranium. Okay, so this is the 3D printer set up in our lab. We have been routinely doing a lot of forensic facial reconstruction cases. So here you can appreciate how we create the face, the skull, and then we create the face using different methods. So talking from the documentation perspective, the analysis, yes, the 3D has helped me both in understanding this surface measurement, linear measurement. If I want to understand the volume, everything can be done with the help of 3D. It has helped me in the reconstruction. Normally, when we talk about the forensic cases, we get this kind of fragments, okay, and then we have to analyze. So in earlier days, we use adhesives like basic example. I hope no prosthodontists are sitting over here. अगर टेंशन भी टूट जाता है क्या करते हैं, फिर भी लेके आते हैं, लगा देते हैं, right, and give it to the patient, but which is something wrong practice. Okay, but what we do in forensic is also in a similar manner. We use adhesive, we use Fevikwik glues to fix it up, but these days we are not using adhesives because it deteriorates, it creates some kind of artifacts in the biochemical analysis. Because after odontology, we give our sample for the genetic analysis. So what we do is we scan individual element and then reconstruct it digitally. So we have the copyrights and the entire form. I'll show how we have done the entire work in terms of virtual reconstruction for incinerated fragmented dental remains. Because during COVID, there were many such fire cases in Gujarat, talking about the Surat case, talking about many such factories in Ahmedabad and nearby. There were such fire that human remains were recovered. So we normally document it, normal photography. We scan it, like each and every individual, and we know what exactly the anatomy is, because we were taught the dental anatomy as well as the general anatomy in the first year, right? So we know the basic anatomy, and we try to create the entire reconstruction virtually. That's how we pinpoint and create the entire specimen. So from one 4-5 fragmented, we created one, and if needed, we 3D printed. Or else we can use this file for all the digital analysis. Okay. Lastly, this is the facial reconstruction part. We have been using these days more of the 3D part, that's high-end softwares. So both the manual as well as digital. So we have an in-house digital software that we are validating. Okay, because we have different methods of creating the face. So which face, if I give, just like tooth carving, okay, so you have been asked to carve a central incisor, but if you carve and your friend carve, it would be quite different. So it's more of artistic, but with the help of the scientific modality. So we have been validated, like we have validated the manual method, we are yet to validate our digital method, it is in process. So that's how we create the face. We first get the digital data of the skull. We create a lot of tissue depth markers on the frontal part, create the face, the eyeballs, muscle, because we know insertion and the origin part, right? And then we create the entire, the parotid gland and the face. So that's how we are doing it. We have been using this modality in largely in cases of forensics. So you can see this is a civil hospital where we go for all kinds of investigation. So I use my scanner, I document it so the way we understand the cause and the manner of the death. This is one of the case which was referred from Maharashtra, Sion Hospital, the professor and head, Dr. Rajesh Tiresa. He made a call last year in the month of October that there's this kind of body. It's very decomposed, mutilated body. Can you help us in identification? I was like, Dr. Sir, you are professor head in forensic medicine. You need my assistance in terms of dentistry because you can definitely do the entire profile. He was like, yes, I need your assistance in terms of 3D part. I said, okay. What we did is we did the CT scanning of the specimen. We did the CT scanning and then we printed it. After that, we did the entire reconstruction and facial superimposition. We took the help of IIT Mumbai for 3D printer because at that time I was traveling to Africa for some of the university work. So because it was a very confidential case, we didn't want the specimen to come to my lab when I'm not there in my lab. So we got entire CT scanning done at the Sion Hospital and the printing at the IIT Mumbai. We did the entire forensic facial superimposition and reconstruction in this particular case. Then we got one more request from the Tripura State Forensic Science Laboratory where they wanted 3D analysis from the dentures. So here you can appreciate a denture was recovered from a crime scene, a scene of incident, and that was given to our lab. We did the entire scanning of it, we did the entire analysis, and we gave the entire report stating who the person could be, male, female, so and so, because we know, we were taught about the spa factor, okay, the personality, the sexual part, in identifying, on selecting the team. So that's how we related. Talking about the work, whatever I've been speaking is based upon the R&D, what we have done, both in Indian as well as international journals. And yes, digital technology could revolutionize and reshape the entire forensic world. It has been doing both in medical as well as dentistry. So, but it is very important that you should acquire appropriate knowledge. So, with appropriate knowledge and utilization of the digital techniques, innovative approaches can be implemented for identification of our general practices. So that's it from my side. Thank you so much for your patient listening. And if there are any queries, you can email to me or contact me. Thank you. Any questions? Okay, thank you.
knowledge with us. Architecture is the visual art. Dentistry is the art of smiles. Bringing both of these together, we have Mr. Pratik Shah among us to give an idea of dental clinic designs. All the way from Rangilu, Rajkot, Mr. Pratik Shah, everyone. A huge round of applause.
Hello everybody, I'm architect Pratik Shah. I'm not a dentist. Uh, Today I'm going to talk about how to design a technical yet aesthetical dental clinic. First of all, I would like to thank CynoDent and Greets for inviting me for this lecture, Dr. Kamal Bagra sir and his team. I'm an architect and interior designer. Me and my team are specialized in dental clinic design. I am also a contributing author in IDA Times and Trendent magazine. We have done almost 75 plus projects pan India. Before few years, I had never imagined that I would be talking to dentist someday, but today I am. And I thought dentistry and architecture are completely separate subjects, different subjects. But dentistry is called art and science, and architecture itself, its definition itself is art and science of designing and constructing building. So there is this beautiful similarity between these completely two different looking subjects. Now you might have seen these Hindi movie scenes where the bone disposable squad goes to the side and at last minute they are confused whether to cut the green wire or the red wire. Similar thing happens when dental clinic has been set up. At last minute, plumbing lines are not fitting with the dental chair, or lighting is not sufficient, or these kind of problems are occurring. These problems occur because we are not pre-planning the dental clinic setup. So the dental clinic setup requires extraordinary teamwork. Design and construction requires extraordinary teamwork. Collaboration and coordination is required between dentists, interior designer, equipment installers, and various agencies. So, for example, an apartment or physician's hospital, it can be given to a contractor to execute. He can easily execute. But dental clinic is not such a thing. It is a very personalized thing, and so teamwork is required. So whenever somebody is setting up a new clinic, the first question which arises is how much money they are going to spend in it. So my question is whether just by spending more money will you get a good dental clinic? My answer would be no. basically there are three pillars for a good dental clinic setup. First is a reasonable amount of investment. Second is detailing, which is personal attention dentist gives to the project. And third and most important thing is planning at various levels. These are the parameters of a dental clinic design. Selection of clinic space, planning of operatory, planning of consulting area, planning of waiting area, plumbing design, lighting design, hygiene and sterilization, storage design, and clinic identity. I am going to talk about each of them. Selection of clinic space. Clinician should be clear about requirements like how many number of chairs they want to set up, kind of X-ray machine they want to use. Natural light and ventilation are very much essential for dental clinic. So nowadays there are these commercial buildings without any windows, without any natural light. So these kind of spaces are not advisable to buy for dental clinic setup. Pre-planning of layout is required before buying the space. Possibility of expansion should be thought of before buying the space. If you buy a space in a commercial building, you don't have a control on expansion. Functioning of layout. These are basic functions of a dental clinic: waiting area, consulting area, dental operatory, laboratory, operation theater in case of oral surgeon, washroom, and pantry. Now, as you can see, this is an image of four-ended dentistry. And as you can see, 7 o'clock to 12 o'clock is dentist zone. So there should be enough space around the chair for doctor and assistant to move and to work comfortably. Some of the specialties need to work more at 11 o'clock and 12 o'clock positions. So there should be enough space behind the chair as well. This is a diagram of minimum required space for one dental chair. So if the dental chair is in a separate operatory, there should be minimum 12 feet by 8.5 feet space for one chair along with a small platform. And when the chair is inside a larger operatory, there should be minimum 7 feet by 10 feet space for one dental chair. This is diagram of minimum required height for dental chair. Dental chair would need 7 to 7.5 feet height. There would be 4-inch underfloor services like plumbing lines. 5-inch would go in false ceiling, and if there is beam or fan above, around 12-inch space would go in there. So total around 8.5 to 9.5 feet height is required in operatory area. And if the height is less than this, there are chances of light arm conflicting with fan or ceiling above. Planning of operatory. There are two diagrams. On the left diagram, you can see that chairs are positioned towards operatory door. It is positioned opposite to the wall. In this kind of scenario, the patient who is being treated would be constantly distracted by movement of assistant and doctor. Assistant going from operatory to lab, a new patient coming inside the operatory. And on the right side diagram, you can see that chairs are positioned towards the wall. It is opposite to the operatory door, and so patient who is being treated will not be distracted by the movement of patients, new patients and assistant. So this right side diagram is advisable. There are three, now I'm going to talk about planning of consulting area. Basically, three possibilities are there for consulting area. As you can see in the topmost image, it is a small operatory. with a consulting table inside the dental operatory itself. In second image, you can see that there is half partition between consulting area and operatory. And in third image, you can see that consulting area is completely separate from the dental operatory. Patient movement. In left diagram, you can see that patient will enter from waiting area to consulting area, and then patient will go to operatory. But in right side diagram, you can see that patient can directly enter from waiting area to operatory. The dentist can examine the patient in operatory and then take the patient to consulting area for explaining the treatment plan, and the patient can directly come out in the waiting area. So this kind of loop movement is also possible in designing. Now I'm going to talk about planning of waiting area. Patient experience is essential for a new age dental clinic. Loud decor is not necessary. Overall ambience must be relatable and uncluttered. The goal is not to impress patients, but it is to relieve anxiety. Keeping one wall for treatment details is fine, but we should avoid overdoing. Filling up all the walls and glass with dental pictures doesn't create a soothing environment. Now I'm going to talk about plumbing design. There are basically 4 lines attached to dental clinic in terms of plumbing. That is water inlet, wastewater outlet, air inlet from compressor, and external suction. As you can see in the image, there is one chair which has plumbing lines and electric lines visible on the floor beside the dental chair, and the image below doesn't have any plumbing lines exposed. All the plumbing lines are under the floor. This kind of pipeless wireless look is possible, and for that a 10 by 10 inch plumbing chamber has to be made exactly below the dental chair. So all the plumbing lines would directly attach to the dental chair. This kind of pipeless wireless look will not only be aesthetical, but it will also provide hassle-free movement around the chair. Wastewater outlet. So drainage blockage is considered common in dental clinic, and to avoid drainage blockage, we advise to put separate drainage pipelines from each chair and not to combine them together. And we also advise to go for Y joint in plumbing line instead of a T joint. We advise to go for a nani trap, which is called NT. This NT should be below each dental chair. NT will provide water seal and it will block the smell. For a compressor inlet pipe, we advise to go for multi-layer bendable pipe like a Kitec pipe. This kind of pipe will provide a jointless and leak-proof connections. Now I'm going to talk about lighting design. Lighting design is a very important subject of dental clinic setup. To reduce eye strain, there should be different lighting sources at same time, which includes natural light, ambient light, and task light. Ambient light is this LED fixtures which are installed in ceiling. They are around 700 to 1000 lux. Pre-operative task light are these big halo lights which can be installed exactly above the dental chair. They should be around. Task light are the lights which are installed already on the dental chair. They should be 10,000 to 50,000 lux, and maximum natural light is advisable in dental operatory. Shadow-free lighting is important in operatory, and for that we should avoid decorative and yellow lighting in operatory because it will distract the surgery procedure. In operatory, there should be even and homogeneous lighting, like the image on the right side. Natural light is considered as best condition for shade matching, and it also creates pleasant work environment. So natural light is very important. Storage design, these kind of portable trolleys can be made, and drawers and things like that can be as per dentist's own requirement. This is a diagram of ideal sterilization room. There is dirty zone and clean zone. The entry should be from dirty zone to clean zone, and airflow should be from clean zone towards the dirty zone. Clinic identity. In today's competitive environment, it is important to create a unique identity of your clinic. For that, clinic logo can be part of interior, and you can also do branding. So same color theme and same color palette can be used in interior, in stationery, in visiting card, clinic name board and website. Now I'm going to show you some of my projects. This is Roots Dental Clinic, around 675 square feet. It has 2 chairs and a small operation theater. Clinic entrance. Waiting area. Consulting area. Operatory. Operation theater and sterilization room. This project was awarded Best Dental Clinic Interior in India in FemDent Awards. Thank you. This is SAP Dental Hospital, around 1400 square feet with 3 dental chairs and operation theater and small recovery room. You can see that there is separate entry for operation theater and recovery room. Clinic entrance and reception desk. Operatory area with 2 chairs. Third chair is in separate operatory. Waiting area. Consulting and operatory. Clinic entrance from outside and operation theater. This is Florence Dental Clinic. This is my first dental clinic project. It is a small single chair separate operatory in an existing hospital. This is for my wife. My wife Ina is a periodontist. This is a pediatric and orthodontic clinic in Jodhpur. It is a dedicated kids play area. Dental chair customized specially for this project. This is Sure-Align Orthodontics for Dr. Ajay Kumar, sir. As you can see, there are no graphics on the glass, there are no graphics on walls. The idea is to create a soothing and tranquil environment. Here consultation is kind of different. There is no, it is like a mini conference room where patient and dentist both sit on same kind of chairs. Waiting area and reception desk. Thank you for listening.
talk, and today my lecture topic will be on composite in today's world, ease, strength and beauty. So what do you have to expect from this lecture will be, I'll be covering on the introduction, the mattressing part, the evolution of dental composite, and a case of midline diastema treated using a bioclear matrix. We'll then talk about in detail about bioclear matrix and then conclusion and references. So as we are all dentists, the first thing that we notice about anyone is their smile. So how many of you here, when you look at a person, it's the smile or the teeth that you first look into after graduating in the dental school? Only one, only two, three, four, five. So aesthetic plays a very important role, right? And also human teeth are designed in such a way that they are provide the support to the teeth and also to the arch. So what happens when there is a break in the continuity of the contact area? It actually throws more responsibility to the periodontal ligament and the alveolar bone, which they are not designed to sustain. So, how do we go about establishing the contact areas or interproximal contact, the natural convex anatomy of the tooth? There has been many mattressing system and that has been in use till now. I would like to give a brief overview of all the mattressing system and then talk about bioclear matrix that I have used with the treatment of midline diastema. So, as you can see from the slide, these are the various mattressing systems that are in use. And I would like to give a brief overview on each of the mattressing system and how it has to be used or how it plays a role in establishing the contact point or the interproximal contact area. So this one is the convex CT, which is actually a pre-contoured band, which can be used either buccally or lingually or occlusally and gingivally. So there are actually two types of convex CT band, the convex CT and the convex CT S2. The difference being the difference in the width. So the convex CT is actually 5.5 millimeter and the convex CT S2 is 6.3 millimeter. So both of it is helpful in establishing the contact point and the interproximal contact area, and also it helps in establishing the natural convex anatomy of the tooth. Coming on to the Paladin sectional matrix system, it is again further divided into the Paladin Plus and the Paladin Plus EZ coat matrices. So both of them, they have a separator, they have a sectional matrix. So can anyone tell me the advantage of a sectional matrix? Anyone? So yeah, the advantage of sectional matrix is the ease of visualization of the operating field, and it also helps in establishing the tight interproximal contact point. So the Paladin Plus and the Paladin EZ coat matrices, they are actually the biting spring night-eye rings, which are used for establishing the contact areas. And the Paladin Plus EZ coat mattresses, they are available in 5 different sizes, like from 3.5 to 7.5. And also they are color coded, so they can be used for premolars and molars separately. The light blue is used for the premolars and the dark blue is used for the molars. Coming on to the Fendermate, this is actually a one-piece sectional matrix and a wedge that can be inserted either buccally or lingually. And this also helps in establishing a tight proximal contact point. And the wedge that is facing the adjacent tooth, it has an angled wing, as you can see. So this wing actually presses the matrix band towards the preparation, and the advantage of using a Fendermate is that it helps in establishing the contact point, the cervical contact point very precisely. And coming on to COMC type system, the COMC type system, as you can see from the picture, it has a ring placement and a wedge placement forceps, and there were further modifications in COMC type system, and it includes the COMC type gold and the COMC type silver system, and also they are available in various color codes. and the most commonly used one is the orange. It can adapt to all the natural anatomy of the tooth, and the gray ring is used for conditions where it is difficult to adapt the ring. You can say in premolars, between the premolars, molars, and in short or mal-positioned teeth, composite type gray ring is used. And also to prevent the bonding of the composite to the band, there is a composite type slick bands are also available. And this is the Metafix matrix system. So you can see from the image, it also has an integrated tightening opening device, and it is considered to be the ideal solution for class 2 MODO and MOD restorations, and the band thickness is about 0.038 mm. So this actually prevents the distortion of the matrix band when it is placed. Coming on to the next is the V-ring sectional matrix system. The V-ring sectional matrix system, it consists of a night-eye ring, which actually gives the strength and resiliency. And the further modifications include the V3 blue ring. So in V3 blue ring, the night-eye ring is actually replaced by the plastic ring. And this is how you go about placing the V3 blue ring. And next we have the V4 clear metal matrix system. So this matrix system, it has a transparent matrix that helps in achieving a clear enamel resin polymerization, pure resin polymerization. So coming on to the topic for today, it's the BioClear matrix system. So the BioClear matrix system, it actually can be used for both anterior and posterior restorations, and they are available separately for midline diastema and also for restorative purposes. And the cervical curvature, the width of the BioClear matrix in terms of its cervical curvature varies, and the main advantage is that it can be used without a wedge, although there are 3 wedges that are available in the kit. And it includes the Saber wedges, the plastic wooden wedges, and the interproximator. So the Saber wedges actually they help in achieving the polishing or the shaping of the composite restorations. So this is the interproximator strip. And next we have the tetra ring, which is actually, it looks like a ring with 4 ants, and it also has a clear matrix. So this can also be used in case of posterior restorations. So as you can see from the image, the A102 is used in case of upper distal, and the DC202 is also used in case of upper distal. One is for the restoration and the other one is for the diastema closure. So depending on your purpose of use, you can select whichever matrix band that is feasible for you. So the main advantage is that its anatomic shape actually prevents the composite overhangs, and it also helps in achieving composite clear finish in the interproximal area. So there is no fear for any overhangs in the embrasure area. And this is the matrix image, and this is the matrix ID. So the A101, it actually denotes for the upper mesial, and they have a curvature of 0.5 millimeter. And the facts include, they are also made from a 50 micron mylar strip. They are anatomical shape, they are flexible but strong, and it focuses on the cervical half of the tooth, and it has got customizable contours. So these are various types of BioClear matrices that are available. And depending upon the size or the width of the diastema that is present, you can also choose the matrix according to that. So here we have treated a case of midline diastema using a nanofill composite and a BioClear matrix. So as we all know, the first introduction of the composite was done by R.L. Bowen in 1962, and it was the macrofill composites that were first introduced. And can anyone tell me what is the disadvantage of a macrofill composite, or what is the drawback of a macrofill composite? So So the drawback was a difficulty to achieve polishing or finishing and aesthetics. So in order to overcome this long-term effect of aesthetics, microfill composites were introduced, and following which hybrids and nanofill composites were introduced. So the microfills were easily polishable, but they had a low strength because of low filler particles. And when the conventional composites were grinded, it also led to the introduction of the hybrid composites, and further modification in the hybrid led to the microfillers and the microhybrids. So, in case of a microfiller, the nanofiller particles were actually added along with the pre-polymerized resin filler particles, and they were termed as the nanohybrids. So, this just shows an image of the evolution of the composite. So the first macrofill composite was introduced in 1970, followed by the microfill composite, and 1990 hybrid composite, and as the millennium arrived, the nanofiller composites were introduced. So according to Bain and Neyman, these are the filler particle size of macrofill, midfill, minifill, microfill, and the nanofill. So yeah, as I previously told you, the advantages or the drawbacks of the macrofill, these are various articles or various authors who have supported the fact. Lamberts and Venner. In 1980, hybrids arrived, and a combination of larger fillers for strength and smaller particles to pack into the spaces between the larger particles. And then these composites were strong, but early hybrids were still not very polishable, according to Powers et al. So these are some of the study. So I'd like to move on to the case presentation. So it's very simple. You have to correctly select the matrix size, and the etching, bonding, and all the other steps are the same. But the matrix plays a very important role over here in building the interproximal contact. So this is case 1, where we have used a biocare matrix and nanofill composite. This is the pre-op of the patient, and this is after diastema closure using the biocare matrix. So this is the post-op. So this was the pre-op. As you can see the space. So then followed by etching. This is the frosted appearance, as you can see. And then we bond and place the matrix. So it doesn't require any wedge, as I previously told. So this is how it is at the end. So you get a very proper interproximal contact and a proper finish. So these are various articles to support the use of nanotechnology or the nanocomposites. As we know, the nanocomposites actually have flexural strength ranging from 153 to 177. And also the direct comparison showed that the flexural strength of nanocomposite were even higher than the other composites. So these are various supporting articles. And also Turkin and others reported a higher retention rate for the nanocomposite. And Pontes et al. Reported significantly higher flexural strength of a nanocomposite compared with the hybrid. And coming on to conclusion, it can be said that performing a direct anterior or posterior composite restoration with ideal contacts and contour is no longer a cumbersome task. And depending on the feasibility, the knowledge and skill, it is for the operator to decide the appropriate matrix system to corroborate composite with natural contacts and contours, and finally improve the longevity of the composite restorations. Thank you all.
બેટરી લાવો ફટાફટ. 6 ચાર્જ છે તું જોઈ લે.
We are waiting for the Dr. Moon and Dr. Ashish. Dr. Kamal sir, Dr. Meir sir, Dr. Anmonan, please come on stage to felicitate Dr. Abraham Johnson sir. I invite Dr. Ashish sir on the stage.
Yes, please. Okay.
Dr. Krishna Shah. Put your hands together.
Sorry, my lecture is last, but felicitation is done before.
Yes, please. Okay.
The only architect present here, Pratik Shah. Louder. Dr. Tarun Vyas.
In my presentation is left.
Dr. Kadambari. Guys, wake up. Dr. Nayan Patel.
પેલું નામ બોલતું જો બોલતો એવું નામ બોલે તરતી આવે
Dr. Abhishek Dubey. Dr. Yesh Sharma.
Lakshmi Pandey. Dr. Lakshmi Pandey. Dr. Pradeep Bam. Thank you, sir. Thank you, ma'am. Women with a voice is by definition a strong woman. You educate a woman, you educate a whole generation once again. Inviting an exceptional woman on stage, Dr. Krishna Shah, a lecturer in Department of Periodontology from College of Dental Science in Bhopal. Please put your hands together.
Very good afternoon, one and all. Before some time, I was sitting in the back. Most of the people were thinking, oh, ये इनका lecture होगा. So myself, Krishna Shah, I am a periodontist. Today I will be taking a lecture on periodontal disease and systemic health. You may find it somewhat theoretical, but it is very well important in clinically also. So, why we take history? Why we ask the systemic history of the patient that we will see here today. We may find it very boring when our professor asks us to say that please take history, because मैं भी जब पढ़ रही थी, मैं भी UG PG में थी, I also find it very boring and sometimes we used to skip also कि चलो ना अभी चालू कर देते हैं patient. So the audiences all are UG students, PG students. Please raise your hands. Who are UG? Okay, most of them are UG, right? Do you take history? Do you ask the patient about the systemic history? What do you ask? Do you have diabetes, blood pressure, whether taking any medications, right? Anything else? Anticoagulant therapy, yes. That is also important because it affects the bleeding time, clotting time in our surgical procedure. So, periodontal health and systemic health is a two-way relationship. How systemic health also affects the periodontal health and periodontal disease also affect the systemic health of the body. How we will look into the slides. So, you can see it is a two-way relationship. Influence of systemic disorders on periodontal and impact of periodontal infection on systemic health. Those who are students, this is a long question in your paper and I have made it in a very concise manner that how both are affecting each other. So you can jot down the points if you want. These are the systemic factors, endocrine influences and hormonal changes, which includes diabetes mellitus, female sex hormones, corticosteroids, parathyroidism, hematologic disorders, which includes leukemia, anemia, thrombocytopenia, antibody reaction disorders, immunodeficiency disorders, genetic disorders, stress and somatic disorders, which includes stress-related immunosuppression, depression and coping, stress-influenced periodontal therapeutic outcomes, nutritional influences, vitamin deficiency, vitamin fat-soluble and water-soluble vitamins, medications like bisphosphonates, and other systemic conditions like hypophosphatasia and metal intoxication. First, we will see about endocrine disorders, which mainly includes diabetes mellitus. Most of the systemic patients, we find it very commonly diabetes, hypertension. These two systemic disorders are very commonly found. How it affects. So, first we are seeing systemic disease to periodontal health. So, in that, it modifies the tissue response. How, like, it alters the collagen metabolism. It alters the pathogenic bacteria. It affects the healing capacity of the tissues. We know the complications of diabetes mellitus like retinopathy, nephropathy, neuropathy, microvascular disease, altered wound healing, but periodontal disease is also a complication. The oral manifestations seen in periodontal disease are cheilosis, mucosal drying and cracking, diminished salivary flow, alteration in bacterial flora, altered rate of dental caries. Effects on periodontium mainly are enlarged gingiva, gingival polyps, abscess formation, teeth loosening, impaired defense mechanism, susceptible more to infection. How impaired mechanism? Because the antigen-antibody reaction is impaired in diabetic patients. The healing capacity is also impaired in diabetic patients. How diabetic influence on periodontium. These are the primary changes: subgingival microbiota, which intercept specific microorganisms, GCF glucose levels. More glucose is found in GCF, periodontal vasculature, host response, collagen metabolism, AGE formation is there, so the collagen repair formation is impaired. Management. How we will treat the diabetic patients when patient comes to us and if he says that he is diabetic, then how you will plan this therapy, at what time and what you will take care, that I have written here. First, the diagnosis is important. For the diagnosis, you ask the patient whether you are taking medicines, what is your last glucose levels. So you ask for the RBS, fasting blood glucose or postprandial glucose, and ask about the HbA1c level. And from the studies, we have concluded that well-controlled diabetes patients are similar to the non-diabetic patient for the therapy. Then, well-controlled with supportive therapy have shown to maintain results 5 years of the combination of non-surgical and surgical treatment. And short-term non-surgical treatment in stable diabetes has been found to compare to controls only. How to schedule your appointments? Generally, we will keep morning appointments. It is capped when the insulin level is not at its peak level. You ask the patient to have the regular diet, to have the regular medicines. Before surgical procedure, they should have diet properly. And if it is altered in some or other way, then ask the physicians about their change in the medication. Common medications such as sulfonylureas, negletimides, and insulin are associated with hypoglycemia in diabetic patients. Sometimes patient doesn't come without eating. If he comes without eating, then there are chances of hyperglycemia during the procedure. Now, female sex hormones and periodontium. There are various phases in females' age like puberty, menstruation, pregnancy, and menopause. Now, all have its significance. Puberty, you have heard about the pubertal gingivitis. In 2004, higher gingival indices during ovulation and before menstruation, despite reported increase in oral systems due to the changes in hormones like estrogen and progesterone, they find many changes in the gingiva. Then menses. During menses, there is increased progesterone, which leads to gingivitis. There are chances of aphthous ulcers, herpes labialis, and candida infections. In pregnancy, pregnancy doesn't itself cause gingivitis. There must be some local factors like plaque calculus to cause gingivitis. More it is seen in the second, first and third trimester, mostly in the second and third month, and in the third trimester. Hormonal changes causes change in vascular permeability, that is, vasodilation occurs, leading to gingival edema and increased inflammatory response. This is pregnancy granuloma, that is epulis. There is raspberry-like appearance, which on just touching, on pinpoint touching, it bleeds like anything. So mostly it is treated after the parturition period. Patient on hormonal contraceptives also aggravate the gingival response when it has been taken for more than 1.5 years. Menopausal gingival stomatitis. Patient complains of dry mouth. Patient says, "Mane taste nathi avto jumma, mane dryness lage chhe," like that. Fissuring, altered taste sensation. Menopause and osteoporosis. Obviously, in menopause age, women are of around 50-60 years, and there are chances of osteoporosis also. Hyperparathyroidism means there is increased secretion of parathyroid hormone, also known as brown tumor. There is widening of PDR spaces, radiolucent cystic-like spaces. There is demineralization of skeleton, increased osteoclastic activity, proliferation of connective tissue in the marrow spaces are seen. This we generally don't find, this is theoretical. Hematologic and immunodeficiencies, as I told, what it includes: leukemia, anemia, thrombocytic disorders. In leukemia, obviously there is increase in leukemic cells, so leukemic infiltration of gingiva occurs. This creates gingival pocket, leads to secondary inflammatory lesion, and it leads to gingival enlargement. What are the oral manifestations? Gingival hemorrhage is a very common finding. Bleeding is an early sign. It is greatly altered and degenerated gingival tissue that is extremely susceptible to infections. Anemia, mostly found in Indian population. What is anemia? That is blood loss. It may be because of blood loss, defective blood formation, increased RBC destruction, or it may be there is reduction in circulating erythrocytes or decrease in amount of hemoglobin, or there is deficiency in the quality and quantity of blood. There are 4 types of anemia, as we all know: sickle cell anemia, iron deficiency, pernicious anemia, and hemolytic anemia. These are the oral manifestations of anemia. Commonly, there is glossitis, dysphagia, paler mucosa, increased susceptibility to infection, tongue is red, smooth and shiny. Thrombocytopenia means the platelet count decreases. There is prolonged clot retraction time and bleeding time. There is spontaneous bleeding from the skin or mucous membrane. Petechiae-like appearance and hemorrhagic vesicles are seen in the oral cavity. Gingiva are soft and swollen. So we need to protect proper history of the patient. Genetic disorders include neutropenia, Chidia-Higashi syndrome, lazy leukocyte syndrome, Down syndrome, and Papillon-Lefevre syndrome. High prevalence and increased severity of periodontal destruction are seen in all these disorders. Stress. Stress is a kind of psychophysiological response what the organism gives to a challenge. It may be because of any family issues, any financial issues, or any working issues. So what it leads to? It leads to behavioral change of a person, which leads to is poor oral hygiene or poor compliance due to his less care, which leads to increased bacterial infection and which can lead to periodontal infection. Then another chance is behavioral change can make the person lead to smoking or make him overeating, which leads to increased cortisol production, which depresses immunity and which leads to periodontal disease. These are some studies. Nutritional influences. Balanced nutrition is very important in a person. Effect of nutrition can produce changes in the oral cavity, but it doesn't themselves produce gingivitis and periodontitis. There must be some local factors present. Fat soluble vitamin deficiency, that is A, D, E, and K. Vitamin A deficiency leads to hyperplasia and hyperkeratinization of gingival epithelia and retarded wound healing. Vitamin E, which serves as an antioxidant to limit radical reactions. Vitamin D deficiency, which leads to inflammation and delay in post-surgical healing. Water-soluble vitamin deficiency, B complex vitamins. Generally, we prescribe patients when they come with the ulcers, we prescribe vitamin B complex. So the common changes are gingivitis, glossitis, angular chelosis, inflammation of the mucosa, vitamin C deficiency, which is very important for the collagen metabolism. So, if the collagen is impaired, there is increased susceptibility to infection, impaired wound healing, bleeding, and swollen gums. Sometimes the tooth become loose. What medications are affecting are bisphosphonates, corticosteroids. Bisphosphonates induce osteoradial necrosis of the jaw, might be have heard. Corticosteroids, increased exposure to endogenous cortisol, have adverse effect by reducing the immune response of the organism. Anticonvulsants, this is very commonly seen. Patient on phenytoin like drugs are we can find the drug-induced gingival enlargement. Immunosuppressants like cyclosporine, calcium channel blockers. Mostly the hypertensive patients are under the calcium channel blockers like amlodipine. We find it very commonly seen the enlargement. Metal intoxication, bismuth pigmentation, mercury intoxication, and lead intoxication. Now, the other part is impact of periodontal infection on systemic health. Can the infection of the periodontium have an effect remote from the oral cavity? Yes, it has. Is periodontal infection a risk factor for systemic disease that affect human health? Yes, it is. How? William Hunter gave the focal infection theory. How and in what system the periodontal disease affect our cardiovascular system, endocrine system, reproductive system, and respiratory system. In heart disease, mainly what is the reason is thromboembolism or atherosclerosis, that is narrowing of the arteries, occlusion of coronal arteries, which may lead to ischemia and angina. Now, what happens in periodontal infection is there is increase of fibrogen, increased white blood cell, increased von Willebrand factor, which leads to increased blood viscosity. So, as the blood viscosity increases, there is chances of occlusion of coronary arteries, which can lead to ischemic heart disease. Gram-negative periodontal organism can lead to increased insulin resistance, which is very harmful in diabetic patients. So the glycemic control is reduced, which can lead to increase in hyperglycemia. So by periodontal treatment, we can improve the insulin sensitivity and glycemic control. The consensus report of the joint has shown that by treating the diabetic patient, by removing the infection, the HbA1c of the patient has been reduced in 3 months. Periodontal disease and pregnancy outcome. Mostly the lay women must not be knowing how the gingiva are important during the pregnancy period, because it may lead to bacterial vaginosis, preterm labor, or low-term birth weight. There are increased chances of preeclampsia, that is, there are chances of hypertension in that period. Periodontal disease and chronic obstructive pulmonary disorder. There is still the research going on, the relation between this, but some studies have shown that there are increased risk of COPD in those with periodontal disease than that to controls. Periodontal disease and acute respiratory infections like pneumonia, and I don't have to give you the example, as we know that COVID-19 is coming back. there is a relationship between periodontal infection and COVID-19 infection because COVID virus is associated with exacerbated inflammatory response which leads to fatal outcome, which is the main characteristic of periodontitis because the inflammatory mediators are increasing. And the study is still been going on. Many articles have been there, finding the relationship between periodontal disease and COVID-19. So, dentists need to appreciate the wide range of systemic disease and have periodontal implications to modify the treatment. And in some cases, the dentist may be the first doctor to diagnose systemic disease based on its oral presentation. Without periodontal health, endo, prosto, implants, none of the treatment is possible because without the gingival health, without the bone, there is no successful of the treatment of any other field. So, periodontal health must be taken care, and we have to ask the patient. We have to make them understand that how important it is. Thank you. Any questions? Any query? Okay, thank you. Thank you so much, ma'am, for your exceptional insight in periodontology. Now I'd like to invite on stage an influential person from Department of OMDR in Vyas Dental College and Hospital from Jodhpur. Please put your hands together for Dr. Tarun Vyas.
Good afternoon, all of you. Today, topic of my presentation is oral cancer diagnosis and current perspective in India. Literally, an illness that spread dangerously, pathologically characterized by the proliferation of the anaplastic cells that invade surrounds and metastasis to the new body sites. That is about the cancer. Now, what is cancer? And any uncontrolled growth of the cells that invade and cause the adjacent tissue impairment is known as the cancer. India has the highest number of the oral cancer and about 1/3 of the total burden globally. As you see these slides. Now, total of the oral cancer in India is about 75,000 to 80,000 of the year of the new cases of the oral cancer, the world highest number of incidents. In this, 52,000 of the deaths are reported annually. This is the scene in India. Now, cancer in the mouth can be squamous cell carcinoma. These are the pictures which I have reported from my PG and to my college, about 84 to 97%. Now, malignancy in the salivary gland, that is major to the minor, as you see to the parotid to the minor salivary gland. Now, to the melanoma, to the Kaposi sarcoma, to the lymphoma. These are the pictures to the melanoma, to the Kaposi sarcoma. As you see, these are the Kaposi sarcoma. Sorry. Now, these are the odontogenic sarcoma pictures. These are the ameloblastoma. This leads to the OSSC, that means the carcinoma. Now these are the secondary from the other focus. This leads to the SCC, that means the carcinoma. OSSC commonly results from the potentially malignant disorder like OSMF, leukoplakia, like lichen etc. What are the risk factors of the oral cancer? That is tobacco, alcohol, age, diet, HPV, family, genetic predisposition, and dental factors. Tobacco, gutka, alcohol, etc. are the acknowledged risk factor of the oral cancer and contain the potent carcinogens. Due to the easy availability and cheapness of the tobacco and gutka, younger populations, especially the students, are getting affected. By this time, they realize the harmfulness of these products. It's become too late. Along with the physical and mental trauma to the family, and then the family get more affected. It leads to the mortality. What do you mean by the mortality? It means the death rate and the morbidity. Who use the tobacco product most? All the category of the society more common, which that is the drivers, students, business people, and the laborers, which I have seen in my time periods. Reason for the popularity of tobacco products. Why the tobacco products are being more due to the advertisements, attractive products, easily it being availability due to the low cost, less objection for the elders, lack of awareness regarding the harmful effects of the gutka. Then magazines and televisions of the advertisement lead an independent life, like become a he-man. As you see the advertisements for this, to take a risk, tempting to get a good friend, taking a good, a cool or enjoy life. Like you see the attractive packets of the pan parak, Vimal or Gutka products. It's a Manikchand or Gutka products. It become a very attractive product to each and everyone. Now it become a very easy available in the markets. Excuse for eating gutka. Why person eat gutka? It reduces the work burden for each and everyone. Not able to have a food income, but person eat it. Working in shifts to reduce the mental tension. Person have a mental tension reduction. It reduces the mental tension to have a working in shifts. Be gutka. Excuse for smoking. If you ask the person why you are smoking too much, smoking gives him more energy. Smoking is a pleasure for him. Smoking helps him to relax him. Everyone says tell like this. Now, what are the total tobacco consumption in India? You see, in 1980, it is about 85 million kg per year. In 1920, it is about 25 million per kg year. In 2005, it increases about 300 million per kg year. In 2019, it is increases about 500 million per kg per year. So it is increasing day by day. So the cases of oral cancer is also increasing by day by year. Now, Indian Dental Association, you see, 70% of college students use this tobacco in one or the other form. So it is our prime concern that we should not use this tobacco in one or the other form. Now, also due to the advancement in the medical science, the treatment of the oral cancer is available. Treatment is always available, but still the prevention is always better than the cure. Being a dentist of duties of the society is educate our countrymen about the harmful effect of the tobacco consumption. A key factor of the lack of improvement of this statistics, a significant portion that we are not diagnosing until they reach the advanced stage. So catch them in the young stage. So we always catch them in the early stage to in the final stage. Early detection and timely treatment dramatically reduce the death rate. So Now, firstly, for them, we should know the TNM staging and the survival rate. Now, what is the TNM staging? For them, we should know about the 5-year survival stage. If if we will get in the stage 1, then there is a more chance for the patient to get survive. That is 80 to 90% patient should get survive. In stage 2, then there is more chances to get survive. That is about 70 to 80%. In stage 3, then there is a more chances to less chances for patient to get survive. In stage 4, about 20 to 30% patient have a less chances. That is about 20 to 30% chances to have a survival. Now, what do we suspect in oral cancer? What are the clinical findings that we get in the oral cancer? That is ulceration of oral mucosa for less than 3 weeks, oral swelling for about 3 weeks, persisting for more than 3 weeks, and dysphagia, hoarseness, unilateral nasal obstruction, particularly when associated with discharge or bleeding, unexplained tooth mobility, burning sensations, unresolved neck mass for less than 3 weeks, cranial nerve involvement, all red and white lesions. And how to detect oral cancer? That is prime question. First, we will do the self-examination. First, we will do the conventional oral examination. Through the hard palate, any tonsillar area, ventral surface, through the mucosa, gingiva. Some sites are highly suspicious, like teeth, hard palate, soft palate. Any highly suspicious area, we will meticulously examine, like soft palate, retromalar tongue, buccal mucosa. If any we think highly suspicious, we should be meticulously examine it. In this area, if we will think, then we will examine it. Lateral border of tongue, then ventral surface of thing, then buccal mucosa, then vestibule. Any ulceration we will find, then we will meticulously examine it in this thing. Then clinical examination. Oral cavity being an easily accessible area. Any early changes can be noted early in this thing. Then the second thing we will go with the oral cancer is tumor extension. We will forget in the oral cancer is always the tumor extension. Then third most thing is the lymph node involvement. Always student forgot in the oral cancer diagnosis the lymph node involvement. They do not diagnose the lymph node involvement. They do not diagnose the lymph node diagnosis. Site, level, size and number and tenderness and consistency. They always have to diagnose the site, level, size and number and tenderness and consistency and fixity. And how to diagnosis of the oral cancer. Now, biopsy. Biopsy is the gold standard of the cancer of the diagnosis. It is highly sensitivity, but there are some drawbacks for this. This is invasive techniques, but they have a technical limitation in the large lesions. Interpretations by the pathologist, but there are the psychological implications for this. There are many biopsies for this, but mainly we are doing incision biopsy and there are excision biopsy in the oral cancer we are doing. There are incision biopsy which are less than 1 centimeter, excision biopsy we are doing more than 1 centimeter in the oral cancer procedures. What is in this tissue based, they are exfoliative biopsy. In this we are just taking this is a cheaper and easy but less accurate. Exfoliative cytology. This is exfoliative cytology. This is a new technology, exfoliative. This is the oldest which is done in the pathology. Cheaper and easy but less accurate. Brush biopsy with the help of the brush, clean, collect samples and non-invasive and assess with the help of the computer assisted network. Now, adjacent technique used for the detection of the oral cancer. Now, this is the oral cancer diagnosis chart. There are different types of physical examination. First, brush biopsy, liquid brush biopsy, fine needle biopsy, endoscopy biopsy, incision biopsy, exfoliative biopsy. But major we are doing only the two types of biopsy, that is the brush biopsy and the incision biopsy.
and then also the explorative cytology in some cases of cases. Vital staining, mainly the toluidine blue we are doing or methylene blue we are doing. But here I have written something else, but mainly we are doing toluidine blue staining and mainly we are doing methylene blue in the cases of the oral cancer cases. While in the some leukolytic, also in some cases of the pre-malignant lesions. Then the advancement, we are doing the Raman spectroscopy, which are mainly in the other elastic scattering. Then biomarkers, these are the latest coming in the salivary biomarkers. Vital staining, toluidine blue, acidophilic metachromatic dye. In this, what is the procedure? 1% acetic acid on the lesion we are applying, and then rinse with water, and then 1% acetic acid, then toluidine blue is used, and then again 1% acetic acid used, and then rinse with water. And how? Then abnormal area become blue due to the presence of more nucleic acid. It is mainly used in the cases of the oral cancer, but it has one major disadvantage. It cannot be used in the patient of BP and the asthma patients, and it cannot be used in the mentally patient and the handicapped patients. Leukolytic, it can be used in the precancerous patients like spectral leukoplakia. As you see, it color changes from the brown black by the reacting of the glucagon. Now, if a person does not have a toluidine blue, what will be the next? We can use the methylene blue staining, similar to the toluidine blue. So the color changes from the dark blue to the light blue. As you see, the color changes from the dark blue to the light blue. So if a person does not have the toluidine blue, we can use the methylene blue in the place of this thing. What are the latest technology which we are using? Light-based detection system. That is the veloscope. What is veloscope? It works on the principle of the autofluorescence. That is the 400 to 460 nanometer to eliminate the tissues. It have the abnormal light have the principle of the chemiluminescence of the physics, capable of delineating the busy light and illuminates and appear more dark. As you see, this is the abnormal. Abnormal cells, and this is the normal cells. Abnormal epithelium reflect busy light and illumination appear more white. And diagnostic aid for the detection of the oral cancers. So, abnormal cells appear more white, and normal appears more dark. This is the concept of the busy light. It works on the principle of the chemiluminescence, while veloscope work on the principle of the autofluorescence. This is the conofluorescence microscopy. Provide the images of the reflectance microscope with the features of the nuclear images, differences in the nuclear cytoplasmic ratios. What is radiology? As you should know, everyone has the radiology in this, but we cannot get everyone has a picture, conventional radiograph, but we cannot get like SCC, we cannot detect the OSC and the हम कोई भी ओरल कैंसर का पेशेंट आए तो हम नहीं कह सकते कि इसमें पॉजिटिव आएगा ही आएगा, हम उसमें दिखेगा. But some patient have some radiological features like hanging tooth appearance, like in the conventional radiograph. Like in this, if you see, there is a hanging tooth appearance are always seen in the oral cancer. There is a bone loss in the conventional radiograph. Then we are going with the CT. Then we are going with the MRI. Then we are going with the PET scan in the radiology. Now, computed tomography used in the X-ray radiation, widely acceptable and comparatively less expensive.
lesion in comparatively and cannot be determined using the CT. This is the axial view. So this is the axial view. Sorry. Again. Now, magnetic resonance imaging, discriminate MRI assessment for the regional tumor invasive depth for the its lymph node. ये ज्यादातर आप देख सकते हैं ये ओरोफेरेंजियल कैंसर के लिए यूज करा गया है. You see the case of the oropharyngeal cancer. Positron emission tomography PED ये GCRA में भी है तो मोस्ट प्रोबेबली यूज करा जाता है नोडल कैंसर के लिए. स्मॉल नोडल मैट इमेजिंग यूज फॉर द रेडियोएक्टिव एजेंट्स. वैसे एससीटी हार्ट कैंसर में यूज कर सकता है. ओरल कैंसर में इट इज मेनली अवेलेबल इन द GCRA आल्सो. मेजर सेलुलर level metabolic changes, early detection and non-invasive technique. You see, this is the cancer on the lymph nodes and cancer of the right base of the tongue. You see, cancer of the right base of the tongue. This is the CT image. But as you say, this is the PET. Sorry, this is the nodal PET thing. Now, this is the latest techniques that is known as the salivary biomarker detections and the biosensors. Biomarker in general are the components of the cells present in the body fluids or the tumors that overexpress during the onset of the disease. What are the latest biomarkers? That is the TSGP16, TSGP53, Ki67, antigens and DNA ploidy, and some of the most common biomarkers associated with the progress of the oral malignancies. Salivary biomarkers such as circulating tumor DNA, mRNA, and extracellular vesicles assist with the detection of the OSCC. Now, latest are the Raman spectrometry probes. Now, finally, my conclusion is prevention is always better than cure. Prevention, early diagnosis, timely treatment are the critical aspects to tackle the cancer-related burden in India. The conventional diagnostic methodology are expensive, time-consuming, and need expert technicians. Sometimes require surgical interventions. And always biosensor-based oral cancer biomarker sensing technique to possess huge potential to be incorporated in diagnostic practices like salivary biomarkers. Thank you.
Thank you, sir. I'd like to request everyone sitting in the back to come and fill the spaces in the front. No spaces should be left empty here. Please come forward.
conduct, what ethics are you are supposed to be followed in dentistry, how you are supposed, the things which you are supposed to do, things which you are not supposed to do. So I just kept from few slides. So basically, ethics is a Greek word which is derived, which means custom or character. Basically, how a person behaves. So there are a few terms, few things which we are supposed to follow. So basically, it is to do no harm, that is non-malfeasance. To do good, that is beneficence, respect to person, justice, veracity or truthfulness, and confidentiality. So these are some simple terms. To do no harm, that is you are not supposed to harm the patient. If it is just basic class one, not go make sure that it doesn't go for RC. Simple word. To do good, it is to benefit the patients, not to inflict them on harm. Attempt to maximize the benefits and minimize the harm. Respect the person. Justice is described as fairness or equal treatment for giving each person their right or due. Do not be partial when you're treating patients just because you know them or there is some fight, some quarrel or something like that. Truthfulness, the patient-doctor relationship is based on trust. There has to be confidentiality, there has to be trust at the same time. So patient has right to expect all the communications and record pertaining to their care will be treated as confidential. So the photos which we see after the processes is delivered or before and after the dentures and with the processes, even if such photos are being posted on Instagram, Facebook, it is fine, but you are supposed to hide the identity of the patient. You are not supposed to make it public because if it happens, if I post some photo, that photo gets transferred to someone else. Now there are some rules which are given by DCI, that is duties of dentist towards patient, towards one another, and towards the public. So basically, towards the patient is it should the patient we should be courteous, sympathetic, friendly, helpful. We should see the patient at the hour of appointment. Do not neglect the calls, especially the calls which we get in hospital from gynae, from medical departments, medicine, surgery, or from other departments, oral surgery or some departments. So do not neglect such calls. Make sure that you make a note of it, at least note down the timing which at which you have got the call and note the timing at which you have seen the patient. These two things, because this might save you when it comes to oral surgery, especially because there are a lot of cases which go for the court, and in such cases, the noting the time at which the case was the patient came to department and the time at which the patient was treated, this can save. And the emergency management. So BLS and ACLS and BLS you must have heard of. It is necessary that every dentist by the time of internship should know what BLS is, basic life support, and ACLS is advanced cardiac life support. You are supposed to know this because if you are working in an institution, it is fine. If anything happens, you can send the patient to anyone, medicine, surgery, pediatrics, anywhere. If something like this happens in your clinic, it is very difficult to manage. When you have a 2, 1 or 3 chair clinic, it is very difficult because one case had happened in my college in pediatric department. There was a 4 or 5 year child. First time she was getting administered with the local anesthetic agent. 0.5 ml injected, and within 10 to 15 seconds she became cyanodentin. I think it was 5th or 6th minute she was transferred on the first floor, whereas we have the pediatric department. She had to get admitted, she had to be given 3 doses, and then she was stable. So if this even happens in institution, it is very easy to manage, otherwise it is very difficult when it happens in the clinic. So towards one another, the first of all, what happens is we should not criticize other dentists. The moment we have another patient from another dentist and we start talking like this is something which the previous dentist should not have done, this is something which is wrong, this is not allowed. Try not to use such words for your colleagues. It is very wrong because you have no idea at what stage, in which condition the patient, that specific dentist has started the case. So try not to judge or pass on any comments with your colleagues. Towards the public, yeah, you have to be active, you have to be with the other people, you have to be with your colleagues, you have to be with society. There are some unethical practices. This is one of my, I wanted to concentrate on this specific point. So you must have seen, I don't know if you have seen, in my college, I am from Rural Dental College, Muni. kind of rural area. So I've seen such cases with crack processes. I don't know if you've seen this, but this criteria I've seen a lot. During my 3 years of PG, I've treated almost 5 to 6 cases of crack processes. Now these needs to be resected. You see a lot of redness of gingiva. There is so much of bleeding when you resect such processes. I'll just show you one video. Now this is roadside dentistry which is happening, and this is still happening. Look at the instruments, the rusted instruments. So basically using the stone to manipulate plaster. And this is their Hana artery, basically. So this is how the teeth arrangement is done. I think audio is not fine. निकालना पड़ा, कोई ऐसा घाव किया हुआ तो फिर लगाना पड़ता है। महीने में जुलाई में कमाने का काम कर देता हूँ, पैसा जो देता दे देता। वो मीरा करा, वो नाम मीरा का बहुत आई होता है। समझे का कोई काम नहीं करता। Is missing the cold cure powder monomer and polymer. So basically, he is going to do the intraoral teeth arrangement. So this is the unethical practice which is still actually happening in some of the areas specific, which the video which was you have seen is from Varanasi. So there are some. This is basically the first step of unethical practice. The second is
signing of a certificate, any kind of certificate issued for untrue, misleading, or improper reason. Like what we do is getting the certificate attested. So that is again, it should not be done. Direct or indirect advertising, as we have seen, as we can see before and after. This kind of advertising is not allowed. Now this is one of the most unethical things. Just look at the prescription. What here, the MD Ranjit, it is BSc BAM. What you have written is, I'll read it for you. BSOP brandy, 60 ml plus soda 3 times in the evening with roasted peanuts. This is the prescription which is given. This is, I guess, BAMS, Ayurvedic medicine. Again, unethical practice. So what basically is supposed to be done is professional appearance, which is very necessary. So clean appearance when you are working in during your working hours, clean cotton clothes while you are working in lab. Protect your hair while working in lab. This is specific for students when you're working in the prosto preclinical lab or any cluster lab. Make sure that your hair are tight. Close-ended shoes, protocol for protection against COVID-19 24. Now these are some specific requirements which are there because the moment you see a doctor which is like out, t-shirt out, jeans, Crocs, that neckband, AirPods in your ear, it is very difficult to trust. Basically, this is what patient does. Because he'll start judging you with your appearance, and I'm not saying that a person who looks like this is a bad. But as a dentist, yes, you're supposed to have that crisp, sharp image so that you gain the trust of your patient. It is very difficult. Once your patient starts not trusting you, it is very difficult to gain the trust, and once your patient is not trusting you, it is very difficult to deliver that successful treatment. Otherwise, if your patient is, if you have that bond with your patient, no matter what you do, even if something wrong happens, you tell your patient is not going to create any issue out of it. You have to gain the trust of the patient. With the colleagues, there is something which is called as C-splitting, that is cut practice. I'll send a patient to the, just because the patient came to me for prosthesis, completely edentulous, I'll send him for CBCT, just because one of my friend has a CBCT center. Now he'll be charged for 2,500 for a CBCT. The center, the person who knows me will send me the 500. This is called cut practice. This is called C-splitting. Again, not should not be preferred. It is not something which should be done. When you are working in an institution, you are not supposed to take any charges from the patient, which is the receipts which are there as an institution. These are supposed to be followed. Do not take any kind of money from the patient. This is regarding. This is specific for the institution. No ragging. Try to avoid these things because this is something which my sir told me that if you have these habits, what right you have to tell your patient that stop using tobacco, gutka, and drinking and smoking. This is on moral ethical basis. Now this is one of the studies which my faculty has done. So is it ethical to advertise a dental clinic? 22% dentists, these are survey by the dentist, 22% thought yes, 78% said no. Is it ethical to affix a signboard in the pharmacy shop? It is not allowed. Again, I'll just emphasis on that. You're not supposed to fix any kind of your name signature board in a pharmacy shop. So 14% thought yes, 86% said no. Is it ethical to sell the drugs or medicine in his or her clinic? 46% thought yes, and 54% said no. You can do this if you have that B.Pharm or D.Pharm degree. Otherwise, don't do this. Is it necessary to obtain informed consent for clinical examination and for routine radiograph? 58% said yes. Still, 42% were saying no. Yes, you have to have that consent. Records should be maintained for 3 to 5 years. 70% said yes, and 30% said no. It is written, it is mentioned in the DCI Gazette that you are supposed to have the patient documentation at least for 5 years. At least for 5 years. And one of my sir, under whom I have done my PG, my sir has the documentation record since his PG, and he is right now professor. So somewhere around 12 years of data he has of his patients. You are supposed to have that data because you have no idea when the patient will come and school for what damn reason. You have seen that you must have seen a lot of videos where dentists are being beaten up for no reason for some false accusations. Now this is happening on the both sides. The government has given protection from the dentist aspect also. If a patient sues a dentist for something, a patient can counteract that action. I don't know what legally that thing is called as, But yeah, there is a provision that if you have that documentation, if you have that proof, yes, you can counteract that lawsuit. And this is basically why we should have, I think, 4 or 5 lectures before we have seen the clinic, how the clinic is supposed to be set up. One thing love to add in that is just a CCTV camera with a voice recording. It doesn't cost much. It is very easy to install. You can have that server, but make sure that you have that documentation. And I'm telling you, because the compensation which patient keep on asking is not in thousands, it is in 50 lakhs and 70 lakhs. One of my sir told me just few weeks back, I organized video orientation program, and one of my previous principal sir was telling me there was a, you must have heard Glasgow coma scale, Glasgow coma scale. So there is an institute in Glasgow. One of the female patient, she had some extraction or something. She was administered local anesthetic agent. She had some problem. She had paresthesia. Consent was taken apparently before extraction. She had paresthesia. She went to the dentist after 4 to 5 months, and the dentist told her that you have to live with the pain. This is paresthesia. It is going to be persistent for indefinite amount of time. You cannot predict. She said, "You should have told me before the extraction." The dentist said, "Yes, I had informed." The problem was in that complete file, that one specific page went missing, where the consent was taken. She filed a lawsuit for I don't remember the exact amount, which was in pound, but in Indian currency it went for 8 crores. It was a 8 crore compensation which was filed, just because one paper was lost. So this is the importance of a documentation which is supposed to be there in your clinic, in your practice, in your PG duration or whatever you are doing. It is very necessary to have that documentation. So basically, this is what I wanted to tell about is the fact of the very unethical practices and the importance of documentation. Thank you.
Thank you, sir. Now, we are moving towards the valedictory function. I request the audience to be seated for 5 to 10 minutes. After this, the valedictory function will start. Also, don't forget about the post-conference that is happening at the Goenka Research Institute of Dental Science tomorrow. Thank you. And after this function, hosted at the Goenka Research Institute of Dental Science, we request all of you to be present over there. Transport is also provided.
આગળ જવું પડશે મને સ્ટ્રેટેજન
I request everybody sitting on the back seats to kindly occupy the front seats onto my right and to my left. Everybody at the back. One speaker felicitation is remaining. I would like to invite Dr. Ashish and Dr. Anmol to kindly felicitate Dr. Minik Jagdare. Dr. Minik Jagdare, sir. Please just kindly join us on stage. Also, Ryan Minik, sir. Please join us, everybody. All the members of the dental fraternity and all my dear friends. We are coming to the end of the 5th World Dental Sciences and Oral Health Conference and first Global Dentos Cyno Grids organized by CynoDent, Indian Society of Dentistry in collaboration with Goenka Research Institute of Dental Sciences. I heartily welcome you all to the valedictory function. I hope you had a great time in Gujarat with us all the 4 days. I request following dignitaries to kindly join us on stage. Dr. Anmol Bagadia, Dr. D.N. Kapoor sir, Dr. Ashish Pandey, Dr. Chaitali, Dr. Mihir Pandey sir. Kindly join us on stage.
स्टार्ट करेंगे
Now I would request Dr. Mihir Pandey sir and Dr. Chaitali ma'am to kindly felicitate our guest of honor, Dr. D.N. Kapoor sir. Please have applause, everybody. I would request Dr. D.N. Kapoor sir to please felicitate Dr. Anmol Bagadia.
and Dr. Ashish Pandey. I would now request Dr. Anmol, Dr. Ashish, and Dr. D.N. Kapoor sir to kindly felicitate Dr. Mihir Pandya sir and Dr. Chetan. Thank you so much, dignitaries. I would now invite Dr. Ashish Chandra, Organizing Secretary of this conference, Co-Director of CynoDent and Vice President of Indian Society of Dentistry, to say a few words. Dr. Ashish Chandra Pandey.
Good evening, ladies and gentlemen. I, Dr. Ashish Chandra, Director, CynoDent International and Vice President, Indian Society of Dentistry, extend my heartfelt gratitude and congratulations to you for joining us at 5th World Dental Sciences and Oral Health Conference organized by CynoDent International and Indian Society of Dentistry in collaboration with Goenka Research Institute of Dental Sciences. I believe that you have grabbed the best of the opportunities offered by us in these 4 days. We have joined by many eminent and leading personalities of the dental world, and I am sure their presence must have inspired you all immensely. I congratulate the entire team of CynoDent International and Goenka Research Institute of Dental Sciences for the grand success of the conference. CynoDent will continue to help you grow and will stand shoulder to shoulder every step of the way. And lastly, I invite you to join us for the 6th World Dental Sciences and Oral Health Conference at Gandhinagar University in the month of February. We hope you had a great time here and we promise you a great time there as well. Thank you so much. May you have a wonderful day ahead. Thank you.
Thank you so much, Dr. Ashish. I would now invite Dr. Mihir sir to kindly enlighten us with a few words. Mihir sir.
Good evening, one and all. What to say? The experience was beyond words, wasn't it? Millions of knowledge shared, lots of eminent speakers shared their knowledge to us, and I would like to congratulate CynoDent and GRIDS both for setting up an exemplary show. Picture to abhi baki hai. Tomorrow still there is one more pre-conference course day to be contemplated, and I would say God bless CynoDent, God bless GRIDS.
Thank you so much, ma'am. I now invite Dr. Anmol Bagadia to kindly brief us about the conference and give a vote of thanks. Dr. Anmol Bagadia. I would invite Dr. D.N. Kapoor sir to please share his word of wisdom. Dr. D.N. Kapoor sir. Please round of applause, everybody.
Good evening, all ladies and gentlemen.
dignitaries on the dais, especially to name Dr. Anmol and Dr. P.C. Chaturvedi, P.C. Pandey, and Dr. Pandey. They have worked very hard to put up a very grand success, the performance of one and all for all the speakers together from different parts of the country. About 95 of the speakers came and deliberated their skills and presented. I hope every one of us enjoyed the quantum of work that has been put in by them and have been beneficially one and all. My mission and my aim has been all through that one should share the knowledge, exchange word, learn as much as possible. I am sure the effort made by CynoDent, especially Dr. Anmol and Dr. Ashish, you have enjoyed the success, the work of all the speakers, plus a teamwork that has been put in by Goenka Institute of Dental Sciences. My good wishes to all, especially to CynoDent for coming endeavor again. This is fifth successful event in this country. I'm sure the next one will be still better and more cherished by all and everyone in our profession. Professional growth is prime importance. Sharing knowledge is most important. Research is most important for updating, improvement, what has been lacuna in our working condition, what has been lacuna in our teaching modalities, and what our lacuna had been in our transferring the knowledge and skill to the community. Improvement in community dentistry is more important because each one will be beneficiary then and now. The professional growth is most important. With all these words, I thank you so much, Anmol and Dr. Ashish, for bringing brain sciences to this program.
Thank you so much for enlightening us, sir. We will definitely strive hard to stand by your words. Thank you so much. I now invite Dr. Anmol Bagadia, Organizing Chairperson, Founder and CEO of CynoDent, Founder President, Indian Society of Dentistry, to give a vote of thanks and brief us about the 4-day conference that we had. Thank you.
Good evening, everyone. Firstly, I'll start with a short insight that what we had in these 4 days and what we are having tomorrow and this evening. We started with 2 days of pre-conference course, which was on 26th and 27th, and I hope we have enhanced your knowledge and skills. And also, I hope you have enjoyed the learning experience with us. And these 2 days we had a scientific extravaganza in which we had scientific lectures, scientific presentations, and I hope you all have interacted with each other and you have made new friends, new colleagues, and many things like you have enjoyed exploring Gujarat, and I hope you had a great time in Gujarat. And today evening we are having a DJ night for everyone from 7:30 p.m. onwards till 9:30 p.m. and the facility of transport is also arranged for you. And it is not the end. Tomorrow we are having a Rabadam workshop by Dr. Anu Ashish and Dr. Akash Azad at Goenka Research Institute of Dental Sciences. I'll make it short because I know you had a lengthy day, and even yesterday you were here till late. I would start with thanking our patrons, respected Dr. Stephen Cohen sir, Dr. James Cutman sir, Dr. Dean Kapoor sir, and the founder of GRIDS,
Shri Apurva Goenka sir, Dr. Viral Patel sir, President DCI Gujarat. Our convener and chief of the conference, our dearest Dr. Kamal Babra sir. I would thank the organizing secretary of the conference, Dr. Ashish Chandra. I don't think because without Dr. Ashish and Dr. Viral, this conference would be possible. Would have been possible. And Dr. Nayan Patel sir for managing everything. Mr. Kushwardhan Singh Chauhan for being the backbone. Dr. Chaitanya for being there 24/7. I don't remember the names of students, but I remember 2 students who were there for me 24/7. I would add their names before my team members' name. Dr. Bhumika Solanki and Dr. Rajkumar. I would thank Dr. Abhishek Dubey, Dr. Prateek Bam, Dr. Aditi Nanda, Dr. Yash Sharma, Dr. Anuvashish, Dr. Sarita Bhandari, Dr. Lakshmi, Dr. Misbah, Noman, Anam, Sara, Misbah, everyone I thank everyone, and also the master of both the ceremonies, Dr. Aditi, Dr. Prateek, Dr. Aneri, Bhumika, and other interns who have done the anchoring and made this event a successful one. I can't take the names of the speakers because the list is too big, but I would extend my heartfelt gratitude to every speaker for giving their valuable time with us and sharing their knowledge with us. Because I think बूंद बूंद से सागर बनता है. That is the thing that थोड़ी थोड़ी knowledge सबसे मिली है तो at least we have enhanced something or we have something new to learn and something to take back home. And today evening we are having our DJ night. So I hope you will enjoy it, and we have kept it for you all. So I would request you all to be there. And I would also, last but not the least, I would thank all the dignitaries who have joined us today and given their valuable time with us. Thank you.
Thank you so much, Dr. Anmol. Dr. Chaitanya ma'am would share a few views. Chaitanya ma'am. Round of applause, everybody.
Good evening, everybody. Before you all doze off, so I'd like to mention that I'm someone very junior staff, and all my seniors, Dr. Charogral ma'am, Dr. Sonal ma'am, Dr. Pankaj sir, Dr. Nayan Patel sir, they all are sitting here, and our respected Dr. Kamal Bagra sir had to leave because he wasn't feeling well. So I'll just say one thing that I have felt myself, because I have been doing all the backstage work and all the documenting thing, and I'm not very used to sitting on such a respectable table sharing such a stage. So I like to say that our field is all about hand-eye and brain coordination, and confidence is something that we're not born with, but eventually we all learn to be confident, work on yourself, consistently do what is needed every day. And yeah, she's not registered, but she's the most punctual one. Yeah, so dedicatedly doing everything, even ये पानी की bottle वहाँ पे रख के आओ, तो if you bring that table, if you are doing that, someone there is noticing it, and it will give you reward one day. So I wish all that luck to you, because if I can, all of you can too. Because I am not someone very old to share this dais with so respectable people, but I am here and I am very confident that one day you all will. So wishing you all the luck, wishing Dr. Anmol Bagaria and Dr. Ashish Chandra to have such happy conferences every year, and we wish to be part of that conference as speakers, as delegates, as participants. So thank you everyone for your esteemed presence. It was a great learning. Looking forward to DJ. Thank you.
So the most awaited moment of this conference, I would be now announcing the names of the winners for the papers and the posters that we had. Dr. D.N. Kapoor sir wants to leave because of his prior commitments. Thank you so much for gracing the occasion, sir. It was indeed a pleasure and a proud privilege to have you with us. Huge round of applause, everybody. Thank you so much, sir. A standing ovation for Dr. D.N. Kapoor sir. Huge round of applause, everybody. Archana Godar. Archana. I would request Dr. Anmol and Dr. Ashish to kindly join. Second prize for the poster in UG category goes to Dr. Pankti Mangrolia and Dr. Z. Bhotsara. Dr. Z. First prize in PG category goes to Dr. Uruj Desai. Dr. Uruj Desai. Second prize is shared by Dr. Mahima Jain, Dr. Kriti Yagnik and Dr. Hani Patel. Dr. Mahima Jain, Dr. Kriti Yagnik and Dr. Hani Patel. Third prize goes to Priyanshi Parekh, Sarikani Ramlakhan Bonwal. I hope I pronounced it right. Sarikarani Ramlakhan Bonwal, Priyanshi Parekh. The first prize in slot 3 goes to Dr. Yesha. Dr. Yesha. Second prize is shared by Dr. Nidhi Shah, Dr. Dhruvin Shah, Dr. Nidhi Shah, Dr. Dhruvin Shah, and Zorayas. Zorayas. The third prize goes to Vasvi Sheta and Sakshi Shah. Vasvi Sheta and Sakshi Shah. Coming to the paper presentations, the first prize goes to Akanksha Gandhi and Nisha Arandal. I hope I pronounced it right. I apologize. Akanksha Gandhi and Nisha Arandal. Arasnal. These are the offline paper and poster presentations that were conducted on 26th and 27th. The second prize goes to Yashashwini Nayak, Pooja Shah, Nikita Shrikamat and Swati Reddy. Nikita Shrikamat, Swati Reddy. Pooja Shah and Yashashwini Nayak. I request all the delegates to be kindly be ready. The third prize goes to Saurabh Gupta, Rahul Pandhare and Abhiya Anna Koshi. Saurabh Gupta, Rahul Pandhare and Abhiya Anna Koshi. Third prize. The runner-up for this slot is Dr. Riddhi. Dr. Riddhi. Slot 2, first prize goes to Dr. Anuradha Rajput. Dr. Anuradha Rajput. Second prize is shared by Dr. Dhwani Desai. Second prize is shared by Dr. Dhwani Desai, Dr. Kartik Dhiroj, Dr. Shreya Shah. Kartik Dhiroj, Dhwani Desai and Shreya Shah. Third prize goes to Dr. Megha Yadav. Dr. Megha Yadav. Slot 3, the first prize is shared by Dr. Milind Chakrale and Dr. Soumya Johari. Dr. Milind Chakrale and Dr. Soumya Johari. Slot 4, the first prize goes to Dr. Ayush. Dr. Ayush. Second prize is shared by Tatwa Shah, Vishwa Ruparelia and Neha Masirani and Janvi Shah. Tatwa Shah and Vishwa Ruparelia and Neha Masirani and Janvi Shah. Huge round of applause, everybody. So with this, we come to an end to the poster and paper presentation winners. These were the offline presentations. The online winners will be declared in the group. So this conference would not have been a success without the constant efforts of the teachers and the students of Goenka Institute and Team CynoDent. So we would like to felicitate all the volunteers who have put their constant efforts. So, Dr. Prachi, all the volunteers kindly join on stage. Dr. Prachi,
Dr. Hiral Sona Sanya,
Dr. Meet Nayak, kindly be ready.
Dr. Rajvi Makwana,
Dr. Priya, all the volunteers of Goenka Institute.
Dr. Archana,
Dr. Archana, Dr. Jigar,
Dr. Himakshi,
Dr. Aditya, Dr. Riddhi, Dr. Shruti, Dr. Dimple, Dr. Niyati, Dr. Mirul,
Dr. Ridham, Riya Gundani, Dr. Ritu,
Dr. Jagruti, and Dr. Chirag. Huge round of applause for the interns of Goenka Institute of Dental Research.
Yes, please. Ma'am.
Dr. Bhumika and Dr. Rajkumar. They have been a constant support all together, along with Dr. Harsh. Dr. Harsh. Dr. Nishtha and Dr. Riya Vyas. Dr. Nishtha and Dr. Riya Vyas. From final year, we have Netik. Netik. Third year, Megha, Royston, Pranav. Megha, Royston, Pranav. First year, we have Yash Chauhan and Harshal. Yash Chauhan and Harshal. A huge round of applause for Bhumika and Rajkumar.
Close कर रहा है.
A huge round of applause for Goenka Institute. So we would also like to felicitate all the staff of Goenka Institute. I would like to invite Dr. Kamal Bagra sir, who is not with us, Dr. Mihir Pandya sir, Dr. Nimesh Patel sir, Dr. Charu Agrawal ma'am, Dr. Sonam Chhajer ma'am, Dr. Chaitali Parekh ma'am, Dr. Nayan Patel sir, Dr. Uday Patel sir, Dr. Akash Azad sir.
Dr. Pankaj Patel. Dr. Anil Patel, ma'am.
We apologize if we have missed out any names.
Dr. Omkar sir.
Please, everyone.
Thank you so much, everybody.
हमारे कॉल ऑप्शन से कौन टॉप करोगे?
We would request
Now, I would like to invite Dr. Abhishek Dubey, sir. Dr. A. Sharma. Dr. A. Sharma, sir. Dr. Anu Vasis, ma'am. Dr. Sarita, ma'am. Dr. Rashmi Pandey, ma'am. Dr. Pratik, sir. Dr. Ketu Shah, sir. Dr. Ritika, ma'am. Dr. Anam. Whole CynoDent team is invited here. Dr. Mishra, ma'am.
Yes, please, everyone.
Ex-student Goenka Institute, Dr. Vaibhav. We would also request our camera persons to kindly join us on stage. Thank you for both of you.
Sir, please. Thank you so much for capturing all the beautiful moments of our conference. Thank you so much, sir. Ganesh bhai, for the wonderful food that we had 4 days. Huge round of applause, everybody. Bhavik bhaiya, I would request Bhavik bhaiya, Mahendra bhaiya, please join us on stage. Thank you for taking care of this wonderful medicine that we have. Yay. Thank you, Bhavik bhaiya, Mahendra bhaiya. Dr. Vinayak sir. I hope we have not missed out anybody. I apologize if we have missed out anybody. A huge round of applause for Mr. Rajesh Bagadia and Mrs. Musha Bagadia, parents of Dr. Anmol Bagadia. We want to felicitate them, Mr. Rajesh Bagadia and Mrs. Musha Bagadia. Main organizing team. They have been a huge support for this conference. Thank you so much, Mihir sir, Chaitanya ma'am. Dr. Aditi. Dr. Aditi. So with this, we come to an end to our conference and the valedictory function. I, on behalf of the entire team of Team CynoDent, thank all the teachers, staff, delegates, students, and the volunteers for putting up this wonderful, wonderful show. All the speakers and all the members of Goenka Research Institute. Thank you so much. We hope to see you in February at Kalinga Institute. Thank you so much. Happy New Year, everybody. Dr. Anmol would share some views.
It is not just the end, it is a new beginning, because we know from every end there is a new beginning. So let's meet in February at Kalinga Research Institute of Dental Sciences, and as I said in the inauguration of the conference, that for first 300 delegates we have free Puri trip, free beach trip, free trip to Konark Temple, and also the 5-star stay facility at just ₹500 per delegate. So register soon, and we'll be soon releasing it on our website and all our social media handles, and also we'll send a mail to all delegates. And if there is any query, you can always contact Team CynoDent. And I always say that we are not a team, we are a family. So I know we have made many new, many new delegates have already, they have told us that we want to be the part of CynoDent. So I would also invite everyone to be a part of our family. Thank you, everyone. Thank you, everyone, for joining us. I would request all the staff members and all the members of Team CynoDent to proceed for tea. And thank you, audience, for being with us.